Доброе утро. Доброе утро.
Good morning, country. Good morning, dear delegates, dear colleagues, dear participants, and good morning, my wonderful, fantastic colleagues. Today, we start day 2 of the Congress, and definitely we start from the international course on endoscopic surgery. So here, I am welcoming 4 gentlemen, 4 supermen, great, fantastic. Armando Romeo, today he would be doing fantastic course on the suturing. Then, whatever you see, so he's a guru, he's a master, he's a maestro of suturing, and I promise to come to his center. Then Professor Rigotti, who's at the same time in France and in China, and he's very close to us as well, and he would be doing the live surgery today. Then Professor Jacques Amou, our great, fantastic, honorable Monsieur of Legion of France, and he's our great friend for about 30 years, and we are together. And also Professor Philip Kornix, and we start our course today. We start day 2. To avoid wasting time, because our time is golden today, I'm happy to give the floor to Armando Romeo. Armando, dear, microphone is yours. You're welcome. Armando, welcome. Microphone is yours.
Dear Leila, thank you very much. Thank you. Good morning, everybody. And please, I'm sorry for yesterday, but I had a very big trouble, probably for stormy weather on the hospital, and the connection was very, very bad. Today, I hope I will repair everything and I will do my presentation for you. Thank you for this invitation. It's a pleasure to share with you and with other colleagues. I start today a very interesting presentation about the suturing and safe, unsafe, and dangerous note in surgery. And I will talk about suturing from A to Z. First of all, it's important that now we delete the old classification of the notes. Before people talk about, and surgeons talk about double, single, single. But this is not enough, and we did a new evaluation with Dyna test. We did a new classification of notes, and we introduced the symmetric and the asymmetric concept, minimum safe blocking sequences, because as my magister friends Philip Koenig says, if we do 10 knots, every knot is safe. But our target of our study, our science of knot time, was to introduce the minimum possibility of choice and discover how we can replace the big size with a very small size of suture. In other words, if we do with 0, we do 10 knots, it's clear that everything is fine. But from a clinical point of view, we will do a mistake, because inside the material make reaction and a lot of adhesions. And our target of our study was to study very well how to reduce the minimum safe blocking sequence. No, normally people say this knot is safe, but this phrase is true for definition. Is it possible verifying empirically? And this was the very big problem in my mind, in our mind, and we put this important declaration of Immanuel Kant, other big philosophy. He's told us only declaration empirically with number proved can give us the true knowledge. And we put together a lot of good gentlemen and good scientists, and we perform 2,000 combination knots. And we saw with our big surprise, a very strange things, very big surprise, and I want to tell you more. Then we saw another paper, we saw a big trouble when we perform knot tying in laparoscopy. A lot of people make a reorganization. This is a very big trouble because all uncross the first knots and the knots come down no square, but completely grainy. And how we did the study? The study, we introducing the new revolution, in my personal opinion, during course, the Dyna test. During the Dyna test, we perform around this orange tube of diameter 1.5 centimeters. We perform knots, and then we put on the Dyna test, and the Dyna test will try to open it. And we saw a very big problem. For example, this double single open without any force, without any opposition. These knots, H3, H2, it means triple double, make resistance. You will see here 73 Newton, and this one more strongest. And we have 79. It means 8 kilo. And this is a good news. It means that we can perform safe knots, but it's important that we perform good combination and no reorganization during laparoscopy. Submitted to the strength of Dyna test, one combination can make the following rule: open completely, dangerous knots, open completely at less of 10 Newton, 1 kilos, more or less. And this is our limit, it's our below limit. Sliding and then blocking, very bad, very bad. And our target during our test was blocking, the knots has to be blocking without any sliding and break the thread. This is the true knot. This is the true knot. You don't need to be scientist, mathematical, or engineer to understand that one knot combination which resists and break the thread around 70 Newton, for example, 2 of Vicryl, without opening is strong than another that open to 0. And this is our target. It's clear that when we perform knots, if we perform 10 knots or 9 knots, it's clear that we will be a safe knots. But our target was the opposite. Less knots to avoid adhesions. This is the clinical point of view that we study. We want to perform not 10 knots with 0 sides, but we want to perform the same knots safe with 2-0 or 3-0 with less material inside of the abdominal wall. In other words, we study the minimum blocking safe sequences. And we saw that it's possible to have a good knots with a very few passage. I want to introduce these two gentlemen that are the DNA of all sequences. Above we have half note, and we call H in our study. And then we have half each, we call S. They are very different notes together, very different, and different behavior. We could have all knots made by half knots, all sequences made by half each, but we can have mix, a melange. We can have knots prepare a very strong base like H, and then we follow with the safe sequences of half each. If you can see here, we are the main actor. The surgeon decided if performed demi-clé, half each, or half knot. If you pull one, in this case, the tail, and you pull the tail, you decided to perform half each. If you put together in opposite side and uncross, you perform half knot. This is the big difference between these two combinations. It's important to understand that when you want to block one sequences, to have to change how we will see, change the passive role of the thread and the active role. And this is a very important topic when we will talk about half each. If we perform in horizontal line, horizontal way, we can perform 1 throws H1, 2 throws H2, 3 throws H3. What is the difference between the first and the last? Friction. Friction, actrite, two surfaces together makes friction. Friction means force. It's clear that if you use H3 in a myomectomy, is more stronger than one H2. And you can perform an H3 in myometrium, you go to drink a coffee, you come back, and then also will be there and waiting for you. I want to say in other words, it's a very strong knot, but this is the first, it's alone. Now I want to introduce a very important concept we discovered during our test, our paper. Symmetric and asymmetric concept. What does it mean? When we go in the vertical way, after the first knot, we perform the second one. You see above, the two outcoming, the thread are in the same plane. It means symmetric question. The second knot is in the same exact plane of the first one, and nothing happened, is safe. The second one, H2, H1A, asymmetric, you see that during our performing rotation, we change, and the other is totally transversal, it's perpendicular position. It means that this probably will make a mandatory question for the first, and at the end, move the first one in a right way or unpredictable way. The same situation we repeated and we study the half each. They following the same question. I want to tell you that is very important. We saw the first one, the symmetric combination slide. Both sequences are slides, but the first one, the symmetric, you see that the thread go out together is more stronger than the asymmetric one. In other words, we saw that during the composition of the sequences of half each, we suggest to do, no, we suggest, the numbers suggest to perform a sliding symmetric that a lot of time I hear from Francais, from Surgeon, from Arnaud Vatiez, you call this toupet. This is the famous toupet that during a period of demi-clé, they studied in Clermont. And we saw that the symmetric way is more stronger than the other one. In other words, this composition, these two sliding SS is more stronger than asymmetric way. Who is the guilty? The guilty of this situation is the rotation of your hand. You can go clockwise or counterclockwise. And this is a big influence in anatomy, in laparoscopy, big influence. When you perform, you will see here the first two green half each are symmetric and they are strong, but they are sliding. If you want to stop these sequences, you have to perform, in this case is the brown one, you have to change and to perform and change the active and passive thread, and you perform the blocking one. This is a very, very important. Don't continue to do green, 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 green. It's important to understand. If we make a comparison with a small video, you see here in laparotomy, you perform one rotation with your left hand, and you perform the opposite rotation of the hand, you see here, and the thread come out together in symmetric way. Typical symmetric. We make symmetric knots if we alternate the rotation. First one. Second, if you perform same movement or same rotation, you will have exactly the asymmetric. And what change? The friction, the attrite. You see here a very strange situation. The second one would like to go in other situation, in other direction, and this is typical asymmetric. We see here a typical two sliding and one blocking, and then SSSB or 4 or 5. Clear that I suggest with monofilament to block with 4 or 5 throws. This is the number, the perfect number, 4 or 5. In other words, at the end, conclusion, you have to perform in a horizontal way H2, and then in vertical way, another H2 is a very good base. H2, double, is a very strong base, a great fundamenta to build up our knots. Then you put on this a very safe 2 demi-clé to half each SSB, S normal, SB blocking, and you have a very great sequences. H2, asymmetric or symmetric is the same, and then demi-clé, SSB. You can go H2, H1 if you don't need a lot of strength, and perform even in this case SB, SSB. At the last, in other words, if you perform a very 2 steps, for example, H3, H2, that we will call homage to Philip Koenig's knots, you perform a very strong knots, only 2 passage, H3, H2, A or S is the same. In case of demi-clé or half each, is important to understand to avoid the reorganization. And in the first passage, to do SS is one thing, but S2 is the bad knots. In this case, you have to perform over these bad knots S2 to perform 3 blocking SB. Here you will see some
sequences,
different blocking sequence, and I want to suggest exactly the difference between mono-manual and bimanual technique. You will see the first H2, H1S, SSB. Look at here. And in this video is very clear exactly the difference. We start mono-manual, just one end. We perform from sovrapubic way.
The needle holder
is monocryl.
from both the horizon
Look,
of the thread.
this is the problem. Here you have to uncross
Technique
with mono-manual.
clockwise rotation.
You uncross the threads and you obtain
Flat knot.
square knot, flat knot. And this is good to tie the tissue.
Thread.
Otherwise, the problem.
Half knot.
Then you change rotation, and it means alternate rotation. You perform symmetric way,
Rotating the
and you
needle
perform
in counterclockwise
H1S.
direction. Symmetric traction is also applied.
To stop this good base, you need
There is no
half each.
traction across the threads.
We perform the first half hitch with the tail traction, and we go with the matrix with the needle.
First one using
But one is not enough. One is not enough. You have to lock this combination and change the role. Now the matrix with the needle became passive, active, and the tail became passive. We perform the same with bimanual technique. We use two hands. Look, it's very easy. You start in front of the tail, you take the tail, and you don't need uncross.
Coming from above the horizon of the thread.
Directly. In my personal opinion, I think that the future, during the course, the guys, the beginners start with the bimanual technique, but it means that you need to train your left hand. As we discover the bimanual technique, they make less mistake of combination because they move only the hand and avoid the reorganization of the knots. Because the big problem in laparoscopy is to pull both or pull the tail and you make reorganization. Look, if you make alternation of the hand, this is a typical bimanual technique. Another story is the complete half hitch sequences. Look at here.
In this blocking sequence,
you perform the first half hitch, but no force. You need to pay. You need another one. In this case, we did a mistake because it's asymmetric. You will see perfectly the asymmetric second one. Okay, it's sliding, but it's asymmetric. You see here, it's totally asymmetric. And this is very weak. Very weak. But in order to block this sequence, this sliding, you need absolutely to stop these sequences. And you go and you change the passive. In this case, it's the tail. You make a half knot and then you put in traction the matrix and go down with the tail. We call this blocking, but one is not enough because it's at the bond, it's very sliding, and you perform another one. Blocking is the opposite of the previous one, and then the last. In other words, we performed the SS sliding, we tie the tissue, and then SB, 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 three blocking. Look, and you performed blocking if you change the traction.
Safety sequence. In this blocking sequence, first the surgeon is performing a double throw half knot using the right.
Here you perform one
from above the horizon.
You uncross,
In a clockwise rotation.
but you perform asymmetric, and H1, H2, H1 asymmetric is dangerous.
In the second half knot, the needle holder comes again from
And to perform blocking one, you perform three blocking demi-clés or half hitch. Demi-clé is français.
regarding the first and the second knot.
You put in traction the tail.
The symmetric knot.
In this case, quickly the matrix one and go down with the tail.
The surgeon may place a blocking sequence of half.
Then you perform another one because it's monofilament.
The active thread.
You make inverted thread. Now is tail traction and go down with the matrix. And then another one. Again, tail traction. Now matrix traction and go down with the tail. That's it. And you perform H2, H1A. He felt go down together is dangerous, and he provided support, performed the three blocking. At the conclusion, to perform all these sequences, you need a good technique. I don't want to tell you that the gladiator rule is the best, but it's more easy. It's the easiest. I saw during my course that is very repeatable technique, very easy and repeatable technique. Why we call the gladiator rule? Because before we prepare the home base and the thread of horizon, and we call this the gladiator because we work with the jaws opening like this, and it's similar, the movement of gladiator is similar to the movement of the Roman emperor that performed during gladiator arena in the Colosseum, and he said, kill the gladiator, save the gladiator. The jaws of our dominant needle holder perform exactly the movement of the Roman emperor. Kill the gladiator, save the gladiator. Look at here, the last three slide. We saw the home base to avoid to stick, to put in tension the system and use all length. We perform the horizon to understand the sequences clockwise or counterclockwise, and you will see here the exercise. We start, for example, with very easy exercise. Last two slides to understand what does it mean gladiator. You call all the thread until the tail is correct length. We put all the thread to the right, in this case, is monomanual technique. And you can see this horizon is very important because it's your reference, your landmarks for the sequences. For example, I start, kill the gladiator, I catch the thread, I catch the thread. The secret of this technique is to stay together. Don't go here in St. Petersburg and this one is in Moscow. You have to stay in 2 centimeters square. Look, kill the gladiator, save the gladiator, and the left hand finish. Kill the gladiator again, save the gladiator, and the left hand finish. And then don't touch the right and disassembly the mount with left. Why? Because you start to wake up your sleeping hand, the left hand, because never you use your left, who is right dominant. Then we can go clockwise or counterclockwise. This is counterclockwise. We start to save and we finish to kill the gladiator. Look, we go here and with finger, we kill the gladiator from here. Look, very easy way. Put this one inside. Boom. You, only the wrist. We avoid the chocolate. Is just a movement of the wrist. It's very easy. And then the left finish. It's clear that is a combination of right and left hand. At the final, you see here, we put together two movements like a pedal, foot pedal of a bicycle. Right, right, right. Save the gladiator, move your left, kill the gladiator again, move your left, kill the gladiator again. And then we take the tail. We go to take the tail. We put the ring inside the tail. It's like to take off the gloves. We uncross the threads to have flat knots, absolutely, square. This is very important. A lot of people, Philip can confirm, a lot of people during life surgery don't do this, and they perform a very strange knots called S2. This is correct, H2 flat knots. Last slide, and I finish. Now, the big problem will be, don't move these knots, because a lot of people pull in traction the tail and move and make reorganization disaster. And you will have a reorganization of these knots and became sliding. And this is a very big problem. The big problem will be go down without pulling the tail. Go down, elegant, always close, and go on and block the sequence. No sliding, block. Many people pull and make reorganization. We talk about this phenomena and this scenario, and during my course, I saw the beginners, the resident, the fellow, to perform a very disaster. We did a paper when we share 10 residents and 10 residents after this lesson, and a group performed monomanual technique, another group bimanual technique. Results. The monomanual technique was my fast, of course, but the 70% of the knots was a mistake, opening to 0. The bimanual, the 7% was nice, but clear with the involved the left hand is particular. You have to train. In other words, the future is made by the bimanual technique, and our course, I perform always the bimanual technique with the people. It's a very, very important to train the left, and this will be nice even for dissection in laparoscopy. The coordination with right and left, bimanual coordination in laparoscopy is fundamental and suture as well. This is our center where when I will be in 2 hours, and thank you very much for the attention, and I hope this was fast, and I hope this was clear, the message. Thank you, Leila. Thank you, everybody.
Dear Armando Romeo, dear friend, it's a pleasure to wake up so early just for you, and you made a heroic deed. You told me, Leila, forever we'll be together. So I'm so happy. 35 minutes of enjoyment, following your fantastic technique, to see your smile, your emotions, your energy. And once again, you demonstrated the highest possible skills. And this is the best of the best technique of making the knots. Romeo, gladiator rules. So the God gave us 2 hands, so we have to work to make it nice, fantastic, and elegant. And this is exactly what you showed. So today, in our agenda, we have the broadcast of live surgery from Mario Malzoni. But we still have some more minutes, and after all, after the broadcast from Mario's OR, we will enjoy the presentation 40 years of hysteroscopy made by Professor Jacques Amour, but that would be a lecture, then there would be a lecture of Professor Betucchi, and then Giuseppe with the broadcast of live surgery in each of them. And I would like to ask you, dear colleagues, before we start the lecture part, I would like to ask all of you to say a few words, each of you, a few words, welcoming words. Jacques, before you make your presentation, could you please tell us what are you going to speak about in your presentation? Give us the short notice, hysteroscopy, that's our course. Please, mic is yours, briefly. Announcement, brief announcement, the most juiciest things about hysteroscopy. Tell us sexy story, maybe some interesting facts, ideas, hypotheses that could be extremely attractive for all our participants. So before your lecture, short announcement, big hook for the audience, key point for hysteroscopy, please.
Jacques?
Yes, good morning. Can you hear me now? Hello, Leila. It's a pleasure to see you. The first image of Moscow, but by internet. I'm sure next time we shall be together physically. This is a pity, but let me tell you, I'm so happy to be among you. It's not the best way, but it will become. Okay, so my presentation today is going to be the different steps in 40 years of activity in hysteroscopy and what was the progress and here. Okay. Do you have the image, Leila? Do you have my presentation? Can you hear me?
Нет, у нас не...
No, we don't have your slides.
Okay.
Мы не
I
видим
cannot see you. It's all right. Let me do my
ничего.
presentation.
Слушай,
No. It's not yet the time of presentation. I want to say that presentation itself will start later according to the agenda. It would be at 10 o'clock of Moscow time. Now we are awaiting Mario when he switches on live surgery from his clinic, from Avellino. But we have few minutes, and I wanted you to give a hook to our audience, something announcement. Professor Amu, please tell me, how long have you been preparing to become the hero #1 in surgery and hysteroscopy? Few words. Before Mario's live broadcast and before your presentation, tell us what is the most important in hysteroscopy. Open as a secret, no slides, just speech. A little bit.
So, hysteroscopy was a long process. As my studies were rather oriented to mathematics and physics, and I couldn't understand when I became a gynecologist, I couldn't understand. We have the uterine cavity, which is 90% of the pathology of the uterus, and we cannot see it. And that was tremendously frustrating. And that's how there was a process of using technology and optics to reach this aim. But the way was somehow long. It took. You'll see, we are only at the beginning because from 1980, when the old microhysteroscope was manufactured, until now, we still use only 10% to 20% of the capacity of this optic. And for the future, and in medical field, the future next step is not a question of 2 months or 3 months. It's a question of 2 years, 5 years, and the capacity of the scope, especially, and the surrounding of technology, especially HD cameras, will make that we shall do more and more progress in the coming decades. Very likely in 2 decades, we shall use the full capacity of the microhysteroscope. So that's what I want to show you at 10 o'clock when I'll do my presentation. And let me tell you, I'm so happy to be among you. I feel a little bit like if I was near to you physically, and I'm so sorry we have to speak only through immaterial techniques. But I'll see you in a short time. Okay? Did you hear me? Okay.
Absolutely. Fantastic.
да,
Thank you very much. Thank you very much. Now I would like to ask Armando. Armando, you made your fantastic presentation just 2 minutes ago. You have a few more minutes now to tell people most important things, most important conclusions from Professor Armando Romeo, how to work to avoid complications. Now it's your culmination. You have 5 minutes, how to work without complications. Mike is yours. And then I would ask Mario in his OR to start the broadcast. He's washing and he's waiting for you. You have about 5, 7, 8 minutes. And Armando gives us golden message of how to work, how to live without complication, complication-free. Armando Romeo experience. Mike is yours. You're welcome. Armando? Armando?
Can you hear me?
Yes, please. Please proceed.
I think, thank you very much for this question. And I think that is very important. The suturing technique is like a big barrier about to sharing a laparoscopy. We saw a very beautiful review in Cochrane. And I think that before to start, behind the suturing technique, Leila, is important to perform suturing for 3 reasons, very important reasons. First of all, bimanual coordination, mandatory for every surgeon that want to perform laparoscopy. Without 2 hands is impossible. Second one, when you perform suture and the gladiator rule, you perform a very, very fine movement, and this is very important for the dissection, because when you will go to dissect ureter, cava, artery, vein, you need to have a great traction and counter traction, as Arnaud Vattiès teach us. In other words, it's important, the suture is important to learn knots, of course, this is clear, and is important even for to develop bimanual capacity. In other words, I think that obviously the technical part is very important. Many times we perform in presence course, and I hope next time, as the legend of the hysteroscopy, my friend Jacques Camus told us, I hope that the next time we will be in Moscow as the past. And it's a pity to be here in Torino, but it's important to understand that the suturing for the future beginners and residents is very important. When you want to start laparoscopy, it's mandatory to start with the dry lab in suture, and then continue with animal lab, and then, of course, cadaver lab. And we perform suture in cadaver lab, and it's very important to perform reparation, restore of the anatomy. And my indication for the future is, please, start with dry lab, and then make in cadaver lab as well suture for the bladder, close 1 vessels. And this is very, very important to be very safe during your procedures. And you don't see, during myomectomy, you don't see the scalpel to transform laparoscopy in laparotomy. Please, it's important to have in your hand for safe procedures suture. Suture is determinant, is mandatory for this technique. It's a very, very important to have to avoid that you perform 1 good myomectomy and don't see the scalpel to transform laparoscopy in laparotomy.
Dear Armando, when I listen to you, it's like a song. That sounds really great, really great. Professor Koenigs, please show us. Professor Koenigs, Philips, you are on a big screen. Please smile. Philip, we have another 5 minutes until Mario is on the big screen wearing masks and gloves. He's already in the OR, but yet we are not connected. So he gave us 5 minutes. Please give us your golden rule and please tell a few words about yesterday, about our first day of the Congress. Philip, please.
I'm going to add a small little thing to Armando, what he probably did not mention because the paper is not yet accepted. But if you take gynecology, where a lot of knot tying is very deep in the pelvis, and if we see all the mistakes which are done during knot tying, just in destabilization of knots, my personal opinion, and also the one of Armando, because we have discussing this a lot, is that the future of gynecology are half hitches and not a flat knot. And there are two reasons for that. First, with half hitches, the risk of making mistake, certainly in depth of the pelvis, is much less than with the flat knots. And second, if you do the strength of the first combination, if you have, for instance, a myomectomy where there's a lot of traction on the threads, or you do an H3 with holds well, like Armando explained, but you have to decide beforehand. You cannot an H3 transform in an S3. That's a bad knot, whatever you do. If you go for half hitches and you do them correctly, the first two who are very strong. If it's not strong enough, you can have another asymmetric half hitch, the three ones. And this is very clearly, we are talking about newtons, and H3 has 18 newtons. If you have the right combination of three half hitches, three, but in asymmetric, you go up to 30 Newton. This holds the first knot very well. And then you block with the blocking. And we have been, Armando has nice data about this to say that you have to do this correctly with, at that moment, the blocking in the right rotation. So study understanding the knots, and understanding the mistakes, and understanding what, let's say, most surgeons. I am going to tell you a story. I'm not going to do it this time, but we had a meeting in Catania, and in Catania you had all the great surgeons who are performing, Arnaud and Kondo and Mario and so on. And I said afterwards, we're sitting together with Armando, I say, that's a wrong knot. This is destabilized. They are looking at all the knots which were made during 3 days of congresses, and we are not going to put names on it. But my estimation is that, or our estimation is that 20-30% of all the knots made were mistaken. So, and this is so easy when you go down, when you are in surgery, that you so easily destabilize the knot. So this, for this reason, personally, I think the future are series of half hitches. Armando, you agree?
Задать всем один вопрос, и Марио будет у нас.
Aha. Now I would like to ask final question to all of you. What is your attitude to the barbed sutures? Barbed. What is your attitude to the barbed sutures? What is your attitude to the barbed? I see Armando wants to speak up. Barbed sutures, please, your position. What do you think? It's easy to do, but is it really successful? Maybe there are challenges, so please tell us. 2 minutes for that, and with that we finish. Barbed sutures.
Thank you very much for this, Leila, because if there are young surgeons to listen, of course, this course and this Congress is important to tell the truth. What does it mean? Well, 10 years ago, one guy came to me and says, hey, guy, Professor Romeo, we finished the training courses in suture because this is the barber suture is fantastic, blah, blah, blah. I told him, I say, look, in 3 days or 2 days maximum, you perform a very great knot tying, half hitch, half knot, whatever you want. The big problem of the suture, Leila, is not the knot tying, is the stitch. And many people think, beginners, that with the barber suture overcome the problem. But they do a very bad load in the needle on the needle holder. They give a very soft, very surface stitch, no good, bad positioning of the needle, and don't come back because the barber suture don't come back, and they leave myoma, they leave the barber suture out, and they do adhesions, big problem. And in my personal opinion, the positioning of the barber suture is after you performed the normal suture. I want to say in other words, is a suture for professional people, for expert people, not for beginners. Clear, the company make a positioning to sell, of course, but I suggest to take care because the big problem is the stitch. The true problem in suture is loading the needle, loading the needle. This is big problem. This is my opinion. I want to say yes.
Дорогой Армандо, я 100%.
Dear Armanda, I totally agree with you, 100% agree with you. Because, you know, to simplify the surgery, it does not mean to improve it. It does not mean to improve it. But in a number of cases, we still use these barbed sutures. So instead of co-opting the tissues, what we do is overlapping and skewing, and that's the problem. We deviate the tissue order. And surgeons should understand, if he or she knows what is tissue cooptation, that's good, it works, it works. And another comment, if there is a time and if there is an opportunity in terms of adhesion prevention, it's better to put truly smooth stitches without barbs. Thank you very much. Thank you very much. And now I'm happy to give the floor to Mario Malzoni. I would like to ask you, please stay as long as you can together with me in this fantastic surgery. Dear Mario, the floor is yours. Please give us the operational room of Professor Malzoni. Good morning, dear colleagues. If you didn't listen to us from 8 a.m. in the morning, so we start our broadcast. And this is the live surgery broadcast of Professor Mario Malzoni from Avellino Clinic. And it's my honor and pleasure introduce him. So we have broadcasts almost every day. Dear Mario, no more wasted time. Please introduce your case. Please tell us a few words about your clinic, your team, and what are you supposed to do. Mario Malzoni, good morning. The floor is to the clinic.
Hi, Leila. Good morning. Good morning, everybody. Thanks again for this opportunity to share with you and all the Russian friends our experience. So we are ready from our operative room here in Italy, in Avellino, with Marianna, with Alessia, with Barbara, Gaetano, Olirio, and Oppido. She's the anesthesiologist. So I want to show you the case with just 2 slides. The patient, she's 53 years old. The BMI is 30, 29.3, and she had 2 previous C-section and a cancer family history of lung cancer, the ankle, and hepatocellular carcinoma in other ankle. No previous abdominal surgery, only the 2 cesarean section, and clinical evaluation and symptoms are only pelvic pain and the pressure at the level of the bladder. And she arrived in a few days ago in our cancer center here in Avellino. And we evaluate in our oncological cancer center with the preoperative workup with ultrasound, CT scan, mammography, and tumor markers. So the staging by ultrasound show us an left ovary occupied by a multilocular solid cyst with a color score number 3 and a size of 76 millimeter maximum size. No visible or normal ovarian tissue. And so with the moderate vascularization, and on the right side, the ovary is normal, and the uterus is with the normal size, a little bit attached anteriorly for adhesions between the bladder and the anterior wall of the uterus. So the CT scan with no suspicious at the level of lymph nodes, no bulky retroperitoneal lymph nodes at pelvic and para-aortic area. Mammography is negative, and CA 125 is 82, and 19.9 is 324. So the ultrasound suspicious, it's a borderline ovarian tumor or an stage 1 ovarian cancer. So the strategy of today is to perform a total laparoscopic type A hysterectomy with bilateral salpingo oophorectomy. Then we send to the pathologist with the frozen section the left ovary and tube, and we wait for histological examination. In case of borderline, we perform a staging of borderline with omentectomy, infracolic omentectomy. In case of ovarian cancer, we perform not only the omentectomy, but the staging at the level of the lymph nodes at the pelvic area, bilateral, and the para-aortic area by laparoscopy. Of course, we started with the cytologic examination, the so-called washing, and we send now the picture inside. So all oncological case starts from the examination of the abdominal and pelvic area. So this is the pelvic area. We put inside under vision the manipulator, and it's the STORZ manipulator, and then we go to show this level at the level of the diaphragm, at the level of the omentum, and to check some suspicious area. And everything we saw at the beginning seems to be okay. We put 3 5-millimeter trocar, and we can start now to move the left colon, the descendant colon. So the technique is to move the descendant colon from the left side, pelvic side wall, and to do it, we work with the scissor on the left, on my left hand, and by clamp on the right side. We are more fast with this technique, and the mobilization of the left colon, the descendant colon, sometime until the flexor, it's mandatory, it's very important. Sometimes you can work with monopolar too. In this case, we work with the so-called precise monopolar current connected to the left hand on the scissor. This kind of movement and to free completely the descendant colon is very important in order to increase the movement and free all the area here on the left of the left common iliac vessel. That is very important for the resection cranially of the IP ligament on the side of the suspicious tumor. So starting from the left, you see very, very important to perform this kind of dissection very cranially. This is a mandatory preparation. And you see that Mariana pull exactly the rectum and the sigmoid medially in order to increase our tension here at the level of the physiological adhesions on the left. Then with this movement, you see, I can arrive at the level here of the crossing between the left ureter and the common iliac vessel. So again, here you see opening of this area and pushing the bowel. We see very well the left ureter here. Okay, so now I want to show you the mass on the left side. So it's important now to perform at the same time the extrafascial hysterectomy with salpingo-oophorectomy bilateral. We can start from the left side because it's a little bit more difficult. And like all the oncological procedure, we start to cut the round ligament at the level of the pelvic side also. Very, very, very laterally. And so at the insertion of the round ligament on the left, and then we arrive in the very good plane here. It's a retroperitoneal plane laterally to the IP ligament. So you see with this picture, I hope that the picture is okay.
Yes, picture is perfect. Please proceed.
I go laterally to the IP ligament. You know that the technique to remove a suspicious mass and the technique to treat a borderline ovarian tumor is to remove completely at least 2 centimeters of IP ligament cranially and all the peritoneum of the ovarian fossa. So this is very important. And you see that I'm going up and I'm arriving at the level of the bifurcation between the left IP ligament and internal and common iliac vessel. So going up, here we are at the level of the bifurcation. And opening this space, we arrive in a very good plane, laterally and posteriorly and dorsally. So you see here some inside the fat tissue here, we arrive at the level of the ureter here. And we see very well. This preparation is important. And I want to show you how to prepare and to perform a correct salpingo-oophorectomy at the sides of a suspicious mass. So we open here and we can check now the direction here of the ureter. So opening at this level, here we can open the so-called window in the posterior. Here, this is the window. We are at the level of the crossing between the IP ligament and common iliac vessel and internal iliac vessel. So at this level, it's a good resection. And so we can complete our coagulation, and then we cut the IP ligament. I want to show you a little bit better with no smoke. So with the hot water, we are working, of course, with the 3D camera. It's everything is okay, the video, the audio, the picture.
Yeah, absolutely perfect, absolutely perfect. Dear Mario, that's fantastic picture. I'm here liking the performance, and all the regions of Russian Federation are applauding to you. They're saying, bravo, bravo, maestro. Please proceed.
Thank you, Leila. Okay, so now we cut the IP ligament. At this level, you see the IP ligament, and then pushing medially, I can understand the direction of the ureter. So the ureter go in this direction, you see, and so now it's important to go in this direction because I want to cut and prepare first, and then cut all the posterior part of the peritoneum in the ovarian fossa. That is a part of salpingo-oophorectomy for suspicious mass. So I stay here and prepare this level, the first part of the entry in the middle parietal space. And here the mass is totally attached to the peritoneum. So I want to remove all the mass, but with all the peritoneum here. So you see that Marianna pull now on the peritoneum. I push a little bit the mass medially, and I stay here in a direction, pushing the ureter laterally and going in this direction here. And so again, I go down and here. Okay. You see that the monopolar can help us very well when I need to push on the tissue, and with the traction of or contraction from the assistant, the use of monopolar can help us to go faster, very, very precise in the dissection. And so with this kind of monopolar current, very precise, no smoke, I think that we are coming back to the use of monopolar. So anteriorly, we go here and we are performing here the dissection anteriorly. Then we move on the right side. So you see that automatically Alessia push the uterus on the left, and Marianna pull the round ligament on the right side. Then we go to coagulate the lateral part of the round ligament, opening of the here retroperitoneal area, and then we move in this direction. The direction is absolutely parallel to the IP ligament. You see all the adhesions here between the right colon, the cecum, and the pelvic side wall. And so if I pull on the bowel here with good traction, I can use the monopolar to open the right plane. And then we arrived here to move again and to push up the cecum here. Okay, again, Marianna pull laterally. I go cranially to open the peritoneum parallel to IP ligament. And with the same technique, I have to resect the IP ligament very cranially because it's probably an oncological procedure. So the technique is a little bit different comparing to the classical technique for benign disease. So if I stay here, this is the level of our resection of the IP ligament. And before to resect it, I have to open here the peritoneum, the window, and then with the ureter down here, I can, in safe mode, do the cranial coagulation of the cranial part here of the IP ligament. And we are at the level of the crossing area with the common iliac vessel on the right side. Again, biclamp to do the coagulation. And then when I finish this kind of preparation, I will ask to Barbara to clean a little bit the biclamp so it will works a little bit better. And then we can move on the peritoneal here area. And this is, of course, the left ovary coming on the right side. Okay. Now we can move here, and before to remove the instruments from the side of Mariana, I check and I increase the coagulation here on the residual part of the IP ligament for control the small bleeding that sometimes can start from this side. Okay. So now on the both IP ligaments, the preparation is okay. Now, this is the position for the anterior work here. You see that this is the two cesarean section scar tissue anteriorly. And with this position, we go here. The preparation is starting from the left, so from the lateral part, left and right, then we arrive in the middle. Two cesarean section previous, so additions between the bladder and the anterior wall of the uterus, and all these fibrotic tissue that we try to remove and free anteriorly here. And
Спасибо за фантастический перевод.
the tissue are very strong, and this strong tissue, in my opinion, is for the not for the previous surgery, but for the pathology. So with my experience, I think that it will be at least a borderline or probably an invasive ovarian cancer on the left side. And so we will see with the pathologists, with the frozen section. And you see that now we are working on the scar tissue.
Говорите погромче, пожалуйста, говорите погромче. Мы записываем звук внутри студии тоже. Погромче.
Okay, now we arrive at the level of the anterior part of the left uterine vessel. Okay. And so in this, okay, we have to move first laterally and then in the middle. So pushing down this area, this is probably a right entry between the anterior part of the uterine vessel and the bladder. This is the right plane, you see. If I go there, I can understand better. But here, the bladder is totally fixed to the anterior wall of the uterus and to the anterior part of the cervix. So here is, we have to be very, very precise in our dissection. And we have to go in the right direction here. Okay, so now the tension between the two parts in this area is very important. I feel the tissue and here probably I can go better.
Вы чувствуете, что ткани инфильтрированы?
You feel that the tissues are infiltrated, right?
Not infiltrated for the disease. Here, I think it's the scar tissue of the previous cesarean section. No suspicious of involvement of the uterus. And so it's not infiltrated by the disease, this part. Okay, so fai un poco dietro. Huh? Is totally blocked here. You see? In this case, the only solution is to cut inside the scar tissue. Only if you cut inside the scar tissue, you can arrive in the good plane. If not, the risk is to go too inside the uterus and to go in the wrong plane. Okay, now I feel a little bit better the area, yes, between the bladder and the anterior wall of the cervix. Perfect. I feel better here. Here is a very good plane here. This is very difficult dissection. The risk is to go exactly or inside the bladder or inside the uterus, but you have to go exactly in the middle. So this is the plane. You see, I'm in the scar tissue. And so here we have the cervix and up we have the bladder. And now I can understand very well the plane, and the use of monopolar helped me to arrive in the correct plane. You see? So this dissection, the only solution for this dissection is the knowledge of anatomy and experience to arrive, to achieve the right plane. Other way, you go in the wrong plane, and then the risk is to cut the cervix or to go inside the bladder. Now, you see, the scar tissue is totally up. And so, going in this direction, we are arriving in a very good plane here to perform a correct hysterectomy at the good level of the cervix. Okay, so now the bladder is up and all the anterior walls. If I go now because until now, I don't need to go with the valve anteriorly in the anterior fornix of the vaginal fornix, but now Alessia can push the anterior valve inside, and we can show you in a few seconds. We use a little bit gel to go better with the valve inside, right? Okay. Right. Pedro. Yeah. So now Alexia go inside, you see, and oh, respirator. Okay. Okay, with the pressure we had the rupture of the cyst. It's not good, but it's only for the pressure, but togli un po' l'aspiratore qua. Cioè, togli un po' quella cosa qua. Ok. Pulisci bene, bene, veloce, veloce, veloce. Ok, so don't worry. Okay, no solution now. We have to only to remove completely everything. But okay, so now we go from here. Sorry. So okay, now I can go faster on the left. Dammi l'aspiratore ancora. Dammi l'aspiratore. Ok, lascia un attimo, Marianna, scusa. Okay, you see that we had the rupture of the ovarian mass only with the pressure at the level of the uterus. Okay. And now we can go a little bit faster to remove completely the ovary and to send all to the pathologist. You know that the opening of the mass during the surgery don't change the prognosis for the patients. Okay. And so now, okay, anteriorly, very well. And now we go here, but we have to do the suction again here. Ok, allontanati un attimo così vediamo. Alza un poco l'utero. Now we put the uterus up. So it's probably better to do now a different strategy. So the better strategy, in my opinion, now is to put the uterus like this, remove completely the left ovarian tube, put everything inside the bag, and then we perform un sacchetto aperto.
Sì, annesso di sinistra.
And then we perform the hysterectomy, the end of hysterectomy. So now we are cutting the tube, of course, and then we cut the uterovarian ligament. And then we have to remove the posterior part of the mass from the peritoneum. So this is the direction here. Okay. And here, okay, so this is the direction. Okay, and here, this is the uterovarian ligament. And then we free completely from the peritoneum. So here is a little bit fixed. And we have to work here. And then we need a bag. We put everything here on the left side in a bag. Okay, now lascialo lì. Now we do this. We go inside with the bag. We open the bag inside. We put the left ovarian tube inside, and then we remove through the vagina all the mass. Okay, so now we pull a little bit like this. And we leave for the moment we leave the left ovarian tube on the right side. Then we come back again with a good picture and we complete the washing of this area. And we can restart for the extrafacial hysterectomy here. So the anterior dissection is it's okay. I want to show you better on the anterior wall. Yes, like this. And now I want to show you on the left the ureter. So you see here, Marianna pull here on this tissue. This is the direction of the ureter here. And I can stay very, very medially here. Sto intendendo dire, vero? No, niente. No, nel senso che no, so che è un po' questo tessuto un po' così. Okay, now we are at the level of the left uterine vessel and we can cut it. And with the use of aspiration at the same time, we increase the coagulation laterally and medially here. So now Marianna pull on the uterus. And we clean a little bit our biclamp in order to be more okay. So this is it's not a radical hysterectomy, it's an extrafacial hysterectomy, and we stay here laterally to the fascia and go here to complete the resection at the level of the uterine vessel. So checking the bleeding, cutting the anterior small vein here, and then we can remove completely the paracervical area here. Then we move on the right side and we finish the hysterectomy. Okay, again, aspiration here to check better this plane. And then we move very, very gentle on the right side. Pushing on the right side, we go to open again here, anteriorly, and here. So you see that Marianna pull on my side the peritoneum, and we go in this direction here, opening again the peritoneum. We clean a little bit the scope because we have a very good vision with 3D, but we are sending you a picture in 2D, so we need sometimes to clean better the scope. And then I can see posteriorly a good plane here and here. And we are now at the level of the right side uterosacral ligaments at the is insertion on the retrocervical area. Okay, this is the posterior preparation and ready for to do the coagulation here on the right side of the vessel. Okay, clean a little bit. Sometimes on the vessel you can use the Robbie back clamp. Sometimes it's better, depends from the yes. In this case, probably it work a little bit better on the vessel. No, non serve, no, non serve. Of course, the distance from this part of the vessel and the ureter on the right side is a very good distance, so we can cut at this level for a correct extrafacial tape eye hysterectomy. And then we go in this direction to free the paracervical area. Non c'è bisogno, non c'è bisogno. Guarda così. And preparing posteriorly the okay, ready to cut the vagina. Just posteriorly, sometimes we need to do a small preparation here, just a little bit, but just to cut here. And just to reconnect the two preparation on both sides. You see that Mariana pull down here. I don't need to go too deep and too posteriorly on the rectovaginal septum, just a little bit to open here. And okay. In this position, I can cut a little bit better the origin of the both uterosacral ligaments. And you see that Mariana pulled down the rectum. This is the insection. I cut a little bit here and there. This is the posterior wall of the cervix. Okay. Pushing here and here. I'm just ready here to go in the right plane. Okay. Now we can remove the uterus and the right ovary and then the bag with the left ovary. And before, it's better to prepare again the bladder a little bit more. So laterally here, this is, you see, this is the preparation of the ventral parametria here. So pushing the bladder laterally, this is the opening of a good plane at the level of the ventral or anterior parametria. You see, this is the preparation. Here we have the little bit down here, the so-called Yabuki space. The fourth space of Yabuki is here. We don't need to open, but we need to do this dissection of the bladder because it was totally attached with this fibrotic tissue. And so it's better to remove better the adhesions here and then to move in this direction like on the right we do on the left. small vessel here, small vein, okay. And now probably we are okay because we can go here and we are at the good level of dissection anteriorly.
Mario.
Yeah.
Mario, could you tell me, please, at this stage, at this moment, why do you choose this particular place, for resection of the wall of the vagina? Not up, not down. What's the diagnosis and how do you choose the radicality of the procedure, whether it should be radical or not? If it were a borderline operation, you could do it a little bit up. Could you say a few words about the dissection zone?
Yes, perfect. Thanks for the question. The suspicious is the ovarian mass, not uterine. The uterine is totally normal. So we don't need to remove a part of the vagina. We need to do a classical extrafacial type A hysterectomy. So we are pushing now the anterior valve in the anterior fornix. You see that at this level, we finish the cervix. So we are cutting only very less than 1 centimeters of the vagina. We don't need to remove more. We don't need the resection of the vagina. So this kind of valve, the Arnovatier manipulator from Clermont-Ferrand, expone very well the anterior fornix and the lateral and posterior fornix. So we don't need to remove a part of the vagina because for oncological reason we don't need. And so this is
Всё
the
понятно.
level of the
Продолжайте.
normal.
Yes, everything is clear. Please continue the operation. Everything is clear. Continue the operation.
Okay, so with biclamp in the middle, with the monopolar hook on my left hand, I can start here and follow this plane here, opening the anterior until the valve, the porcelain valve here. Then you see that the movement from Alessia, she's a resident from a university in Italy that works in our center from many months, and she knows exactly what's the direction. The direction is from the middle for the central part to the left, under this part of the paracolpium on the left. Then we go down following the same plane, and then we go posteriorly on the left. Then we go at this level and we stop on the left and we go a little bit on the right side. So following the right plane here. Sorry for the smoke, because with this kind of monopolar, of course, you have a little bit more smoke. You see, this is the position of the manipulator, a little bit with the under the residual part of the uterosacral ligaments on the left. And then we move here. Okay. Now, you see that Alessia go on the right side like this, pushing in order to stay at the same level of the resection of the vagina, and then we go anteriorly to finish the colpotomy. Then she will remove very fast the uterus and the right ovary and the tube, and then we'll put the bag in the vagina and we'll send to the pathologist the ovary, and we wait. But I think that at least we will have a borderline ovarian tumor. So in case of borderline ovarian tumor, we need to do to add at this procedure only an infracolic omentectomy. that we perform with the same access, the same trocar position, and we change only my position and the position of Marianna, and I go to operate through the, okay. The uterus go outside, and then we will put the.
Mario, can you hear me? Armando.
Hi, Armando.
Hi, Mario.
Congratulations for your lecture.
Thank you very much.
Yes, I was connected during your lecture.
Thank you.
It's
Thank you.
really perfect as usual.
Yes.
And all the
Just I would
the gladiator
like.
technique.
Yes, I follow your procedures, and just I would like, if Leila permits, these comments to thank you and to do congratulations to your fantastic team, because you are.
Одну минуту.
Just a minute, Armando. Just a minute. At this point, when Mario was going to operate and do the suturing, I would like you to look at this, the suturing technique of the vagina. And here we will make our comments, because each surgery has its own key moments. I was very silent because that was a very good surgery, a very good operation. We do about 40 different operations per day at our center. In my department, about 20 procedures per day, 8 to 10 hysterectomies, all others are resections. But it's not the number of procedures. We also do organ sparing procedures. So why do we, during this international course, show our international experts who are operating, our stars, so that our colleagues from many countries, from Russia, could watch? And right now there are 3,000 people watching this Congress. 3,000 people, imagine that, Armando, are watching this procedure. And that's very important, because this is an international Congress. We're sharing international experience, not because us, but because we have Mario, Arnaud, you, Bitoki will be operating, and Bigatti will be operating today. So people should realize, as if they were abroad right now, watching these operations live. And why I stopped you when you were going to make a comment. Well, right now there will be a minor coagulation, hemostasis, and then we'll ask Mario to demonstrate the suturing technique on the vagina, because if the suture is not consistent, then after some time, a month later, after coitus, after an intercourse, there might be problems such as prolapse, inflammation. Armando, do you agree with me that the suturing technique, especially for women, is very important, especially those women who would like to have an intercourse in the future? For such patients, it's very important, right? So, dear colleagues, Mario Malzoni continues with his surgery. That was an elegant, brilliant surgery. Mario is very calm, and I have a feeling that I am with him right now, operating in the same OR. And dear Mario, we are waiting for the suturing technique with the explanation, and then Professor Armando will make his comment. We're ready. Mario, please, and then Professor Armando.
Thank you, Leila. Thank you, Armando. Of course, I can show you the technique of suture of the vagina, but before to show the technique, I have to wait for histological examination, because, of course, if I have to remove the omentum or the lymph nodes, I need the opening of the vagina to remove the omentum and the lymph nodes through the vagina. So for the moment, we have to wait for the vaginal suture. But just to explain my experience in the suture of the vagina changed in the last 25 years. We started with the running suture with the traditional intracorporeal nodes. Then we moved to single stitch, usually at least 4 or 5, starting from the angle and then in the middle with the extracorporeal nodes that we used for more than 15 years. with good results, with good rate of vaginal adhesions. Consider that we performed, I don't know, probably more than, I don't know, more than 10,000 hysterectomy in the last 20 years. But then we moved. At the beginning, we was not too convinced about the use of barbed shooter. We started with barbed shooter many years ago. Then we have two cases of complication with barbed shooter at the level of the angle of the vagina, and we went back to the old technique of single stitch. Then we restarted with the barbed shooter from the last 2 years, and now we are using the barbed shooter again with a very good results. So I close with the barbed shooter, with the running shooter using the Stratafix, with one needle
Марио,
from the right angle going to the left angle. So in this
дорогой Марио,
Dear Mario, so let's ask Armando to make a comment. Armando, please make a comment, Armando.
Look, I agree. I totally agree with Mario, and in my opinion, I saw a lot of time the sequences, the beautiful sequences of 5 throws at Fitch in extracorporeal, like Arnaud, like other fan of extracorporeal notes. And I think in the school, in my training school. For me, is important that the people understand that has to be able to perform intracorporeal and extracorporeal as well. And regarding barbed suture, I want to be clear. For me, is wonderful. I like a lot, and is a future, is an advance in technology. But this is important. Don't eliminate it. No eliminated the training courses, because it is important to teach, to continue to teach stitch loading of the needle, because now, Leila, we see Mario performed the stitch very easy way, with left hand, with right hand, but it's important that the people understand that is determinant to know loading the needle and to give correct stitch. Otherwise, it's a disaster even with barbed suture. My suggestion is, please, don't do easy, because barbed people think is easy and I perform. No, study, do training, load the needle, and go ahead.
So just a comment, Leila. I totally agree with my friend Armando. This is the right thing to do. So you need training. Absolutely, you need training. You have to know exactly the technique for intracorporeal nodes, extracorporeal nodes, and when we need it, sometimes, like in vagina, you can use the barbed shooter. It's good technique, the barbed, but the message of Armando is very important. Don't go in the direction of easy thing. Go in the direction of knowledge, and so you need more than in the past the course for shooter. Absolutely.
Dear colleagues, at 10 o'clock, we start the plenary session. Professor Jacquemont will be speaking first. We still have 8 minutes, and I would like to clarify. Well, it looks like we have one religion. We look at this surgery, and Mario, I have a feeling as if I am with you in the operating room, or maybe even instead of you. That's great. That's wonderful. Mario, could you tell me, please? And we have also a lot of experience. Well, I don't know, as far as endometriosis, during the last 15 or 20 years, we have 5,000 hysterectomies. Well, 8 operating rooms are at the Kulakov Center. Everyone knows how to do hysterectomy. There are also oncology departments. There are different specialists. The OBGYN center, the Kulakov Center, deals with obstetrics and gynecology. But we have the most severe patients. We also have a simulation course. We have a simulation center. Mario, in your view, what is the role of simulation course and the simulation center? Is it important? To what extent the role of simulation course is important? What is your opinion? Just 2 minutes to answer. I know that you have also a similar simulation course. Armando also has a similar simulation course. We have a wonderful simulation center, wonderful simulators. What's the role of the simulation course? How a surgeon should get this kind of training through this elegant opportunity to operate like it's a performance, but not just pains. Mario, what's your answer?
It's my opinion. It's mandatory to go in the direction of simulation courses, starting from courses of shooter, of course. Then you can move on the animal and then on the cadaver in order to simulate the operation. But the knowledge of the notes and the technique for notes and for the shooter is mandatory, in my opinion. So. It's the main part of our training. And sorry for waiting some more minutes, but we are waiting. The pathologists usually in less than 50 minutes arrive the diagnosis, but probably we have to stop the connection because I know that it's only 1 hour. So I don't know if we have time to reconnect after or not. I don't know. We continues to do the and perform. I think that we have to perform at least the omentectomy, and in case of ovarian cancer, we have to perform bilateral pelvic lymphadenectomy and then para-aortic lymphadenectomy until the level of the renal vein, that is the cranial level, for a correct para-aortic lymphadenectomy in stage 1 ovarian cancer. And a great greetings to Philip, to Armando, and to Jacques Camus. It's a really pleasure to see Jacques again. And so thanks, Leila. Thanks to you to organize this very wonderful meeting every year, 2 times per year. So will be a pleasure for all of us in Avellino to be part of our next meeting in the next January.
Dear colleagues, well, it's been the second day of our Congress, and we've shown you the second day of live surgery, and we've shown you our opportunities. As of today, we have 3,800 people registered who are constantly watching such events. That is why we would like to show you how we work, and we work actually every day at our center from Monday till Friday, and all Russian citizens have a chance to come to the Kulakov Center to sign up for a course at the Simulation Center and to see 8 surgeries. We have 8 ORs. Well, and it's great happiness to do such a surgery. Our Congress is free of charge for everyone who had registered before, and during this Congress, well, right now you can see Mario Marzoni, Armando Romeo, Philip Connings, Jacques Camus. You will have a chance to see live surgeries tomorrow. Arnaud yes, will be performing it. Today we are going to have live surgeries from Professor Bitocchi, Professor Bigatti, and Jacques Amu. So you will have a chance to see Professor Tozzi and all other our friends who are the stars in surgery. And of course, we do our best. Dear Mario, thank you very much. And I move to the plenary session of the Congress. Well, no, we do not say goodbye. we say see you soon. And well, of course, if there is a chance, we will reconnect to you again, and you will be able to show your picture on our monitor. Thank you very much, dear colleagues.
Да. Дорогие
Dear colleagues, we start the plenary session, and right now I would like to show you a short video because we must start at 10 o'clock sharp. Please, the short video of our international team will precede the plenary session.
Leader of the Corsa Commission, Adamian. These are the titles.
уважаемые
Distinguished colleagues, dear friends, it is 10 a.m. sharp Moscow time. We are on the 7th of June. It's day 2 of the 36th International Congress on New Technologies in Gynecology, and it is the 52nd International Congress to be held by and to be hosted by the Center of Gynecology and Obstetrics since 1991. The Center for OBG, named after academician Kulakov. Our center is indeed a head institution where I have the honor of working. I've been working there for exactly 51 years. Today, so dear, he's having fantastic meeting. Jacques, go ahead.
Yeah, hello, Leila, and good morning. And I'm sorry I couldn't participate too much with the presentation of Armando. since one of the progress of hysteroscopy is that we don't need any suture. You have noticed that, so I couldn't comment the problem of Armando. So let me start my presentation. It takes just to put the beginning here. I have it. Do you have the image now? Yes, I suppose. Okay, so I want to show you what we did for developing and try to make state of the art for 40 years in hysteroscopy. So hysteroscopy, it was a lifetime patient, as I told you, and because of the rationale of my formation, I found that it was useful to use innovation and advanced technology, which are the base of scientific and medical progress. So the state of the art actually can be, let's see, be resumed in 5 major steps. It is taken from our experience, my colleague experience in hysteroscopy. I cannot cite them because they were so many, and they all contribute to the progress of hysteroscopy. So let's see the step 1. The step 1 started in 1980, and it was the most difficult step because it was the step which requires conception and calculation of a new optical system adapted to the physiology of the uterus and to the axis of the uterus. So this step was extremely, took about 6 months to calculate a new system, new optical system, which in final was like a microscope and a telescope. And it has tremendous capacity, which are not completely used for the time being. For time being, we use maybe 10 to 20% of the capacity of the old microhysteroscope you see here, the original microhysteroscope. So once we've conceived it and stores have built it, we did put the international patent, therefore mainly in France and USA. And this was to protect this new system, which will be useful maybe in the coming decades, because you're going to see it has a lot of capacity for the future, which are not yet used in gynecology. So in this first step, not only we have to do the calculation and do the miniaturization, we had to do a prototype. And this was the prototype to check that the calculation were right and that we can magnify from 1 to 150 to see from infinite to contact and to have a very high definition of 2 microns. Down here, you can see the original model that Storrs has he has done a miniature of the prototype. And this original system was necessary. It was cumbersome, somehow cumbersome, because we didn't have yet at that time HD cameras. With the HD camera, we could simplify the microhysteroscope and give it exactly the same shape as the traditional hysteroscope. So the next step was with this capacity of vision from infinite to contact and different magnification. You see that the problem was to build such an optic was to cross this cervical canal, which is very hostile canal. It has a lot of fibrous structures beneath the glands. And you see that if you don't see what you do when you're crossing the endocervical canal, you will never do a good hysteroscopy. So also when you have obstacle in the isthmus, like here, you see that if you don't see where it is, you will never get into the cavity. So with this intermediate magnification of 20, like a colposcopy, will be able to analyze the endocervical, and this one is a perovulatory aspect with active glands, and this is a very atrophic endocervical canal, which shows the fibrous structure arboretale of the cervical canal. So the next was using this 20 magnification. You see that the vision was best vision, and especially you can use like a colposcope that studies the semiology of the endometrium. You see the glands just by depressing the endometrium. You see the edema, which shows that it is a perovulatory, and also the thickness of the endometrium. You see, it's not a conventional hysteroscopy. It is therefore a progress in this. Then at this first step, we have to make a lot of progress inside the first step. First of all, we have the original optic, then we get thinner and thinner. Originally it was 4 millimeters, then we did 3 millimeters and 1 millimeter here, and also we adapted, like in urology, operative instrument, side instrument here. Well, also we need security, and security was done by developing the micro-hysteroflator, which is very safe, and there's no possible accident or embolism, because when you're using CO2, there's, in case of infraction, you can have an embolism, gas embolism. And with this system of insufflation, there was no possibility of accident or embolism. We shall see why. But one of the main progress at this first step is a few years ago, after we could have disposed of a HD camera, which was very helpful and replaces the microhysteroscope for the low magnification of about 10, because video is increasing. You can increase the definition by 10. Then, but still, since the optic goes up to 150 magnification, the high magnification will be either partially used now or rarely used, but it is the future. You're going to see how. So this is the microhysteroflator. You see, it is an electronic control of flow and pressure with a feedback. That means in case you have an obstacle, the pressure will go up, but since it is an obstacle, electronically, the flow will go down. So there's no risk of intravasation, but when the pressure becomes dangerous, the flow is so low or zero that there's no possible it is the step 2. It's not possible to have embolism. So no intravasation is possible, as you see, and also by having this feedback, we don't have pain when you performing diagnostic hysteroscopy. I'm sorry. No. Here. Oh. Here, you see, by controlling the flow and the pressure, there's no peristaltism because the summation of the two is a constant. Therefore, there's no stimulation of the myometrium. And this is the step 2, is to make progress in diagnostic hysteroscopy. And you see here how it works. When the flow goes up, the pressure goes up, these come down. And therefore, there's no possibility of intravasation. So this is the step 2. It was in 1982. So you see, when you perform diagnostic hysteroscopy, become a very reliable examination with a lot of precision. Like here you see organic pathology. For semiology of the endometrium and vascularization, you can study the vascularization to either say what is the step of estrogenotherapy, it's estrogen's level of the body. You can have some dystrophy, like, for instance, endometritis and organic myomas or polyps. So in this step 2, we had developed also a rational organization of diagnostic hysteroscopy. Here you see how is a normal setting for diagnostic office diagnostic hysteroscopy. You have all the video printing camera on the right. You have all the optics and control of pressure of intrauterine parameters on the left. So you don't have to move at all. Everything is done perfectly while sitting in front of the patient and looking at the screen. And you share this vision with the patient so that she can see exactly what's going on and you can explain. Or when you have a teaching, it's also very useful because they have to look screen as before at step 1. They have to look through the scope. You do the hysteros and you say, look at this. And you see, it's a lot of progress. Okay. The next step is step 3. We developed it, we start to develop this in 1984. It is the endomat. The endomat is exactly the same thing as the microhysteroflator, and with the same parameters and the same principle, but it is liquid media for operating hysteroscopy. And therefore, it is a little bit more complicated because water and glycine cannot be compressed. So we have to use more parameters. We have to use 3 parameters. We have to use the pressure here. You have to use the flow, and you have to use the evacuation of the water. So you see, all this is calculated by the machine. And by controlling these 3 parameters, you're going to have exactly the same protection as the microhysteroflator, and therefore you don't suppress the risk of intravasation of liquid when you have a vein open. but the machine will warn you if you master very well this technique, because if the pressure or the flow, you see when the pressure goes up, the flow come down, and when the flow goes up, the pressure come down automatically, and that is make also very comfortable operative hysteroscopy. You are not bothered by peristaltism, by bleeding. You can control all this with this machine, and we shall see later. It is also used for hydromassage. So this first step, it was in, then we do application of operative hysteroscopy. We started with organic pathology like a fibroid, and you see that with these parameters controlled, it is a very simple and easy operating procedure without any problem. You can overcome all the bleeding problems and all the risk because of the vision, exact vision of the structure. Here you have the myometrium, and you know that you have removed the base of the myoma. And you do that, and you see it's very fast and very simple. This is when it is you have another myoma which is interstitial. If it is small, you just don't bother, you remove it, and that's all. Okay. Here also the second operative procedure, which was developed in 1985, was the endometrial ablation. Here again, you can control perfectly bloodless the resection of the dystrophic endometrium. And you see, if you are organized, it goes very fast. You are always at the same depth, and you remove all the glands, and that is, you see, without any bothering with bleeding, with peristaltism, with carbonization. All this is controlled. This is the step 3, and it took, as you see, 5 years between the conception of the instrument to the capacity of using it in a daily routine diagnostic or operative hysteroscopy. So the step 4 is maybe one of the most important, because it will, at step 3, we could only remove fibroid intrauterine fibroid, or if they are partly visible in the cavity. But and at step 3, we couldn't remove this kind of fibroid. Now, between 2000 and 2022, we progressively been able to remove more completely intramural fibroids, and even if it is very small space between serosa and the myoma, it was possible to develop the technique, but it takes a lot of years to complete such a procedure. So let's see, you can remove fibroid. You will do the same thing with adenomyosis. You see here, you cannot see it in the cavity when you do prior diagnostic hysteroscopy, but you can localize and you can be able to remove all the cyst or the spot of adenomyosis. What is this? Oh, this is, for instance, we remove a fibroid like this. You see, you can see the serosa here, but maybe this is for the future, not do that daily, because there's a risk of perforation. And I don't remember. Oh, this is when you know there's a cyst somewhere, you just go there and remove it. You see here. Okay. So you see that was the most difficult. When you have a fibroid which is intramural, you see how you remove it. You cannot see it in the cavity. Therefore, you're going to open the capsula and do hydromassage to push the fibroid into the cavity and remove it with 100% of safety. And this is possible with the endomat. You see, you going to push, you size intramural, you open the capsula, you alternate positive and negative pressure in a very swift way. And here again, it is for security that you do this hydromassage. No, I'm sorry. So for adenomyosis, here you see you can have spots on, it is the same uterus before and after operating, and you see that the spot correspond. So you know where it is. As you don't see anything inside, you know where it is. So you're going to resect there, even if you don't see. And when you see the focal infiltration by adenomyosis, you're going to remove it until you reach, if possible, the myometrium. And 70% of indication is for metrorrhagia, to remove such, because it's too aggressive to use it in infertility. So you have another type of adenomyosis, which is cyst. So the cyst is here. You know that it is about here. No, I'm sorry. You know by the ultrasound that it is about here. So we shall do, look, we shall go there and remove the endometrium and few millimeters of the myometrium where you think the cyst, adenomyosis cyst is, and you will find it. You can guess it is around here. And here, you see we were a little bit left of it. So we know where it is now, and we shall remove it with the capsula. And this can be used in infertility because it can be a cause of difficult implantation. Okay, next. And the last thing is focal infiltration here. And the last type of adenomyosis is adenomyoma. Here again, it is for infertility. You see that adenomyoma is a very special pathology since there's no capsula, there's no it is a continuum between the myometrium and the adenomyoma. And here again, you see that in the cavity, when you're doing prior hysteroscopy, you cannot see where it is. So you know where it is, and we shall here again do the same. So we know where it is, so we remove the endometrium, focal endometrium. We see it here, we can see it. I show you, it's a mixture. You can see it's a mixture of myoma and glands. You can see here how it is. You have a mixture of them. So sometimes you can remove here, you can see better. So you're going to remove it progressively. Oh, here you see the mixture of myoma and adenomyosis. And you will keep going, but not too deep, never exceed about 10 millimeters in depth. Otherwise, there's a risk of perforation. And here And this is very useful when you have an adenomyoma in infertility, and you see, you continue. Well, this was a very difficult step, and it was developed for more than 20 years to be able to work in the position, in the blind part of the uterus, that means between the extra-serous pathology, which is accessible to laparoscopy and inside. So this was the most difficult, which took about 10 years to perform more and more precise procedure. And let me show you in this step 4 of intramural pathology, you can have diffuse adenomyosis. And indication can be infertility, even though it is concerning all the cavity, because the technique we use is to open beneath the endometrium. You going to do furrows of about 7 millimeter depth, and regularly, and as you see, you don't destroy at all the endometrium. You use, of course, special currents not to have carbonization, and so that you respect completely the endometrium. And you see that you can do that all over the cavity when it is diffused adenomyosis, until you get here. You see you have furrows all over. And once you have done let me see if we have all furrows. Here, you see the furrows here, so you see them. And once you open them, you're going to, in the bottom of when you see a localization of adenomyosis, it is just simple to destroy it by fulguration. And therefore, you don't touch the endometrium, and it takes about 1 to 2 months to heal completely. And you will not see anymore any sequela of the furrows you have done. Okay, so you see how we proceed for adenomyosis. So, hydromassage, how we do that? You see, I did show you. You're going to use the endomat here with swift change of pressure. It will stimulate the myometrium and bring any pathology, organic pathology, which is inert, into the cavity, and of course treat this pathology in a very safe way and without destroying the endometrium. And now the step 5, which is unfortunately not much used yet. And as for anything in medical field, it takes sometimes 20, 30, 40 years old until it become routine. So let's see this example of cervical pathology. You see here you have the transformation zone, which is all the strategic part of the cervix. You see it by microcolposcopy at magnification of about 100. You see that you have gradation, you have columnar epithelium, the junction, the transformation zone, and the normal iodopositive zone. This is how it is looked at about 80 to 100 magnification. But with the HD cameras now, we have done a lot of progress, because you don't have to control the light, the coloration, and all that. The camera will do all this. It will magnify by 10, therefore you can see on the screen perfectly the cells. without with great comfort and always a clear vision because of the control of the light by the camera and the control of the focus of the camera. But you need the microhysteroscope to reach this step. That's why I say it will take some years. But it's important. Let's see. This is how, when you do microhysteroscopy in the cervix, normal normal squamous, normal epithelium with pycnotic cells. Okay? I'm sorry.
Дорогой Жак,
Dear Jacques,
Conclusion. And here you
я
see,
знаю.
I know this.
you can identify neoplastic cells. It's not difficult. This is normal. This is neoplastic. So next. And so, but you know, all this progress, you have to understand, I've worked a lot with Mr. Storrs, the father of Relink Storrs. And he was a genius in manufacturing whatever was calculated. And without this family, that means Mr. Storrs and Mrs. Relink Storrs, of course, we had the principle and the fundamentals of microhysteroscope, but we would have been nowadays at step one of hysteroscopy without those people, because they did that so perfectly that I think I owe them all the progress we have done in such a long time. So in conclusion, hysteroscopy has become a major tool in diagnostic and operative gynecology. In diagnostic hysteroscopy, endometrial evaluation, organic pathology, uterine defect, operative hysteroscopy, organic pathology, synechia, congenital, and adenomyosis. Okay, that's over. I hope you, it was a
Дорогой Жак,
recall
дорогой
on many
профессор
years,
Амин,
many decades.
понимаете, это
Dear Jacques, Madam Storz, Father Storz, they are important, of course, but the most important thing in our life is such people as you are with us, and these instruments, these devices are now in your hands. They developed the devices, but you use these devices in your hands. Hysteroscopy is our Bible, the Bible for studying the uterus. We know what the size of the uterus is. We can see it from inside. We can see the morphology. We can see the cyclic changes. We can see different synechias, tumors, and we not just can see it, but in some cases, when we do office hysteroscopy, we can eliminate many things. Hysteroscopy becomes the method that may replace hysterectomy. Thank you very much for your service to people. Thank you for your presentation. Stay with us. Dear colleagues, right now we have a wonderful course, an expert course in hysteroscopy. And I'd like to give the floor to Professor Stephanie Bitocchi. Professor Bitocchi is the professor at the Department of Clinical and Experimental Medicine, Foggia University, head of the Department of Obstetrics and Gynecology of the University Hospital in Italy. Power of hysteroscopy through the years is the theme of Professor Bitocchi's presentation, a live surgery and a presentation. So right now we're talking about the hysteroscopy school. Stefano, you're our friend. You're the youngest specialist, and I would say you are one of the best specialists in this field. You have 30 minutes. Please cover this subject, the power of hysteroscopy. Please.
Thank you, Leila. Thank you to all of you. I'm very happy to be with you, even again on the screen. Thank you for being the youngest, but I'm not the youngest. I'm becoming one of the oldest. But anyway, it's okay. Listening the presentation of Jacques, I just fit perfectly the title of my presentation as a consecution of the presentation of Jacques. So seems to be the same, the history of modern hysteroscopy, but it's a totally different point of view. I define as to be in the right place at the right time, or even better, to have the right instrument at the right time. So my presentation will be focused on the power of the modern hysteroscopy. Jacques showed to you how hysteroscopy developed in his hands since the 70s, and I will show to you what's happened afterwards. We know, I don't know if you heard the sound also of the presentation. Let me check. Okay. We have every evening we see a moon in the sky. Okay, for the young generation, the moon is there. They don't ask why. They see the moon, and the moon is part of the night panorama. But we have to know how the moon was not there since the beginning. We know that the moon was the result millions or probably billions of years ago of a planet on a very young Earth. It's called Teros. And the impact generated an apocalyptic event where the planets impacting the Earth was totally destroyed and was generating billions and billions of different size fragments. That during the millions of years, they get together and they create the moon. So why I use this kind of, let's say, of introduction? Just to say to the new generation that they have to be able to go through the history of hysteroscopy. It's like the moon. They don't have to say today hysteroscopy is done in a certain way and therefore that's it. We have to understand why we moved from the hysteroscopy we did in the 80s, and Jacques told you very well. The 80s were a fantastic period. We were almost all happy. There were, let's say, money and ideas circulating. But also there were many products that today, probably my child, very young, they don't know even they exist, but they are part of our memories. And the people, around the 60 or the 50, they probably remember all these devices. So we have to go back to that time to better understand the power of how we got the power of hysteroscopy as we see today. So that time, the 80s, where for a certainly long period was the time of the masters. And of course, Jacques is one of the masters, and everybody, including myself, we were listening, like in the past, we were listening to the philosopher or the senator in the old Roman Imperial or Greek Imperial. There were a kind of respect in terms of what they said, and no way to reply except with reasonable and super proof ideas. So that time was the time of diagnostic, 5mm hysteroscope, CO2 anesthesia. There was some complication, blah blah blah. All the things you already heard from the presentation of Jacques. But then we got to the and this is of course the pictures of what's going on in the 19th, and also what I did as my personal experience when I started in '87 to approach the field of hysteroscopy. CO2 gas, bubbles, and so-called Japanese flag in case of blood inside. And of course, look on the right of the screen, the surgical power of hysteroscopy was zero. The whole power was in the end of the resectoscopic procedure. With hysteroscopy, you were able only to look inside the uterine cavity. Of course, there was at the time a dedicated sheath for the so-called AMU1 and AMU2 scopes, but the scope that was 5 millimeter was then becoming close to 7 millimeters. So therefore, at that time, we did some study on, for example, on biopsy in '93, and every patient undergoing a biopsy had to undergo also sedation or anesthesia, because we were forced to dilate the cervix up to 7 millimeters to get to be able to introduce the so-called AMU operative hysteroscope. So the power of hysteroscopy, as hysteroscopy performed without any kind of anesthesia or sedation, was 0. Then one day we wake up. Okay, this is of course it's allegory to what's happened. We wake up in a static world, the world we were used to have. Let's say a primitive, let me use compared to today, of course, but super advanced for that time, a primitive world of hysteroscopy, and an idea came. So, like in 2001 a movie, we got the monolith, and the monolith changed probably our life, or gave us the push to develop, let's say, a new idea, a new concept for hysteroscopy. And this was the age from '94, start the age of the liquid distillation and vaginoscopy. But as I told you prior, the world was, let's say, dominated by CO2 and diagnostic instruments. So I represent this change like the, let's say, the attack or the competition between David and Goliath. Of course, David was the new burning concept of hysteroscopy performed with the liquid, without the speculum, the tenaculum, and including some operative procedure. And Goliath, of course, was the very well known and developed CO2 pure diagnostic hysteroscope. So day by day, year by year, the young, let's say, concept of hysteroscopy was able to not to kill, because it was not a matter of killing anybody, but to change the mind, the idea of the people, showing that there was probably time for a new idea. And at that time, as you see, we start changing also the power, or improving the power of hysteroscopy. No more zero power in terms of surgical capacity, but thanks to the mechanical instruments that were introduced during the '90s, we were able also to start removing polyps, to do, syneculysis, small surgery. So this was the subtitle I told you at the beginning: to have the right instrument, or to be in the right place at the right time. So we got the instrument, and we stressed the use of the instrument, and you see the turtle, the power of receptoscopy was already contaminated by the power of the incoming modern office hysteroscopy. So we used the mechanical instrument for years until we understood the limit of the mechanical instrument, of course, and we were looking for something different. And something different came in '98, when it started the age of bipolar instruments. You know very well the VersaPoint, who introduced the concept of using bipolar energy through a very small 5 French or 1.6 millimeter probe, able to get inside the operative channel of the office hysteroscope. And then was another jump ahead, and we were in the right place at the right moment. So we already stressed the use of mechanical instrument. We were looking for something more powerful, and something more powerful came. So we were able to start the new age. It was a long age, already more than 15 years of use of the bipolar instrumentation. And even here, we hardly stress the use of the bipolar 5 French instruments, and we got we again eat a part of the cake, and you see already half of the surgery, who was before a matter of the receptoscope, was already in the end of office hysteroscopy with the mechanical or with the bipolar instrumentation. Then it came another age, the age of the mini receptoscope. Of course, the mini receptoscope was introduced earlier than 2016, but I put 2016 because in 2016, even the young world of the mini receptoscope changed, having for the first time an instrument of 5 millimeters. So at the same size of the instrument Jacques showed to you as innovation at the end of the 70s, beginning of the 80s, the same size, then 30 years later, was the size of a full capacity bipolar mini receptoscope. And with these instruments, we were able to jump ahead and to eat another part of the cake. So the power of classic receptoscope was before 100%, so everything was done using the classic receptoscope. Then with the combination of mini receptoscope and office hysteroscopy, but the mini receptoscope, for me, it's a part of office hysteroscopy. You see, almost the majority of the case are done, could be done, of course, in an office setting. So this was, and is still today, one of the major topics, the use of the mini receptoscope. And of course, it came also, not only in 2020, but earlier, the tissue removal device, so-called at the beginning morcellators. Why again not writing the early age of the tissue removal devices? Because in the early age, it was really a niche. People were not appreciating the use of this instrument. Today, thanks to new application and thanks again to the miniaturization of this instrument that are getting closer and closer to the 5 millimeter, who is for us, office hysteroscopist, the limit, we are able, and we will be able in the future to see instruments of a small diameter tissue removal devices, morcellator, call as you want, of a small diameter. So this is another improvement. Of course, it's not getting into the field of receptoscope or the small area still dedicated to receptoscopy, but it's already a mix of the power for the instrumentation. You see, still a part for mechanical instrument, a part for the bipolar, a large part for the mini receptoscope, and the tissue removal devices are really present and available today. So I want just to show to you some videos. This is, for example, it's an official video done by me for Karl Storz, explaining the way we can solve some problems. So this is, for example, the way we are developing now, and it's an incoming study, to get biopsy in a hard tissue. We call strip biopsies. Why? Because really a strip of tissue, you can see here, being the loop, a closed loop, the diameter of the biopsy remains the same. The length of the biopsy depends how long you stay and how long you are able to move the mini receptoscope loop inside the cavity. So we get biopsy from tissue that before was almost impossible to be biopsied, like atrophic tissue, like cervical tissue. Imagine when you have a problem with modification of the cervix. Then again, with the mini receptoscope, we have the possibility, you already saw the mechanical instrument before, then with the mini receptoscope, we change also the way of performing metroplasty. Here you see a small septum treated initially in the classic way, so using the L shape or the hook. So once you remove the septum in the way you were used to do with the receptoscope, without dilating the cervix, it means without changing the visual anatomy, then it remains, as always, a triangle on the top and triangle on the bottom. This triangle, in our opinion, must be removed. And then we move to the loop, and you see we are removing tissue that is exactly like a myoma tissue. In fact, our study demonstrates that the tissue is exactly the same it appears on myoma. And if you look at this picture, it seems to be that you are removing, without knowing what we are doing, it seems to be that you are removing the final part of a myoma. At the end, you leave a cavity intact, but without fibrotic tissue. And then some video I already published on the net, so probably some of you already know them. And this is again relate to a septum, but just to explain that sometimes inside the septum you should find some surprise. So here we were at the early stage of our study with the septum. We were removing the septum, not in the way I just showed to you, but still at the time using only the loop. So we were removing, then we understood that this technique was so done, was let's say a little bit complicated for beginner, and then we moved to the technique you saw just in the previous video. But just to show to you that while we were removing a normal septum, then in the middle of the septum we discovered a myoma. It was a nice 1 centimeter myoma totally included in the middle of the septum. If you see in panoramic view, there is still a lot of septum present after the myoma. So we are removing the final part of the septum, and we found inside the muscular part of the septum, because if you read our study, you will see that you see how long is still the septum, that in the a part of the septum, the one who is nearest to the fundus, it's made by muscles, but it's muscles that is not the good muscles should be there, but it's a modified muscles where all the muscles fiber are parallel. So it's, let's say, it's not useful for the classic, let's say, contraction effects we need in the myoma. So here you see how we approach. We remove the septum, and then when the septum is totally removed, the myoma practically float inside the cavity, and then we remove also the myoma. We finish first to remove the remaining part of the septum, and then we go with the myoma. This is, of course, you see, it's a totally let's say done with the mini resectoscope, so no dilatation, nothing. And you see the myoma with this capsula, so we don't touch any, let's say, good muscle. We just remove what has to be removed. Okay, so, and this is finally we get into the myoma, and we remove the myoma. Then we have another video, like in this case, it's a more complicated case. This was done completely in an office setting without any kind of sedation or preparation. I still remember that I was in my previous hospital in Bari, and one of my colleagues called me from the ambulatory visceroscopy, and they were unable to get inside the uterine cavity. They stopped in the cervix. So they called me knowing that I like very much stenosis and how to solve stenosis. So I went in with the scope, with the office hysteroscope, and I saw that there was a small space to get inside the uterine cavity. And this was done due to the presence of polyps, but particularly two large myoma kissing one another one, and one of them was cervical. So we get in with the mini resectoscope, and you see the first myoma who was cervical, and behind this cervical myoma, two submucosal myoma. So we start removing the cervical myoma, all done without any kind of anesthesia or sedation. It took let's say more than half an hour to do this, but being the patient perfectly, let's say, okay, and accepting eventually small local and focal discomfort, but anything strange for her, we were able to remove the myoma. And you see the myoma was a G0 myoma or G1 myoma maximum, and you see the first myoma over there, intercavitary. So we finished to remove the cervical G0 myoma here, and you see that it is not connected to the myometer, but it's only some adhesions. Okay, and we remove this myoma, and finally we see the two kissing myomas. Okay, so we remove this part of the myoma until we found the bridge was the problem for our colleagues. So we get in, and then removing the bridge, we were able to isolate the two submucosous myoma, intracavitary myoma, and we ended completely the procedure. Of course, this is a video of 15 minutes, but it's just edited. So we also, I have to be honest with you, we broken 3 loops because we were also at the beginning of our experience. This belongs to 2018. This video, so at the real beginning of the life of the mini resectoscope. So we were still designing the right technique to do the right things. And you can also see that the electrode is not the electrode we have today. It's not really round, but it's more like different shape, and it becomes sometimes red because we were not still having the update mode on the autocon generator designed specifically for the mini resectoscope. But you see, slowly, with the full respect of the anatomy, we were able to remove the part of the myoma who was approaching the cavity. So if you are interested, of course, the surgery takes a few more minutes, but I don't want to waste time or to take the time of the speaker. So this time it's on the YouTube. It's on YouTube. So if you want to see how it ends or the full procedure, you can go on YouTube. So in conclusion, if we compare the surgical power of hysteroscopy thanks to the, let's say, the presence or the idea of transforming CO2 hysteroscopy in so-called office hysteroscopy. You see the process of the surgical power start with the arrival of office hysteroscopy, and today it's really big what we should do in an office setting, of course. And just for the young generation, taking a clip for a famous movie of the 70s, it's called The Big Feast or Le Grand Buffet in French. It's an Italian-French movie, very famous in Italy and in France. I don't know if you know it, but it's here, it's just to give you the idea that today we have a big buffet. So big that sometimes you don't know what you would, you know what you would like to eat, but you are not able to eat everything because there are so many options that it's problematic for you to choose the right one. So the message I want to leave you is the message Stephen Jobs gave to his speech at the Columbia University. Listen very carefully.
Not too long from now, you will gradually become the old and be cleared away. Sorry to be so dramatic, but it's quite true. Your time is limited, so don't waste it living someone else's life. Don't be trapped by dogma, which is living with the results of other people's thinking. Don't let the noise of others' opinions drown out your own inner voice. And most important, have the courage to follow your heart and intuition. They somehow already know what you truly want to become. Everything else is secondary. Stay hungry, stay foolish. And I've always wished that for myself. I wish that for you. Stay hungry, stay foolish. Thank you all very much.
And this is also my thanks to you with this fantastic message, that it's my message also for the younger generation. Always try to prove your idea. Thank you very much.
Dear Stefano, you know, You're always surprising me with what you do, with what you show. Well done. The whole history from 1980s until today. History is changing and we are changing together with it. I am so happy that today we can gather together all the giants, the figure giants in hysteroscopy. And it's so good that we are changing so fast. We are still hungry. Sometimes they say, look, Leila, you've got it all. Why do you keep going to the operating room? But the operating room is like my church. It gives me strength, it gives me good mood. I am always craving for something new. I want to teach my students, and I'm so happy that all my friends today have exactly professing the same religion, feeling hunger for good things, trying to get to know things. And you are a fantastic example. You are just a fantastic, outstanding hysteroscopy that was conceived to me by Jacques Amour, by Sturz. You invented an elegant office hysteroscopy, but I suppose we can carry on and we will invent something new, maybe with artificial intellect, maybe no artificial intellect, AI, no AI, but I'm sure our own human intellect is enough so that we could conquer these diseases. Now it is my great pleasure to give the floor immediately to Professor Bigazzi. Professor Bigazzi is with us and is online, and I'd like to say that we shall necessarily, but we have two questions, but I will ask you these questions later on. And now Mario is online. Mario, dear Mario, 2 minutes.
Just 2 minutes, just to explain
Да,
you
да, да.
that we had the frozen section on the ovary, and like in the ultrasound evaluation, it's an endometrioid ovarian cancer. So we started to perform the pelvic lymphadenectomy on the right side during the two from Stefano and Jacques Amour presentation. On the right, on the left, we removed all the lymph nodes in the pelvic area. We removed the lymph nodes at the level of the common iliac vessel until the presacral nodes. You see here, we have the promontorium, the medial limit of the left side common iliac vein. This is the bifurcation of the common until the aorta, and we are at the level of the vena cava. We removed all the lymph nodes here laterally to the cava vena here, and freeing all the ureter on the right side. And so now we have only to go up, change position, and to perform the upper part of para-aortic lymphadenectomy. And then we remove the omentum, and then the staging procedure of the stage 1 ovarian cancer, the probably stage 1 ovarian cancer, is performed totally by laparoscopy. Okay? So,
Дорогой
thanks again.
Марио, все это
Dear Mario, all this time I kept, looking. I've been watching what you've been doing, so I very much ask you. Sorry, intervention online. So I very much urge you, when you finish this operation, please connect to us once again, get back to us, and tell us what you see, okay? Благодарю.
Обращаемся
See you later.
сейчас к
Bye-bye.
профессору.
Итак, we move over to Professor Giuseppe Bigazzi. Please, thank you.
Can you hear me?
Да, да,
Hello?
пожалуйста.
Yes, we do. Yes, we do. We do hear you.
Okay. So, dear Leila, thank you very much for your kind invitation. We are at the Sino-European Life Expert Center of Shanghai, and we have prepared 2 surgical cases. So I suggest that you show my pre-recorded lecture, which lasts about 17 minutes. And in the time you show my pre-recorded lecture, we will prepare for the first case. I'm here together with Professor Incha, is one of my doctor of the center. Okay? When you start my presentation, we will start to prepare for the patient. Okay?
Дорогой
colleagues, dear
профессор
friends, dear
Джузеппе, спасибо
Okay.
большое. Выступает
Thank you very much. Now we give the floor to Professor Giuseppe. Professor Giuseppe will give the floor. It is a pre-recorded operation. We must stop using DNC no more blind DNC. Bigatti's method is a new era in hysteroscopy. We shall hold both the lecture as well as will go live during the operation. Giuseppe Bigatti is the head of the Sino-European Experimental Center, CELEC, in Shanghai, and we just seen him and his distinguished colleagues from Shanghai. Please, could we have the presentation up, please?
Friends, dear Leila, it is for me a great honor to be invited to speak at this 26th International Congress held in Moscow. I would like just to say a few things before I start with my presentation. If it's true that in the past a good surgeon could just use a scalpel and it was okay, today instruments they have a very important role in our profession. Since the endoscopic cameras have been introduced in an endoscopy, instruments can make our life very easy and help us to be more precise in our job. So I hope that in my speech and my presentation, I will be able to explain why the Bigatti shaver is helping us in our profession and is making our life much easier. So thanks for listening to my presentation. Thanks, Leila, once again for your invitation. I'm Dr. Giuseppe Bigatti from Milano. Actually, at present, I'm based in Shanghai, China, since 2019, where I'm responsible of the Sino-European Life Expert Center, which is probably the first center dedicated only to hysteroscopy and which is doing innovation and which is based in Shanghai. So I'm very happy that I had the opportunity to give this lecture from blind to visual DNC. And the reason is because during my last, let's say, 4 years since I'm in China, the sentence which I've been using most of the time in my several speeches has been that the shaver technique is no more than doing a DNC under vision. So the aim of this lecture will be to explain why we should go from blind DNC curettage to visual DNC curettage. So the definition of DNC. DNC is no more than a dilatation and curettage and refers to the dilatation, widening or opening of the cervical canal and the surgical removal of part of the lining of the uterus and its content by scraping and scooping, so by doing a curettage. It is a gynecological procedure used for diagnostic and therapeutic purposes, and this is very important. To point the attention, the DNC is used both for diagnostic and therapeutic purposes, and I will explain to you later. And is the most commonly used method for the first trimester miscarriage or abortion. So if we look to the history of, in general, surgery and also of DNC curettage, the first signs of a surgical procedure like DNC dates back to the 13 and 1500 before Jesus Christ. And for those who have been lucky to go to Komombo Temple in Egypt, I remember they showed me on the wall some surgical devices which actually are very, very impressive because they really resemble the surgical devices we are using today. Even for DNC, you could see that there are some hooks, some curette, or even some scissors and some forceps, which are exactly the same tool we are using today. So if the Egyptian were the first surgical example we find in history, the second population who got the teaching from the Egyptian were the Greek. And Soranus of Ephesus was a physician who lived in Alexandria of Egypt and in Rome. And in the 2nd century after Jesus, he described the technique of the DNC curettage. And we can see some Roman period
devices which are actually very modern in their design and their use. You see, this is like, especially the bottom picture on the left side is a speculum, and the two valves are kept open by a screw movement, exactly the same like the speculum we are using today. If the Greek were the second to expand the surgical technique in modern civilization, Coelius Aurelianus was the Roman physician in the 15th century after Jesus, who actually put on paper all the teaching of Soranus of Ephesus, and he wrote a treatise called De Morbis Acutis et Chronicis, in which he actually put on paper all the teaching of the Greek. So the Egyptians were probably the first. The Greek developed the technique which was invented by the Egyptian, and the Romans spread this technique all over the world. Of course, we have to wait the Renaissance period during which Leonardo da Vinci started again to do surgery and to do some anatomical studies. So there has been a long period of Middle Ages in which everything was frozen, and of course Leonardo started again the modern concept of surgery. But it's a great pleasure for me to speak about Samuel Jean Pozzi. So every time I've been using the Pozzi clamp, I've been thinking to this guy, and I didn't know his history, so it was great for me to look to his history. And I always thought that Pozzi actually is an Italian surname, but actually this was a French physician. Of course, he was a French physician, but he was Swiss-Italian origin. So there is always a little bit of Italy in it. And the Pozzi clamp is probably the most used clamp all over the world because it's less traumatic. Is the best tenaculum you can use when you do a DNC curettage. And also the design of the curette made by Pozzi was extremely fine. And I should say that if I could have one of these curette today to perform a biopsy at the end of the hysteroscopy, it would be really of great help. Another guy which is very interesting is a Scottish physician, and John William Ballantyne, who developed actually and put on paper the modern concept of DNC curettage. He wrote a treatise, and in his treatise there was a chapter called Curettage of the Uterus, History, Indication, and Technique. And if you look to the indications, it's exactly the same indication we use today. So DNC was used both for therapeutic uses and for diagnostic uses. And you can see that between the therapeutic uses, there is heavy bleeding or heavy menstrual bleeding or hemorrhage from the uterus, especially when retained products of conceptions are involved. They had also a lot of infections, so DNC was used also to treat endometritis. And also what is interesting, it's also the induction of abortion, which is exactly the same what we do today, plus diagnostic reasons. So we can say that blind DNC for obstetrical and gynecological indication is the oldest and most widely performed surgical procedure. I would like to make two comments on this. The first comment is that when we were resident, the first operation which was thought to us was DNC curettage. So senior doctor always think that DNC is an easy procedure. So we start with this procedure, and it actually, DNC is not an easy procedure because it's a blind procedure. So you need to have a certain sensibility in order to not to make a complication. And this is probably why the complication rate by doing DNC is quite high. And also because this underestimation of DNC curettage. The second comment should be that you are not a good gynecologist if you never experienced one perforation during an obstetrical procedure with DNC. So you should have experienced at least once in your life the terrible feeling when you lose the curette inside the pelvis of the patients. So for this reason, we should
reduce the number of blind DNC. And operative hysteroscopy did a great job already because it gave the opportunity of a visual estimation of the uterine cavity, as well as a guided treatment of intrauterine pathologies. And this is a remark which has been made by Gregoris Grimbizis in the last hysteroscopic newsletter, which I received, and I totally agree to him. Of course, bipolar receptoscope is still today considered the gold standard to perform a major hysteroscopic procedure, but even bipolar receptoscopy has some drawback. So the limits of this technique is that the learning curve is very long, so it's difficult to use. This has to be clear, no? And for this reason, the complication rate is still quite considerable. So we can run into a fluid overload syndrome, especially when we are dealing with large myomas. We can have a perforation because the visibility is not so good. And what is most dangerous regarding bipolar receptoscope is the possibility to run into a gas embolism. This is probably the worst complication you might have today by using bipolar receptoscope, because when you have a gas embolism, there is very little possibility, very little to do. I mean, and then in the end, of course, we are using electricity, so especially when you treat myomas, you can have adhesion, postoperative adhesions. So bipolar receptoscope has some important drawback. So I think that the most recent, the latest and most relevant innovation in the world of hysteroscopy has been the development of tissue mechanical removal system. The advantage, first of all, which is the main, which is the difference between resection and TRS. The main difference is that these devices are able to remove the tissue chips at the same time of resection. By doing this, you implement your visibility inside the uterine cavity. For this reason, the learning curve become very short. So they are very easy to procedure, especially when you deal with soft tissue. When you speak about myomas, you still need some skill. And they are safer for several reasons, because the complication rate is also lower. There is always the possibility of a complication, even when you are using this kind of devices. So, but the complication rate is certainly lower and less severe compared to the complication you might have with the bipolar receptoscope. Actually, there are two disposable devices. One is the TrueClear, the other one is the MyoSure, and there is the Bugatti Shaver, which is this only reusable device in this group of devices. In 2018, there has been a development in the shaver system. Until 2018, we had only the possibility to use the 24 French shaver, which means 8mm optics. Since 2018, there has been the possibility to use the 19 French optics, which means 6.3 millimeter, much lower size of the optical system, while the cutting device is almost the same. So if you look to, this is important because I would like to describe our activity in Shanghai at the Sino-European Life Expert Center. The first year we performed about 3,700 procedures, almost 2,000 were trophoscope procedures, and about 1,775 were shaver procedures. And what is interesting in this whole group that we use the receptoscope only 4 times on large myomas. So this is 1 year of activity. And the second year, because of the 3 months lockdown period in Shanghai, the total number of procedures is less, always 3,038 cases. And you see that the trophoscope procedure has dropped down a little bit, while the number of shaver procedures is almost the same, 1,687 versus 1,775. And we had also this year, only 5 resection. So you see the lockdown period went from March until May, but also in February and June, the number of procedures were a little bit less, despite this reduction, you see the total number of procedures is very high, 6,737 procedure. You see that the number of shaver procedure is almost the same. Since I started this activity, the first operation was done in 2009. It was a small myoma. You see the number of procedure until July 2022. So now we are in 2023. Has been 4,522 procedure. Now we overpassed the 5,000 procedure. The majority are polyps and soft tissue, 82%, but also myomas are about 10% of our whole indication. And what is interesting is that if you follow the right indication and you choose the right indication for myomas, and you choose myoma which are less than 3.5 centimeters, in most of the cases you manage. And you see also recently in the Malaga consensus in 2022, there has been a general consensus regarding the indication of tissue mechanical removal system in those cases. So if you don't respect this indication, you will encounter the favor of this young lady on the left side. So no more blinded DLC should be used in case of endometrial biopsies, in case of retained products of conception, in case of heavy menstrual bleeding, in case also of endometrial polyp. And I should put, I was not involved in this consensus, but if I was involved, I should also put that in case of small myoma, the treatment, the preferred treatment should be the use of the shaver. In case of thick endometrium, in case of misabortion until 10 weeks, and also first trimester termination of pregnancy, these last two indications are still today quite debatable. So if you want to get more information about the shaver technique, you can look into the YouTube channel. In the end, I would like to say thanks to my friend, Professor Leila Damian. So Leila did a fantastic, invited me in 2019 to Moscow. And I should say it has been one of the most beautiful meetings I've never joined in my life. And also because I had the opportunity to do live surgery, to go together with Jacques Camus. I mean, Jacques Camus was doing using the resection in one OR, and I was using the shaver in the other OR. And you know, for someone who is doing hysteroscopy, to have the opportunity to do live surgery together, Jacques Camus is almost the top you can ask. So thank you for your attention. Thanks, Leila, for this wonderful opportunity you gave to me, and I really hope to have the opportunity to come to Moscow again in the nearby future. Thanks again for your attention. I hope you have a fantastic meeting.
Thank you very much, dear Professor Giuseppe. And we now move over to live surgery. Do I get it right? Do I get it right?
If you see the image of the uterine cavity, do you see? Yes.
Да, я
Okay.
вижу маточную.
Yes, I can. Yes, we can.
As you see, we have been very fast in preparing the patients since I introduced my live surgery. And this is all thanks to the people of Renji Hospital of Shanghai. Both my colleague, the nurse system, the anesthesiologist, they are just amazing. So we are using the 24 French shaver, which is the biggest one, 8.5 millimeters. So we had to do the dilatation until number of 8. You see, the view is just fantastic. Look at the view of this image. Okay, this is a patient of 29 years old who had some abnormal uterine bleeding, and the reason is because she has many polyps and a sort of hyperplastic endometrium. So I will show you and how the shaver works. The first thing you have to do, the nurse is helping me to insert the shaver. I've just checked the functioning of the shaver outside. When you have the shaver under vision, you press the pedal and you see the blade working. That means that the system is okay. And there is no collapse of the uterine cavity because we use a suction of 250 milliliters per minute. Then you rotate, you go closer to the polyp and you start. And this, actually, the operation would be already finished, but we have to remove all this endometrium. So we just do like this. Gently go up and down or rotate. If you rotate, you can remove quickly all the endometrium. Of course, the blade has to be in contact to the tissue that you want to remove. So the secret is that the shaver is removing the tissue at the same time as you dissect it. So you always control and you always see what you are doing. I don't know, I told my friends to show you also my hands to show the rotation. You see the rotation, I'm rotating the blade. I'm not just keeping the blade in the same position. The blade is coming out towards the posterior wall. So if you want to shave all the surface, you see you can go very close to the tubal ostia, no problem to making damage. Okay, this is the SB blade, the flute beak shape blade. I forgot to tell you that we are using the Bugatti shaver, the beginning, but this is not so important. It's the technique that is important. No matter whether you use this device or other devices. Okay? So we removed almost all the functional endometrium. So this will not give any problem to the patients. Professor Insha, I don't know if she will have the opportunity to make an operation. She did a study on 1,000 cases. And by doing this, the recurrence on 1,000 polyps, and by shaving not only the polyp, but the whole endometrium, the recurrence rate is only 0.3%. Only 3 cases on 1,000 recurrence rate of polyps, which means that is the lowest recurrence rate you can find in literature regarding polyps. And you are not making any damage to the patients because you are not removing the basal layer. You're just removing the functional layer, okay? So at this point, I think we can be satisfied. We can be more precise, but I think the operation is finished. So another thing I want to tell you is that the use of the shaver is not difficult. The learning curve is very fast. The difficult part is done by the nurses. The nurses that they have to do the setup of the machine. And this is the most, let's say, complicated thing as far as we are using the 24 French shaver. Because with the 24 French shaver, we have a double flow also on the optics, which makes the system a little bit more complicated. We are using the AMU endomat and the endomat LC for the shaver. If we were not using this pump, whenever you go in with the system, the first operation I did in Italy in 2009, I didn't have a pump to control just the shaver. And so all the fluid came out. So the nurse was clipping the suction tube by hand. Okay, so this is the finish. Last thing. So this is the posterior wall. If you want to reach the anterior wall, you don't have to go down like this. This is a mistake. You will bend the blade. You have to do a rotation. You see how easy you go to the anterior wall. You go to the left side and you go to the right side. Very easy, okay? Leila, I think my surgery is finished.
Дорогой
I'm
Джузеппе.
sorry.
Да,
I'm sorry.
дорогой Джузеппе.
The problem is that the shaver is too fast. And my colleague Isha is even faster than me.
Дорогой Джузеппе.
Dear Giuseppe, dear Professor Bugatti, you are a decoration of this morning session. This was the highlight of this session. I want to say that you're a brilliant surgeon. We are all aware of this, but we are lucky today. This morning, we have only star performance today. They are Professor Amu, Professor Betoki, Professor Bugatti are all speakers today. And I would like to say, dear colleagues, may I remind you once again, today we are on day 2 of the 36th International Congress on new technologies in gynecology. This congress is hosted by the Center of OBNG, named after Kulakov. The director of this center is also a champion of new technologies, academician Gennady Sukhich. Thank you very much.
We've seen different techniques. Well, the baseline technique, we've seen hysteroscopy by Stephanie Bitoki and shaving by Professor Bigatti. No more blind dissection. We should not have any blind dissections anymore. And before I give the floor to Professor Minkalia, please show Mario Malzoni for a couple of minutes. Can you show Mario for a couple of minutes? Mario would like to see you because I've been watching your surgery all this time. Please show Mario Malzoni on the screen. Excellent, excellent, Mario. You can speak.
Yes, okay. We are ready and we are finishing our procedure. I want to show you the final part of this procedure and just few seconds in order to give you the picture inside. So we did all the cranial part of our lymphadenectomy and we arrived at the level of the renal vein. The renal vein is the landmark, the cranial landmark of our para-aortic lymphadenectomy. So here we are. Okay, so no. Let me know if the picture is okay.
Yes, yes, very good picture. That's a very good picture. Thank you.
1 second, I want to show you the situation here. Now we are in the control position. So I am looking up the head of the patients. And here we have the right ovarian vein at the origin in the cava. We removed all the lymph nodes between the aorta and the cava. Up here, you see here, we are at the level of the renal vein. This is the renal vein, the left renal vein going across the aorta and going to the kidney on the left side. This here we have the mesenteric artery, and we removed all the lymph nodes. Here is the bone here, you see. And this area was the area of the para-aortic lymph nodes that we removed completely. We removed the intercava aortic lymph nodes. You see the ureter on the right side here. This is the right ureter on our left side. Allontanate un poco, la bifurcazione. You see the bifurcation here, like usually the bifurcation of the common iliac artery here on the left. This is the left common iliac vein and at the level of the cava. So all the lymph nodes here we removed, and we are removing now the omentum. We are a good part of our omentectomy. I remember you that it's an infracolic omentectomy. So at the level of the transversal colon here, we remove all this omentum and then we finish. So thanks again, Leila. And if you want to share and to go in the other operative rooms.
Дорогой Марио.
Dear Mario, we have a wonderful situation here. We are at RIA Novosti Agency. We have 4 screens, 4 big screens, and we can see everyone on the screens. And right now, we've been watching you. So, dear Mario, thank you very much again, and thank you to your team. Professor Giuseppe, thank you very much as well, and also thank you to our Chinese friends. That was a wonderful procedure. You convinced us that there should be no blind interventions. Thank you for showing us both the presentation and a live surgery. Thank you so much. Now let's move on to Professor Luca Mincalia, Italy. Please show us Luca Mincalia or Luca Mincalia. I called you the biblical way. Thank you so much. Show Luca Mincalia. Are you connected? There should be a connection. He was just here. I saw him on the screen, and then he disappeared. All right.
Скажите ему.
Please tell him he should be online. Luca, Professor Mincalia, please turn on the camera. Turn on the camera. Professor Mincalia, please turn on the camera. Luca. Well, Luca Mincalia, can you hear us? Luca. Professor Mincalia.
Professor
Mincalia, please turn on your camera. Turn on your camera. Please turn on your camera, Professor Mincalia. We cannot see you on the screen. Well, I can see you, but not everyone. Who else can see you? Dear colleagues, you changed the screens, I guess.
You hear me?
Dear colleagues, I'd like to introduce Professor Luca Mincalia, who is the director of the Department of Physiopathology of Human Reproduction, Santa Margherita Hospital, Margherita La Fratta, sorry if I got your name wrong, Cortona, Italy, platelet-rich plasma intrauterine infusion, a new frontier for repeated implantation failure. That's the theme of the presentation. Professor Luca Mincalia was in Russia in 1991 when we had the first congress, the first course on hysteroscopy. Giacomo was with him, and Frank Lofer, and many other wonderful gentlemen. So, Professor Mincalia, the floor is yours. Start your presentation. Thank you.
Thank you very much. Good morning. Thanks to Leila for this kind invitation. I'm very proud to be in this Congress, in this very important Congress. So I will bring my experience. As you know, we are one of the major public center of Italy for human reproduction and for IVF. And one of our last research is utilization of platelets
rich plasma intrauterine infusion. As you know, platelet-rich plasma is obtained from a venous blood draw, which is centrifuged and to remove red blood cells and to leave a concentration of platelet higher than in baseline. Is very inexpensive and allows to have a really important body repair and regeneration of tissue, all tissue in the human body. Why? Because we have in this platelet concentration growth factor involved in intercellular communication mechanism and a very important concentration of platelet and consequently of cell for stimulation of regeneration. Is PRP, platelet-rich plasma, is utilized in reproductive medicine, from more than 30 years. In reproductive medicine, in a very large time, more than 10 years, especially in Spain, Italy, and United States. Promising results. We really think that need more randomized study in large samples that's for standardization of the preparation of PRP. Where we use in patients with poor ovarian reserve, that's we call patient that have a very bad response to stimulation, but we use also in recurrent implantation failure and when the endometrium is thin and not enough thick to receive the embryos. Let's talk about simple utilization in endometrium of PRP. Why we use PRP? Because we think that if we inject PRP in the endometrium, we can have a more precise implantation of embryos. As you know, our problem is implantation. We have results in more than 90% of patients concerning recuperation of oocyte, fertilization rate, and all the stage of IVF. But when we go to implantation rate, this is very low all over the world, around 35, 38% of all patients. So for sure, our main problem is an implantation failure in patients. What we consider as repeated implantation failure is that means that when we have a minimum of 3 fresh or frozen cycles in a patient less than 40 years, we consider that repeated implantation failure. And also when the failure to have a pregnancy after 3 embryo transfer. So this is what we consider repeated implantation failure. What is the problem? The problem could be anatomical disorders, chronic endometritis, thin endometrium, immunological or non-immunological disorder, dysbiotic microbiome, and lifestyle habits. We decided to manage the endometrium of patient before transfer when we have a thin endometrium, that means less than 7 millimeters. We know that in this patient, the number of pregnancy is very low. And for that reason, we consider not to make a transfer if the endometrium is not arriving at thickness of more than 7 millimeters. We have an ongoing protocol accepted by our ethical committee in which we are treating patients with PRP in cryopreserved embryo transfer cycle. And this study will have a duration of 1 year and will include 20 patients to demonstrate the efficacy of treatment with PRP administered in patients with endometrium less than 7 millimeters or patients with repeated implantation failure. We will consider pregnancy rate and live birth rate. These are the points that we want to investigate. In patients with endometrium less than 7 millimeters, at day 11 of the endometrial preparation, before transfer for cryopreserved embryo, in patient with previous cycle suspended for inadequate endometrium, or patient with repeated implantation failure. The endometrial preparation is estradiol valerate 2 milligrams 3 times a day orally, and estradiol anhydrate 50 milligrams every 3 days transdermally from the second day of the menstrual cycle. The administration of PRP is performed about 12-14 days at the days of the therapy. Our preliminary results. 17 patients undergoing PRP intrauterine infusion, 5 patients with previous transfer cycle suspended for inadequate endometrium, and 12 patients with repeated implantation failure. Our preliminary results are 4 patients negative, 13 patients positive. Of these 13, we have 7 ongoing pregnancy, 3 biochemical pregnancy, and 3 miscarriage. So, as you can see, the results are very interesting, very promising, and we really want to perform this study. Consider that these patients are very difficult patients that have a previous negative story of IVF, and with this technique we can offer a new possibility of results and pregnancy. Thank you. Thank you very much, Leila.
Dear Professor Minkalia, I'd like to say that time goes on, but you make new things in medicine. But I'd like to boast myself. At our center, we have 8 operating rooms. At the Kolokov Center, a lot of surgeons, a lot of specialists who have PhD and advanced degrees. We have new technologies right now as compared to 1991. It was a pleasure to hear it from you, because as for PRP, well, platelet-rich plasma, we use it when we have a premature ovarian failure, and also when we have different procedures on the uterus, inside the uterus, when we have synechias, well, thin endometrium, as you mentioned it, and also cases when there are repeated implantation failure. We've been watching your research studies. We know your literary review concerning plasma, platelet-rich plasma. And right now, by the way, we have a woman who is writing a dissertation on this issue, and maybe we will have a joint research and publish the results of our joint work, because there are a lot of young women who have this problem, who usually have wrong surgeries at other centers. There might be trauma to the endometrium, and it's very difficult to provide care for these women in terms of their reproductive function. Thank you very much. Thank you for being with us. You still have your charm, or charm, as the French say, and your Italian energy is with you. Thank you very much, Professor Minkalia. Thank you very much, and good luck. Dear colleagues, Mario is with us. Mario, say a few words. You wanted to say something because we continue our conference. Mario, please.
Hi, Leila. It's a pleasure for me to share with you this moment with all the Italian friends, with Luca, Armando, Giuseppe. So thanks to you, Leila, for involve all the Italian doctor in your amazing meeting. And we finished 10 minutes ago our procedure. We're performing the para-aortic lymphadenectomy or mentectomy, and we closed the vagina with Stratafix, so barber shooter. And so then I think it was a good staging for ovarian cancer in good time, less than 2 hours and a half. So usually the patients go home in 2 days after this procedure. So I think the staging by laparoscopy of ovarian cancer when it's a first stage, or when CETO reduction is possible, if feasible by laparoscopy, is the best chance for the quality of surgery for the patients. So again, thank you for all the people.
Thank you very much, Mario, and we continue our Congress. Thank you again, dear colleagues. Now the floor is given to Giancarlo Di Renzo, a professor of obstetrics, mother and fetus, gynecology department of the Perugia University, optimization of luteal phase in reproductive patients after the gynecologic surgery. Please, Professor Di Renzo, show us your slides and start your presentation.
I'm very sorry that still we have to interact by web. Fortunately, we have this opportunity. And I congratulate with Professor Leila Damian, who is organizing the 36th edition of this International Congress on gynecological disease. And thank you for keeping me in the faculty, and very honored to be with you today. The task I was given is to speak about the need of luteal phase support in reproductive patients which are undergoing minimally invasive gynecological surgery. So let me address the issue, speaking first, no conflict of interest, of course, speaking about the fact that patients in reproductive age have mainly undergoing laparoscopy surgery, because mainly for large follicular cyst or endometrioma, so benign ovarian pathology, which has mainly a surgical indication. But of course, although there is a debate among the experts who should be treated or should be treated medically before going to a surgical intervention, we have to consider in any case that either one, either the other, may have variable negative influence on the ovarian function, and particularly of ovarian reserve. So the question is, do we should the surgery every time? And if not, what in alternative? And of course, also, which is the technique which is better? Now, some studies have shown usually that after any intervention which affected the ovary, there was a significant reduction of the anti-Mullerian hormone, okay? And these pertain for few months compared to the preoperative levels. Either we have treated the cysts which are normal follicular or endometriotic. Of course, the endometrioma is the most discussed, and the cystic lesion of ovaries are almost present in almost half of patients with endometriosis. And we have to consider that already the ovarian reserve is decreased because of the presence of endometriosis. And this is because probably the circulation of ovarian cortex or the compression of the cyst is causing follicular loss or apoptosis, or the inflammatory setting will bring to follicular damage. So you see that there is a study, in any case, consistent again, that the anti-Mullerian hormone is constantly show decreased after surgery, and therefore indicating ovarian reserve is affected. What about the technique? Technique is, of course, the laparoscopic look to be the most modern and most usual treatment for many of these disorders. And apparently, the effect of surgery on the ovarian reserve doesn't look so strong, but some of the features of the laparoscopy, depending from the type of the cyst, the inadvertent removal of other tissue, which is healthy, the effect of laterality, and the method of use for hemostasis are probably affecting the ovarian function afterwards. So the kind of suture, the bipolar cauterization, which are most used, and their disadvantage or advantages, or the use of hemostatic gels may change a little bit the prognosis related to the ovarian reserve. In fact, there is some study which are saying that the use of laparoscopic ovarian drilling, for instance, in polycystic ovary syndrome patient, change variably the blood flow and bring a significant reduction of anti-Mullerian hormone, which, as I said, nowadays taken as the marker of the ovarian reserve, along with evaluation of antral follicle count or the number of sites retrieved during an assisted reproductive technology, or the use of ovarian volume or Doppler velocimetry, according to different study produced. Now, very recently also, an Italian group has proposed the ratio between the volume of the affected and healthy ovary in order to understand the reserve in one ovary compared to the other, especially when we have unilateral endometrioma. Now, Saying that, therefore, in any case, that we have to be careful to look at the corpus luteum activity after any intervention we do in the ovary, whichever is the reason. I think that is very important to try to understand there is a defect. And unfortunately, here is not so easy. The reason, because there is a defect now, is mainly related to the inflammation that may be remaining increased after any laparoscopic intervention, the fact that oxidative stress disturb the normal physiological processes of the ovary and decrease, of course, the fertility and fecundity potential. The circulation of ovary is sometimes altered, and this factor is associated to poor progesterone production for the corpus luteum, and also the microenvironment of the peritoneum is changed, and this changed the endometrium activity and receptivity after operation. So how to define a deficiency? The definition that was given 40, 50 years ago was only based on a chronological order of menstrual cycle. If we have a premature onset of menses, this was already a sign of luteal phase deficiency. The second was the progesterone concentration in the blood with a magical cutoff of 10 nanogram per milliliter, but you know the variability of the concentration is very high and the circadian rhythm also very variable. And the third was the histological evaluation of the endometrium. In the 2 days of endometrial histological development lag more than the expected day of life of cycle was supposed to at least be a marker of luteal phase deficiency. Of course, the reason why we have a corpus luteum defect are not only the one that are consequent to an operation and to the ovarian reserve, but because we may have other action that may be enhanced by, for instance, the assisted reproductive technology, like, for instance, through supraphysiological level of steroids or inhibition of LH release and so on. And, of course, the fact that progesterone is not produced enough. So the best way is to understand what does progesterone. And the best way to understand if we need support is to add progesterone and see if the effects are maintained. What does progesterone in the luteal phase? There are 4 major activities among the many of progesterone. First, the transformation of endometrium. Transformation of endometrium, which is called receptivity because it's ready for implantation. This, of course, is because of the estrogen priming, but of course is related to a local vasodilation and the quiescence of the uterine musculature, because when the blastocyst arrives, may increase the risk of a small contraction of the uterus, and attachment is not as suboptimal. Therefore, the need is that progesterone is enough in order to maintain quiescence of the uterus. This has been demonstrated also with the supplementation of progesterone. Now, the problem is that how to support the luteal phase. 2 things are important to know. If we support with the natural progesterone, we should demonstrate that we obtain a synchronic transformation on endometrium. And this is being demonstrated only using vaginal micronized progesterone. With other progestin, this is not obtained. And in most of half of the cases, you don't obtain any synchrony between your menstrual cycle, the histological specimen, and the amount of progesterone you give, or the progestin you give. Second is that we know that any technology of assisted reproductive technology needs supplementation. But we need also supplement the luteal phase in intrauterine insemination, and not only, it has been demonstrated also that when we have difficulties in fertility or the so-called unexplained infertility in a patient, it can be useful to start supporting the luteal phase enough, with enough amount of progesterone, at least 600 milligram a day, because this has demonstrated at least a 30 to 40% fertility achievement and pregnancy achievement. And this is in keeping with the fact that when we look at luteal phase defect, which is consequent to operation of laparoscopic or any operation on the ovary, we have to try to support as much as possible in order to obtain a pregnancy, particularly because if we operate for endometrium, we need to have a pregnancy soon after in order to avoid a relapse of the disease. Eventually, when to start and when to stop. As I said, if we have IVF cycle, we stay on the day of egg collection, the most, or within the first 48 hours. This is demonstrated very well by a systematic review. Within 24 to 48 hours, the same should be done in the natural cycle. When to stop, nowadays nobody stops as soon as the test is positive, because this demonstrates not to have very good effect on the pregnancy maintenance, but at least to arrive to 12, if not to 16 weeks. And should we personalize the luteal phase support? Yes, because if now we have the possibility to measure very easily progesterone levels, although they are not correlated very well to the effect on the endometrium, we can titrate the levels according to the dosage we give to the patient. So there is a magic number of 10 that can be obtained also by giving 600 milligrams of progesterone a day. And if this number is not obtained, that's been demonstrated by the Spanish group, particularly of Valencia and then Barcelona, that we can increase the dosage of progesterone daily. And you can see here that this adjustment dosage is personalized. This is good for embryo transfer, for frozen embryo transfer, and also for natural cycle. Of course, another action we can have is to wait the test positive, evaluate also the concentration of progesterone with test positive. If it is more than 50 nanogram per liter, is enough, so there is no need to add more progesterone. But if it's less than 35, this is associated with a less chance of pregnancy maintenance, so the progesterone should be increased. So the information that we have nowadays is that the progesterone can be used as concentration in the blood only when used, of course, vaginal progesterone micronized, because if we use subcutaneous, we obtain so much progesterone in the blood, we cannot make any meaningful evaluation. We should prefer vaginal progesterone, and of course, this is in keeping with the safety data, which are not pertaining to the other progestins. And of course, we can nowadays personalize the treatment. And of course, patient, what they say, the patient preferring, and also obstetrician should say, because recent evaluation 2020 has shown that 80% of the center of IVF in the world are using vaginal progesterone alone, and there is no need to add anything else to vaginal progesterone. What say the international guidelines for support? The luteal phase should be supported. This is a committee opinion from American Society of Reproductive Medicine, but also from the ESRE. If the ESRE 4 years ago was also endorsing the use of progestins, nowadays, 1 year later, revised the guidelines saying that there is not too much safety for using the progestins, and there are concerns about the outcome of the offspring, either a short and long term, because nowadays, with the use of progestins, we may have some more teratological problems. So the final message is that the progesterone supplementation luteal phase is more and more important to consider in patients in reproductive age which are undergoing laparoscopic minimally invasive surgery of the ovaries and also of the pelvic area because of the changes which I mentioned. Vaginal progesterone is the best tolerated and main route of administration. There is enough data for its convenience and cost benefit. And of course, we have to start in 24 to 48 hours of any action that we want to pursue for pregnancy, for instance, after the ovulation or after the oocyte retrieval. The monitoring can be useful. If I use the standard dose of 600 milligrams and then I look at the concentration of the blood, and finally, although the data say that it's not the case to continue after 12 weeks because there is no evidence, I would say that the risk factor of a patient should eventually be personalizing the care and continue the progesterone according to the risk of preterm birth or abortion that one specific patient may have. Of course, there are need for more studies, particularly for the IVF people, and no need in the case of luteal phase support to add any estradiol at all. And I say that it's very important we don't forget the patient which have some reproductive surgery don't go directly to IVF, but they can be sustained in the luteal phase by progesterone because these may have very good result, at least in 40% of cases. Thank you very much for your attention. Спасибо большое.
Dear colleagues, dear friends, we listened to a brilliant lecture by Professor Carlo Di Renzo. Giancarlo is a great friend of ours too, and he thought he would deliver this lecture not only about intrauterine surgery, but about comprehensive preparation of women in reproductive organs so that the woman could conceive. It has to do both with the endometrium, both with the ovaries and with the insufficiency of the ovaries. Thank you very much. Dear colleagues, it is my great pleasure, my great gratitude, and I would like to give the floor to this audience to Professor Pietro Bari. Professor Bari, I've known him, it's been how many years since we met, and we listened to a fantastic lecture by a great surgeon, a fantastic specialist, a wonderful researcher from Spain that I love so much. What is the influence of age on female health? Professor Bari is president of the Clinic of Female Health, Dexus Mujer, is a consulting professor in the Department of Reproductive Medicine in Barcelona, Spain. Professor Bari, the floor goes to you. You're an audience of over 3,000 people from all countries are listening carefully to what you have to say. Thank you so much, Professor. Nietlina.
Thank you very much. Thank you very much, Leila. And it's for me, it's a great honor to be invited by Professor Leila Damian, who is a very relevant figure among the scientific community in the field of reproductive medicine and a good friend. So my apologies for not being face-to-face with you in Moscow, but with my heart, I'm totally with you. And it's an honor to be among this extremely high-quality faculty. All of them are good friends, and I would like to send them my best and warmest regards. So, greetings from Barcelona, where the spring is already here. And I'm going to talk to you. I will share my presentation. Just a second. I hope you will be able to see. Just a second. Can you see my slide?
Да, прекрасно
Okay.
видны слайды.
Thank you.
Спасибо.
Yes, we can. Thank you. Thank you. It worked.
The topic I'm going to discuss with you in the next 20 minutes is the influence of maternal age on fertility. And we know that when a patient reaches 40, age plays a negative influence on fertility for 3 different reasons. First, because these women produce less eggs and of poor quality, and it's more difficult for them to get pregnant. Secondly, because if they got pregnant, they have a higher risk of miscarriage, of a spontaneous miscarriage. That can be over 50% of patients over 50 will miscarry after achieving a pregnancy. And third point, because if they got pregnant and they have a normal ongoing pregnancy, this is a pregnancy that should be more carefully controlled from fetal and maternal perspectives. The social point that we are facing in all our hospitals today is that there is a social fact that there is a motherhood delay all over the world. And as you can see here in this slide, in Spain, we have the negative record of being champions of this motherhood delay. And as you can see here, the mean age at which a woman delivers her first baby in Spain is between 31 and 32 years of age. And this is for a general population, not for infertile patients. And why this motherhood delay? There are some reasons. First, and probably the most important, because women complain of not having a stable partner. They have also some professional and financial issues that makes more difficult for them to get pregnant at a younger age. And we know that if the age is advancing, the chances of having a baby or the risk of being infertile will increase significantly, as you can see here in this slide. At 38 years of age, which is the moment in which the perimenopausal transition starts, 20% of the patients will be definitely infertile. This percentage increases at 50% at 41 years of age and reaches 90% at 45 years of age. So we cannot fight against this biological evidence. But what can we offer? What can we suggest to this? We consider an old patient if a patient is over 38. And what can we offer them? Can we offer artificial insemination? Can we propose in vitro fertilization? Or the last option for them will be oocyte donation. Let's have a look at the artificial insemination if it's a possibility to offer to this patient. If we look at the data from the Israel registry, in Europe, 13% of all IUI cycles were performed in patients over 40 years of age. And look, the live birth rate is very low, is 40%, less than half of the standard IUI pregnancy rate that we should consider. In Spain, the registry of the Spanish Fertility Society, 7% of all IUI cycles are performed in women over 40 years of age, and the live birth rate achieved is 7%. Again, less than the normal live birth rate that can be obtained with IUI. And in other studies, they showed that the cutoff age above which the pregnancy expectations with IUI are significantly reduced for this study was 37.7 years of age. So according to all this evidence, we should not recommend IUI for patients over 37 years of age. And there is an interesting study conducted in a population of patients with unexplained infertility being between 38 and 42 years of age. And these patients were randomly allocated to 3 different protocols: clomiphene citrate plus IUI, gonadotropins plus IUI, or immediate IVF. And the pregnancy rate were significantly higher and fewer treatment cycles were needed when patients were treated with immediate IVF instead of treating them with IUI, either with clomiphene or with gonadotropins. What about IVF in this population of all women? IVF should be evaluated considering the parameter of cumulative birth rate. So is live birth rate obtained with fresh cycle plus with frozen cycles. And what about the influence of age in this group of patients? In our center, Marta de Vesa conducted a very large study analyzing the results obtained in a group of 4,500 women older than 38 years of age. And we analyzed in this group of patients fresh and frozen embryo transfer cycles. So we were able to obtain this figure of cumulative live birth rate. Of course, ovum donation, PGD and PEGA cycles were excluded. And this large group of 4,500 women were divided into 4 age groups. Group 1, patients being 38-39, Group 2, 40-41, Group 3, 42-43, and Group 4, all 44 and older. And these groups were different as, of course, as for the age, by definition, and they were significantly different according to their FSH levels and antral follicle count. Of course, FSH increased significantly with age, and antral follicle count decreased significantly according to the progression of the age. And let's have a look at the overall cumulative live birth rate obtained in these 4 groups of patients. And as you can see here, the cumulative live birth rate in the group of 38-39 was 25.6, 16.4 in the group 40-41, 7% in 42-43 years group, and 1.2% in patients 44 or older. There was a significant trend of decreasing live birth rate according to the progression of the age. Another important aspect that is really relevant is that the cumulative live birth rate increases with the increase in the number of oocyte retrievers. So the message was, the more eggs you have, the more embryos you will have to be either replaced or frozen. And in this study by Dracopoulos, what Draco showed is that when more than 15 oocytes were retrieved, the cumulative live birth rate could reach 61%, significantly higher than the cumulative live birth rate obtained in patients with 1 to 3 oocytes. And Nikos Politsos from our group conducted a multi-center study, with a larger study with 14,000 cycles in patients with their first IVF cycle, and the cumulative birth rate increases up to 25 oocyte retrieved in the follicular aspiration. There was no plateau, so the message is that the more oocytes, the more embryos, and the higher the pregnancy rate will be, but the increase is moderate if more than 27 oocytes were retrieved. The message is clear, but what about the advanced age? Is this valid for all age patients, or is this only valid for young patients? And what Marta de Besa in our group did is she split the results in according to the 4 groups that we had in the different age categories, and she analyzed the cumulative live birth rate in relationship to the number of oocytes retrieved in each age group. And as you can see here, when in the group of 38-39, in the group of if more than 12 oocytes were retrieved, there was an increase in the cumulative live birth rate. The same happened in the group 40-41, that 12, 19, 24%, with 4, 8, or 12 oocytes. In the group of 42-43, 5, 8, 12%. So the cumulative live rate increases with the increase in the number of oocyte retrieved. But in the group of 44 years or more, you can see that despite increasing the number of eggs, there was no increase in the cumulative live birth rate, 1, 2, and 2%. So this means that in patients over 44 years of age, I think that we should suggest other options apart from their own IVF cycle. Can we stop the progression of the clock? Can we do something more to increase pregnancy rates in this group of patients of advanced maternal age? Of course, we can propose them to have a PGTA analysis, to do culturing the embryos until day 5, 6. And if we obtain blastocysts, we perform a biopsy of these blastocysts to get 6, 7 cells, and the blastocysts will be frozen, and we can analyze these cells in order to find out if this or this specific embryo was chromosomically normal, euploid, and suitable for transfer. We know that the more the age of the patient advances, the higher will be the rate of aneuploidy, and the lower will be the rate of patients having at least one euploid embryo. So if we place the cutoff, as you can see in this table from Fransiak, at 30 years of age, 38 years and above, these patients will have a significant reduction in their aneuploidy rate, and they will have very few possibilities of getting pregnant. The advantages of performing a blastocyst biopsy, comparing those patients with polar body biopsy of cleavage stage biopsy are clear. So this is why nowadays all the PGTA cycles are the embryo biopsies performed at the blastocyst stage, which is less invasive and gives more material to be analyzed. And if we perform any kind of analysis, either FISH of comparative genomic hybridization, or what we are mostly using now, this is NGS, next generation sequencing, by using this embryo selection process, we will increase the chances of having a normally ongoing pregnancy for these patients of advanced maternal age. But we need to have more oocytes, more embryos, and in most of the cases, these, let's say, all patients have a poor ovarian reserve, and they produce few eggs, and they will get less embryos. And it's interesting, the strategy of the duostim proposed by Filippo Baldi and his group in Rome. What they do is they offer the patient 2 stimulations in a row with the same stimulation protocol, starting one in the follicular phase and the second stimulation in the luteal phase, just the day after the follicular aspiration. And as you can see here, if we look at the number of patients with euploid, at least one euploid blastocyst in black, when there was only follicular phase stimulation was 41%. If it was luteal phase stimulation, 53%. If we accumulate this strategy of duostim, we can have almost 70% of the patients will have at least one euploid embryo to be transferred. And this is really, the improvement is really significant. And there were no significant difference comparing follicular stimulation and luteal phase stimulation. And this is nowadays something that is clinically universally accepted, that we can start stimulation at a random moment in the cycle, and you can have even 2 stimulations in the same cycle. What else can we offer to this patient that cannot get pregnant at a younger age, and they assume that they will get older and when they will get pregnant, they will need young oocytes. We can propose to freeze their oocytes, what we call an elective oocyte cryopreservation. And the question is when we should propose this strategy and how many eggs do we need to really offer a realistic possibility of pregnancy in the later future. As for the number of eggs, this will be related to the age of the patients. And as you can see here, if we want to have at least a 50% chance of having one child, at least, in a young group of patients at 36 will be 8 metaphase 2 oocytes. At 38, you will need 14 oocytes. And at 40, you will need at least 20 metaphase 2. Then in this study, it was clear that in patients over 41, even increasing the number of oocytes frozen, you will not increase the chances of a future pregnancy. And what happened in the real world? And this is some information of different studies conducted all over the world. And again, look at the age at which patients come for an elective oocyte preservation. And more or less are around 37, 38, maybe is already too late. And look at the mean number of oocytes retrieved in this population is around 9–10%. And it is important maybe to do it early and to freeze more oocytes. And what about the thawing of these oocytes? We have looked at the data published by Anna Cobo, and what Anna has a large experience in this field. Anna published that the utilization rate was low. It was 12% for them. The mean age at thawing this oocyte was 40, and 50% of this cycle reached the embryo transfer, and the ongoing pregnancy rate per transfer was 39%, and cumulative live birth rate 34%. And what Anna showed is that the importance of the number, the more oocytes, the more embryos, and the more chances of achieving a pregnancy, this was valid. But in patients over 35 years of age, we can see that no more oocytes will increase the chances of a future pregnancy. In our experience at the Hospital Universitari de Zeus in Barcelona, we have accumulated experience in 2,000 cases of oocyte cryopreservation, some for oncologic reasons, some for benign reasons, but most 1,400 for elective oocyte cryopreservation. Mean age 36. Percentage of age over 35 is 74%. This is too high. In the mean number of oocytes vitrified, 9%. What about the thawing wishes when these patients come for warming these oocytes and having an IVF cycle and a pregnancy? Mean time to vitrification is 41 months, so almost 4 years. Mean number of oocytes warmed is almost 12, and survival rate is 73%. Fertilization rate is normal, 73%. Blastocysts, 41%. Mean number of total embryos, 2.7. And cumulative pregnancy rate per embryo transfer, almost 50%. And the last hope that we can offer to these patients is oocyte reception. We know that with oocyte reception, we can overcome the negative influence of age on fertility. And as you can see here, data from the American SAR registry, patients with oocyte donation are not affected in their pregnancy rate by the increasing age. We have analyzed our data looking at the pregnancy rate obtained in different group of patients, less than 30 up to more than 45 years. And as you can see here, pregnancy rate remained quite stable, although there was a slight increase in the miscarriage rate. So, for the take-home messages, we should not propose intrauterine insemination to these patients over 38 years of age. With IVF, we have a low success rate in patients over 42 years of age, and results in patients over 44 are really futile. PGTA can improve the results and can shorten the time to live birth with the possibility of trophoctoderm biopsy and with duostin in patients with poor ovarian reserve, and consider elective oocyte cryopreservation for patients, young patients between 30 and 35 years of age. And finally, with oocyte donation, there is a stable success rate, which is not influenced by the progression of the age. Thank you very much for your attention. Thank you very much, Leila, for inviting me to join your excellent meeting.
Dear Professor Barry, you know, it's like in life, very elegant, very confident, very smart. You have fantastic clinic. I visited your clinic about 20 years ago, and I'm sure that you made great progress. Also, I would like to say a compliment, because you raised a very sensitive issue, the issue of age influence on female infertility. Because in our country, we have a huge pilot project, which is called reproductive health. And in this project, even now, we are saying that still the birth interval should be from 20 to 35. From 20 to 35, when the eggs are fresh, endometrium is healthy, when a female for her reproductive life could have 1, 2, or even 3 children, and by the age of 40, she could even become a grandma if happens. So this message we should translate and interpret as a very important, and I see that you are on the same wave with me. So thank you very much. Distinguished colleagues, thank you very much. Thank you, dear Professor Barry. And now we are moving to next very important part, and this is how we start our plenary session. And I'm happy to give the microphone to Professor Arnaud Vattiez. The title of the plenary session sounds like New Opportunities and Technologies in Gynecological Surgery. And this is good, and this is very correct, that it is this aspect and it is this plenary session which would include great surgeons of our planet, Professor Arnaud Vattiez, Professor Kazuhiro Kawamura, Professor Hiraoka, Professor Patrizio, Professor Carugno, Falcone. And Arnaud Vattiez is the first one to start, and it is his right to start because he is our co-author of our huge interdisciplinary team. The title of the presentation of Professor Vattiez, and yesterday he showed brilliant surgery, by the way, and he is the member of international team of our educational course on laparoscopy. So the title of the presentation is Adenomyosis, Unresolved Issue. So dear Arnaud, you have your 20 minutes. You're welcome.
Thank you, Leila. Thank you also to take me a little bit earlier. I must say that in my agenda that served my purpose, so thank you very much. I will share my screen immediately to start. And I change a little bit the title in something that adenomyosis surgical management is time to be sustainable. And again, you know that this concept of sustainability is sometimes poorly understood in the medical, in the healthcare. So as you know, we have 4 pillars of sustainability. And when you look, sustainability is used normally not in medicine, is used in industry, is used in social things, but very rarely in medicine. And I think we are wrong. And I will try to make a parallel and then to move to the surgical treatment to explain to you what is the idea behind. The first pillar is human. And if you compare to healthcare, you can translate it in patient. And so what is the patient desire? What are the patient objectives? What are the patient symptoms? Should be a priority to define what kind of treatment you will give her. The second pillar is social. And that becomes even more important because we understand and we all know the impact of endometriosis and adenomyosis in the family life, in the professional career, in the quality of life generally, but also affecting, and I think this is what was discussed previously by Professor Barry and by you, Leila, about what we call now the reproductive autonomy of patients. I mean that is we can no longer tell to the patient because either she has a disease or because either she become over 30 that she has to run to get kids before it's too late. And so I think that this message should be changed. And this is our duty, we doctor, to provide all the necessary treatment we can to keep the reproductive autonomy to every patient. Then we have the economical pillar, which is important. And especially when it comes to adenomyosis, you know that we can speak about cost of treatment, surgery or hormonal treatment in long term. We can speak about the cost of complication, the cost of the iterative surgery that we see more and more. But also we should take in consideration the cost of the obstetrical outcome, which are not necessarily always very positive. And we have seen a uterine rupture. We have seen very, very early prematurity on babies after this kind of disease. So that also has to be a pillar that should be considered before you make a decision. And finally, we have the environmental pillar, which is important, and where paradoxically, I mean that the doctors or the healthcare system can be a stakeholder on the degradation of the environment, because we know that we are producing a lot of waste, we healthcare. And as I compare always, if healthcare in the world will be compared to a country, healthcare in the world will be the fifth country providing the worst waste and the highest carbon print in the world. And if you go to an hospital, you know that the surface of the operating room represents around 6% of the hospital and produce more than 40% of the waste. So necessarily we have to think when we do surgery about this. And the second aspect that also we have to look at the incidence of adenomyosis that greatly increase, and I will show you data, and that is probably due to the environmental impact of the pollution, or at least is one of the factors, because we see that endometriosis and adenomyosis are following the industrial area. And so mainly and probably, and even if we consider the epigenetic origin of endo or adeno, very probably that the reason of the accident, the epigenetic accident, may be the pollution. And so you see that we have to be also to look as a victim. And so the healthcare system is a victim of the degradation of the environment, and we have to look at this. So you see why when you compare surgery to, when you look surgery in sustainability vision, it's very interesting and we can go further. Coming back to adenomyosis, you know that we know it since long, since Rokitansky and Bird. Rokitansky in the 19th century, and Bird was the guy that in the 20th century make a better definition. And what we observe nowadays factually is that the epidemiological scenario changed totally, and as well as now we see more and more adenomyosis in very young patients in the age of the reproduction, as in the earlier time we are just seeing this pathology in elderly patients. And if you look the risk of having the main diameter of the uterine dorsal junctional zone, you see that in patients with endometriosis, you are much more keen to get adenomyosis. So even though this is not the same disease, this is still very linked. And so it's not anymore the disease of perimenopausal patient, and is actually the disease of young patient responsible for abnormal uterine bleeding, dysmenorrhea, dysmenorrhea, infertility, pregnancy complication, etc. So this is a strict burden. I don't want to go in diagnostic. You know, we share with between utero ultrasound and MRI, and I just give you my opinion, which is mine, and I don't say that ultrasound is less good than compared to MRI. I just say for me, for my surgical planning, I prefer MRI because I can have a better vision. But this is also because I don't do my ultrasound myself. I have a better vision for my planning, for explaining to the patient, and for the information and the consent for the surgery. So this is what I do, just to share with you. It's quite easy in T2 mode to see the lesion, to measure them, and to do this. And then you have also hysteroscopy, that is a big part, and especially for infertility. And if Rudy Campos speak after me, we'll speak about it. So, I mean, hysteroscopy is part with the possibility of doing biopsy with a spiroton. Alors, obviously, when we speak about treatment, surgical treatment, hysterectomy is the key, and it should be the way for patients who have completed their family or when no medication or no conservative technique can take over. Alors, we have a dilemma because more and more it was told in the previous discussion, a patient wants to conceive lately, and so we have more and more 35 to 40 years old patient that with adenomyosis that wants to conceive and claim that they want a conservative treatment. So if we go to conservative treatment, we have a lot of technique available. Mainly they have been pushed by Japanese people because of the frequency of diseases in their country. And we have always to balance the pro and the con. And remember that first, not to harm. And this is what we can do. We can do a complete excision, mainly when we have focal lesion. We can do partial adenomyomectomy when we have more diffuse. Or we can do hysteroscopy when we are under or at the level of the junctional zone. And so, for example, this is a case of posterior focal adenomyoma that can be resected. And you see the post-op result. We can never remove all, but we can be a cytoreduction, which is compatible with a better quality of life. And so this is the case of this case. And this patient got this cytoreduction. Result after she got pregnant, and unfortunately, she got an implantation of the placenta at the level of the resection, and she did a percreta. And so the baby don't survive, but fortunately, she became pregnant another time, and we delivered her early at 33 weeks with a very healthy baby, and so this is a good hand. Now, if it comes to technique, conservative technique, everyone knows the triple flap of Osada or the double flap of Takeshi. I put the two videos at the same time is not very interesting, except that I want to show you what we do because, and I will put in parallel the laparoscopic video, and I will tell you what later. So what we do mainly the same technique of the double flap of Takeshi. So you see we open clearly the cavity to have a landmark. We preserve at least 1 centimeter of tissue at the level of the cavity, but at the level also of the serusa. I use myself, but this is myself, mainly the knife because I have no smoke and I have a very clear vision of my zone. You see very here where you can make the difference between the adenomyotic layer and the normal layer, and you can, in my opinion, better adjust the debulking to the pathology. So this is what we do, or you do it in 2 pieces, 3 pieces, 4 pieces, it's not a problem. And what is important is to save at least 1 centimeter margin on both sides of your debulking, on the side of the cavity and the side of the serusa, as you see here. And then you have to reconstruct. And obviously you see there is no bleeding because we clip all the vessel. We clip the uterine artery at their origin. We clip all the vessel that goes to the uterus. And we also use, concomitantly, we use also vasopressin because then we can have this dry. And then we reconstruct. The first thing is to reclose the cavity. We use barb suture that now have obviously facilitate the Z. So we close the cavity and then we close in double flap. So you can use the same blade we have used to remove the serusa and to increase the capacity of healing. Then we make an internal layer to avoid the dead space on the first flap before to finish to fold the first flap on the edge of the other one, and then we flip the next one. I let at the same time the video of the laparotomy, you see that we are really mimicking the same. Here in laparoscopy, we finish the second flap, and then we will do the same adhesion prevention by either powder. I like better to put Interseed to cover my barb because I always am afraid that the barb will come and stick to the barb, even though the barb is not too apparent. So this is the final result. We use powder for the cul-de-sac, and we are going to use an Interseed to cover our scar. So the result is good. And I must say that when you see the pre-op MRI and the post-op MRI, it's interesting. Another case, we do the same. This is the post-op vision. So you see clearly an improvement, and we have a quite good result. Alors, when you say that, I want to show you just this video, just to show you how we prevent the bleeding before we use. So we use vasopressin plus vasopressin plus the ligature of the two. And here we can do with the harmonic energy. I like less, but we also open the cavity and then we reconstruct. This patient got pregnant spontaneously. You have the first baby. And here I put, by chance, I saw this patient yesterday, and you see the second pregnancy starting. This is a picture I took with my iPhone yesterday during ultrasound. She's also pregnant for the second time. I am a little bit worried for the second time because the implantation is close of the placenta, is close to the place where we have done the resection. So we are going to follow that with a prudent manner. We have the cystic adenomyosis, which is mainly on young patients. And so what we do a resection. So here I just thanks Dr. Pistofidis to borrow me this video because I didn't find one good case. So you see, we do a resection. We remove totally, it's quite easy technique, like an endometrioma, and the post-op and the fertility are very good on that. And probably picture that I also borrowed to Dr. Campo, and then to show that Nowadays, with the mini resectoscope that you see on the right side, we can do easily a diagnostic and resection on the crypt and on the implant of adenomyosis, as you see here. So what about results? And you see that when we look at symptoms and not at fertility, we are quite efficient. We are quite efficient on menorrhagia, and we are quite efficient on dysmenorrhea, and we are quite stable within the time. Those are results from an hysteroscopy treatment, and it seems to be that the combined surgical plus medical treatment works better than surgical alone or medical alone, and so this is always a combination of both. This just to tell you that for laparoscopic treatment, you see that the complete excision are obviously what we do by laparoscopy are more severe case, less focal case compared to hysteroscopy. So results are a little bit less, and complete excision is obviously better than partial excision as the data. In terms of fertility, very interesting. You see the result that the total pregnancy rate of this cumulative series of mainly Japanese people published by the Danish team from Aarhus shows a total pregnancy rate of 47%, which is, in my opinion, a little bit low, because when I look, if you come back, look, the numbers are very low. Like we have a very low number for the moment because we follow them and we are very prudent. So actually we have a little bit more, but this is the number we had few years ago, 2 years ago. So you see that we got 80% of pregnancy rate in our series. On what we got one intrauteral fetal death at 22 weeks, one uterine rupture, and you see that the term of the preterm ratio is quite high, because it's almost 50% of the baby are delivered around 32 to 33 weeks. So what is the risk? Because this is the problem. What is the risk in fertility in obstetric? And this is something we should discuss and we should follow. The risk is the rupture with the eventual death of the baby, eventually death of the mom, or the loss of the uterus. So I mean that when you try to look what are the factors that may influence the risk of rupture, you have the use of energy, obviously, electrical energy, and you have laparoscopy. So it means that laparoscopy may be a factor that leads to one of those complications. But look, the list of complications in obstetric: preterm, rupture of membrane, malpresentation, abnormal placentation, high rate of Caesar, PPH, etc. So I mean, we have a lot of pathology that we should think and we should inform our patient before we do the surgery. And so this I don't have time, but this is the case at 25 years. This is one of my case. Patient with an adenomyoma. I did the adenomyoma. Unfortunately, the patient ruptured at 25 weeks. The baby died, and the mother lost her uterus. So when you have this type of experience, you try to look. The first thing you observe is that rupture is a little bit earlier compared to myomectomy. So it's more 25, 30 weeks than 30, 32 weeks. And so it's unpredictable, it's silent, and you have, for the small experience we have, not too much pain. So we have to pay attention. And again, the frequency of uterine rupture after laparoscopic adenomyotomy seems to be higher compared to laparotomic adenomyotomy. So it means that there is still a place for laparotomy, and we have to observe this, or we have to improve our skill and to avoid rupture, knowing the risk factor, which are the size of the lesion, the quantity of the debulking, the energy used, the technique of reconstruction, the infection, hematoma, and the time that you wait for the pregnancy. We have a lot of limit, and probably the main limit we have in laparoscopy is not only the capacity of suturing, but the tactile sensation. So it means that this is where the surgeon experience play a role, and that's why a lot of laparoscopists now say that combined laparoscopy, when necessary, mini laparotomy are relevant to treat those patients. And a lot of good surgeons by laparoscopy, experienced surgeon laparoscopy, actually do so, and I think is not totally wrong. So we need an adequate diagnosis. We need to integrate surgical and medical treatment. Probably surgery is better for focal form. We are still doing cytoreductive surgery if we have failure on heart, if we have failure on implantation, or if we have failure on any technique to make this patient pregnant. Surgery has no impact on fertility for older patients. So again, this is what I've been told before by Dr. Barry, and this is true in the same. So don't do this surgery, which is dangerous for patients which are too old. This is not a cancer. Radicality is an illusion. And so for the diffuse form, we still have to work, and the best approach is yet to come. And so on that, you see, and this is the conclusion, and I think I am on time. So it means that if you see what I just mean, so it means that you can place your surgical decision within a sustainable program. And this is what we are going to talk next year in February in Endo Dubai, where I invite you. And thank you again, Leila, for your kind invitation. I'm very glad to be part of that. Tomorrow I will be there again, and I hope I answered to your question. Thank you.
Thank you very much, Professor Vatiers. Yes, tomorrow there will be a live surgery in the morning. Thank you again for being part of our team, a big part of our team, in fact. Thank you very much. Dear colleagues, we continue the plenary meeting, and Professor Kawamura may get connected at 13:20 in 20 minutes. So I will try to make my presentation right now, and I will finish this presentation on time. The title is Premature Ovarian Failure, a Multidisciplinary Problem, the Role of Surgeon and Surgery. Well, dear colleagues, why this problem of POF is interdisciplinary? Together with Victoria Dementieva, my student, and other staff from the Kolokov Center, and by the way, our director was also involved in this subject as a scientist, as a geneticist. Well, we just invited those patients who were not operated by other specialists when they could not be sent to IVF, when there was no egg donation, nothing like that. And we realized that the psychological stress plays an important role. Iatrogenic factors are also important. Infection is important. Genetic factors are important. And we decided that this should be an interdisciplinary approach to treating POF. Therapists should be involved, endocrinologists, specialists in reproductive medicine, oncologists, geneticists, medical psychologists, microbiologists, immunologists, and if all these specialists do not work, in this case, the patient should be sent to surgery. The ovarian reserve can be spontaneously low due to genetic autoimmune defects, viruses, well, stress, and iatrogenic reasons. When there is chemotherapy or operations on ovaries or radiation therapy is involved. And here I should say that surgery on ovaries, especially on women with endometrioid cysts, can not be training procedures. That's not possible because we know that the ovarian reserve in patients with endometrioid cyst without surgery is usually low, and the quality of eggs is not as good as we think. The age of manifestation of POF is 9 years earlier than in mothers of such patients. We studied the family history of such women because it was a serious research study. Different authors also conducted studies, and events leading to social stress were marked during 1 year before the menstrual cycle stopped. It was also proven that the symptoms of anxiety in women with premature ovarian failure occur rather often, and it's very difficult to see such women once a week at the Kolakov Center. I see patients, and usually there are 4, 5, or 6 patients out of 40 or 50 come with the request to restore the ovarian function when the AMG is less than 0.5, and even those who did not have any surgeries. It's a very sad picture, but we must do something about it. The connection with genetic disorders, congenital malformations, that's another story, especially those patients who had congenital malformations. And right now, we are preparing a new dissertation on the subject. Dr. Antonova is studying the immunological aspects, and thanks to the immunological results obtained at our lab of genetics, our Kolakov Center is the leading organization in Russia. We hope we'll find new mechanisms that will allow us to open up this Pandora's box and find out why POF, premature ovarian failure, occurs. There were also genetic disorders in every third girl with POF, although there was no family history of such diseases. We discovered such malformations, uterine malformations, by chance. In most cases, what should be the modern approach to treating women with POF? First of all, hormone replacement therapy, HRT, is the foundation of treatment. There are different methods of activation of primordial follicle activation using specific activators, and I will show you this in next slides. When we went to Japan to Professor Kalamura, and also we were before that in Spain, in Italy. My daughter studied this problem in the US. We studied this problem from a different angle, namely how we, obstetricians, gynecologists, and surgeons can help patients with POF. We're very grateful to Kazuhiro Kawamura because he said, of course, it's not a panacea, but we can solve this problem at least partially. And of course, well, everything depends on surgical methods and on the hands of the surgeon. There is a lot of information in literary data whether hormone replacement therapy works or not. Yes, HRT works, but without stimulation, there is no effect, even if you administer HIT. What's the role of the biomechanical force and folliculogenesis signals, their impact on the regulation and fertility? Mechanical forces play an important role in the regulation of the cascade of molecular signals. Changes in this context will determine poor folliculogenesis and lower the potential for oocyte development, which occurs in pathological conditions, not only in case of POF, and they can lead to the development of POF. The slides you see are absolutely new. They are high-tech. My grandson, Edik Osipov, helped me do this. Before that, Victoria Dementьeva provided me these slides. So what's the role in terms of relations? Well, gonadotropin in case of POF in independent stage can be part of the surgical impact. Gonadotropin dependent stage, well, they should be treated using HRT or ART. The activation of primordial follicles in vitro can be different, dear colleagues. In our case, we do the fragmentation of ovaries, we do a biopsy. Biopsy of this part of ovary is a must. We send them for frozen section for histology to avoid any oncological risks or pathologies. We just take women who are thoroughly tested. Well, this is my baseline slide. Why did I want to make this presentation before Professor Kazuhiro Kawamura is going to speak? Because thanks to Professor Kawamura, we believed in this method. 127 patients with poor ovarian response and poor ovarian failure have been tested at our department, and we obtained very good results, and we got our own patent. And before that, we had studied the works of all these gentlemen. You can see the inclusion criteria. First of all, FSH, high level, AMH 0.5 and less. Well, lack of surgeries on ovaries, and age up to 30, maximum 42 years. The average duration of our surgery is about 1 hour. The blood loss, almost no. And if you look at these ovaries, if you do not know that these are ovaries, they look like brain hemispheres without any signs of ovulation, corpus luteum, etc. The idea of the surgery is incision of the cortical layer, dividing them into 100 pieces, and reimplantation without the use of any energies. We conducted two very important studies: the morphological assessment of follicular apparatus in patients with poor ovarian reserve and the assessment of endometrium using immunohistochemistry and morphology. We identified the presence of the superfluous epithelium on a huge area of ovaries. Before that, it wasn't detected. And I should say that the longest duration of the disease correlates with the previous treatment. In case of immunohistochemistry of markers, the conditions of ovaries and endometrial tissue, we obtained new data that were later published. Here you can see they were published in Russian journals and in foreign journals. The presence of expression and the level of expression shown here in endometrial samples in patients with poor ovarian reserve were higher as compared to those who have normal indicators. As for literary data, well, there are gonial precursor cell-derived autologous mitochondria injection to improve outcomes in women with multiple IVF failures due to low oocyte quality. It was shown that out of 10 women who had the embryo transfer, 4 had a clinical pregnancy occurred, and they gave birth to children. Another study, autologous mitochondrial transfer as a complementary technique to ICSI to improve the embryo quality in patients undergoing IVF. It showed that 17 children were born, and these children had better results, and women had better results after IVF as compared to women who were not sent for IVF. Children had no pathological changes. The use of stem cells in case of POF. I hope that our director, Professor Suhik, who is the champion in the field of the study of stem cells, and I've known him for 30 years, and the Kolokov Center has conducted wonderful studies, and some of the authors, including Professor Pellissier showed that 30 days after the injection into the ovary, the injection of stem cells into the ovary, there are signs of the proliferation of corpus luteum. We put a lot of hopes on these studies. As for future clinical use, the use of allogenic mesenchymal stem cells in the premature ovarian insufficiency mouse model, as you can see it here. The authors were very concerned whether the stem cells will spread beyond the ovaries. The data were obtained by our Japanese researchers. They were primarily in the tissues of the ovaries. Stem cells did not migrate into other organs such as lungs or the heart. Well, also extracellular vesicles. This is a congress. This is not a training course, so I'm just going to show you what is already in literature. Our center began to conduct such studies. It was noted that when extracellular vesicles were introduced, there was a significant increase in the number of primordial, primary, and secondary antral follicles on the 4th week after the intervention. With the use of PRP, well, for women with POF, again, many authors conducted such studies, including our center. Well, platelet-rich plasma induces cellular proliferation and the differentiation, as well as angiogenesis and regeneration. 23 women had pregnancy achieved. It was spontaneous pregnancy. 100 out of 101 had antral follicles developed, and there were IVF attempts taken. In 27% antral follicles were absent. That is why these women did not get any additional treatment. The restoration of the ovarian function after the biopsy, the so-called scratching, in patients with POF, I do not believe a lot in this method, but anyway, I think that if any intervention is elegant, it can improve regeneration and increases the efficacy of the therapy. 80% of patients with POF during laparoscopy got ovarian scratching, and 11 of them, 13.75%, had the restoration of the ovarian function. Dear colleagues, we must try to do our utmost to help these poor women. Today, we're talking about different things. 396 studies were devoted to premature ovarian failure and autoimmune diseases. We can see there is a key to solving these problems. Here you can see another dissertation. At our center, it will be devoted to interdisciplinary approach, because right now, even ASHRA and us are conducting routine studies and screening for antibodies to thyroperoxidase, and we can see that congenital immunity is very important here. Screening for autoimmune diseases should be conducted on a regular basis. We've already done it for all women with POF, premature ovarian failure, and autoimmunity. Well, we do not know at this point whether immunodepressants should be administered or not. Well, how to improve immunity, maybe some activation should be involved. We are waiting for the results of our own studies. I'm absolutely sure that there will be a solution to this problem. There have been a lot of studies about the role of the vaginal microbiota associated with primary ovarian failure. Yes, we're talking a lot about microbiota. At our center, there is a program devoted to microbiota. If vaginal microbiota plays an important role, if it is associated with POF, then we'll be able to solve this problem if there is an association. There are other studies as well. I would not like to go into detail, like here you can see a concrete study, but we would like to say that we must monitor those patients who have early POF. And now, in order to demonstrate the results of our center, I do not know if this will be mentioned in other presentations or not. We have an alliance between a gynecologist and oncologist. There are lots of patients who have had gynecological surgeries and oncological surgeries at the same time. There are also patients who right now have different cancer diseases, such as cervical cancer, breast cancer, and they want to become pregnant. And I'm very happy that I also made some particular contribution to helping such women. 4 years ago, we did a surgery on that, and 2 years ago, we operated on a woman who, during the surgery, that was a laparoscopy, and Professor Nazarenko asked me about this. So during the surgery, we did the puncture of 3 follicles. We got 3 embryos, and while the patient was on the operating table and her husband was ready for sperm donation, we got 3 wonderful embryos. As for pre-implantation genetic testing, PGT is also important. But I would like to say a few words about PGT and POF. In my life, I saw patients with endometriosis, myoma, hyperplasia, different malformations, etc. But believe me, please, there is a huge cohort of patients who need our help. And as for what we can do for them. First of all, verification of the diagnosis, exclusion of concomitant diseases, while also identifying the reason for POF, diagnosis of other reasons of infertility, the histology study, and a new view on this pathogenesis. So I am waiting for Professor Kawamura's presentation. I wanted to speak before him just to give you a brief preview on what has been done in Russia. And I should say that it's wonderful that twice a year, well, at the Kolokov Center, where Professor Suhik is our director, we can get together. We have 60 colleagues from foreign countries participating in this Congress, and these are the stars of medicine. Thank you very much. And now the floor is given to Professor Kawamura. Dear Professor Kawamura, dear Kazuhira, I exceeded my time 2 minutes, but please make your presentation. I know you're in a hurry for the airport. Please, the floor is yours. Professor Kazuhira Kawamura, ovarian rejuvenation and new techniques for fertility treatments of ovarian dysfunction. He's a professor of the Department of Obstetrics and Gynecology and Reproductive Technology in the field of food and reproductive function of the Department of Medicine at Tokyo University. Please, the floor is yours, and thank you for your contribution to science. Please.
Your really great introduction. So I really appreciate you for giving me this opportunity. And today, as already introduced, my title is the Ovarian Rejuvenation and New Techniques for Fertility Treatments of Ovarian Dysfunction. So here's the COI. And, if we think about the ovarian rejuvenation, the fertility preservation is one of the potential methods. So now I'm going to introduce a couple of the options of fertility preservation for ovarian dysfunction patients, like DOR patient, POF, POI patients. Okay, so one most established approach is an oocyte embryo cryopreservation. Of course, the ovarian function, ovarian reserve, continue to decline, and it's always progressive. So we have to do the cryopreservation of the oocytes and the embryos before the severe condition of low ovarian reserve. but we can do it. But this method has some difficulties. One is a difficulty in correcting a sufficient number of the oocytes and embryos to guarantee one baby in those cases, and difficulty to conduct in patients with severe ovarian dysfunction who does not respond to the standard ovarian stimulation. Then we developed this in vitro activation approach, ovarian tissue cryopreservation followed by in vitro activation, IVA. So Leila already, introduced our approach in detail, but again, I'd like to briefly introduce a technique. So the first step is an ovariectomy under laparoscopic surgery. So at the beginning, we removed both sides of ovary to prove it is really scientifically working. Now we just remove one side ovary because ovarian tissue, one side ovary is already good enough. Then we can do the cryopreservation of ovarian cortical tissue. So now we are using a vitrification method. And during the cryopreservation, we can confirm the presence or absence of the residual follicles by histology. And after confirmation of presence of residual follicles, then we saw the ovarian tissue and cultured with PI3K activators to activate dormant follicles. And then we are going to do second surgery, laparoscopic surgery, or transplantation of ovarian tissue. And then we can do IVF ET treatment. Here I'm showing the localization of our follicles in a human ovarian cortex. So as you can see, within 1 to 2 millimeter thickness, all early stage follicles are located. So, but the large antral follicles are located deeper, more than 2 millimeters. So that's why in IVA approach, after removal of ovary, so we removed all the medulla part because they don't have any residual follicles. And then we prepared the cortical stripe like this, around 1 centimeter square. And using a small portion of this, individual ovarian tissue, we are doing the histological analysis. And then after that, after correcting these ovarian stripes, then we can do the vitrification for ovarian tissue cryopreservation. So at that time, we developed this cryo support device, and using this device, we can do the vitrification approach. And now this one is already commercially available from Kitazato, Japan. Then we had our first baby in 2013, and then we have a series of the publications. And in this IVA approach, of course, the process is effective in the severe cases, even severe cases, no need to perform ovarian stimulation to retrieve oocyte at the timing of the fertility preservation. But in an oocyte embryo cryopreservation, they need to receive the ovarian stimulation, they need to the oocyte pickup, but for tissue cryopreservation, the patient do not need to do this ovarian stimulation. But cons, so of course it is more invasive as compared to oocyte embryo cryopreservation. Then I'm going to share with you our results of the new technique. Actually, in the title, new techniques, but due to the shortage of time of presentation, I'm just going to show the one technique. So what we have done is in vivo administration of mTOR, mammalian target rapamycin inhibitor. So this is a basis for the IVA because this PI3K signaling pathway is very important to activate dormant primordial follicle. So that's why we use the PI3K activators to stimulate this signaling and then suppress FOX3 activity. Then primordial follicles are start to develop. So we use these drugs, P10 inhibitor and PI3K activator to activate the PI3K signal. Actually, for the activation of dormant primordial follicles, there is another pathway. This is a mTOR pathway. So actually, activation of this mTOR pathway promote primordial follicle activation. So the first we used rapamycin. This is the inhibitor for this mTOR signaling pathway. So we first used this rapamycin to try to suppress this mTOR signaling. So this one, the PS6K, this one. This one is one of the marker for the activation of mTOR signaling. But as you can see, if the animals were received 21 days of the injection, the mice at 21 days of the age received 3 weeks the long term in the injection of rapamycin, and then removed the ovary, and we checked the suppression of the PS6K. So you can see it's really suppressed. Then we checked the histological dynamics. So as you can see, as we expected, the rapamycin treated group had 15.4% more primordial follicles and 7.6% more primary follicles, but fewer late secondary and pre-ovulatory follicles. So this means the injection of rapamycin suppressing the activation of the primordial follicles. So if we check the histological specimen, then show the rapamycin treatment also led to more early secondary follicles and fewer antral and pre-ovulatory follicles. In particular, it is important, degenerated follicles are not found in ovaries with rapamycin treatment. And we also checked the FOX3 localization. FOX3, this one, as already mentioned, known to localize in oocyte nuclei before the activation. Okay, this molecule should be localized in the nucleus before activation. And after activation, it translocates to the cytoplasm of primordial follicles. So as you can see, we found nuclear FOX3 localization in primordial follicles of ovaries with rapamycin treatment, whereas the cytoplasmic translocation of FOX3 was detected in all sides of growing follicles of untreated mice at day 10 of age. So that means rapamycin is really effective. So then we have done this type of IVF experiment. So mice at 21 days of age were administered with rapamycin or VIC for 3 weeks, followed by the injection of 5-IU, PMC, and then HCG for ovulation induction. And at 14 hours after HCG injection, ovulating oocytes were collected and IVF was performed. And fertilized oocytes were cultured for 3 days to allow their development up to the breastfed embryos. So here you can see almost half, 50% per decrease in ovulating oocyte number was observed in rapamycin-treated mice. However, there was no significant differences between the fertilization rate and breast formation rate in control and rapamycin-treated groups. So then we try to check the recovery of ovulation by cessation of rapamycin treatment. So to test if ovulation rates recovered after termination of rapamycin treatment, ovulatory potential and also competence were evaluated 3 weeks after the termination of rapamycin injection. 3 weeks actually in mice from primordial stage to pre-ovulatory stage takes 3 weeks. So that's why we chose 3 weeks for the recovery of this, the activation of primordial follicles. So as you can see, the ovulated oocyte number recovered perfectly to the same level as the control group. The quality of the oocyte derived from rapamycin maintained primordial pools was same as the control group. Fertilization rate is the same, breast formation rate is the same. Then we performed translational research using a human sample. So ovarian cortical samples were obtained from the patient with an ovarian dysfunction. And ovarian cortical sheet around 1 centimeter with 1 millimeter thickness was cut into small cubes, 1 millimeter square, and transplanted under the kidney capsules of SCID mice, severe immunodeficiency mice, to avoid a rejection between human and mice. And then the animals were treated with rapamycin every other day for up to 4 weeks. And then at 2 and 4 weeks after rapamycin treatment, ovarian grafts were dissected for the histological analysis. So this is a result. So ovarian graft weights were lower in rapamycin treated group as compared with the control at both 2 and 4 weeks after direct treatment due to likely maintenance of follicles at early stage of development. So we have also checked the histology. So actually higher percentage of the human primordial follicles are present in rapamycin treated mice compared with control at both 2 and 4 weeks after rapamycin treatment. So this means the follicle are less at the primordial stage. So even in human samples, we can suppress the activation of the dormant primordial follicles. Well, in this experiment, up to 4 weeks, maybe much longer, we can do it. So here's my conclusion. So our studies provide the basis for the further studies on the possibility of using mTOR inhibitors to maintain a follicle reserve in middle-aged women and cancer patients before during the germ cell damaging therapies. So this is my slide. Thank you for your kind attention.
Дорогой профессор Кавамура.
Dear Professor Kawamura, thank you very much for making it possible sharing your new data with us. If I can, I have a couple of questions. Tell me, please, why did you study rapamycin? What made you study rapamycin? Why rapamycin gives you more encouraging data than what you did before? Why rapamycin?
Actually, there's a couple of the different types of mTOR inhibitors, but rapamycin is already commercially available drug. So I thought like a drug repositioning. So using the rapamycin is, of course, it's an immunosuppressor. So people using it for immunosuppression after, for example, lung transplantation or whatever uterine transplantation. But in addition to such, let's say, immune suppression, this drug may be able to use for the suppression of the activation of dormant follicles. So that's why I thought this is easy to adapt, try to do the clinical trial, easy to do the clinical trial, and for future suppression of activation primary follicles. So this is a reason why I focus on the rapamycin.
Professor Kawamuro, now Victoria and I and Volodya visited your center, and you somehow very much encouraged us that what we do, especially because you know the technique of our operations, you know what we do, and we got good results, good effects. 27 pregnancies. The director checked each pregnancy, whether the patient felt pregnant or not. Thank you very much. Where do we go next? My impression is like this. My impression is in those girls who were not operated, who were not receiving chemotherapy, who didn't have genetic defects, a major effect of stress, autoimmune thyroiditis, and something that does not really, is not relevant to surgery. Surgery operating we shall continue because we got good results, but probably because during surgery we look at what other reasons could exist for maybe endometriosis comes into play, anomalous or uterine defects. We do get comprehensive therapy, not only for PCOS. Maybe we did something, maybe we'll do something together. Maybe if we can, especially the possibilities of our center are great. Our director indeed is a huge immunologist, geneticist. What do we do next? Do we move towards stem cells, or should we study immune disorders, or shall we study genetics? Given that you know somewhat better this technique rather than us, especially with Professor Hugh, who works in America, and my daughter is involved in this there. Where do you think the future of this problem lies? What's your take on this?
Yeah, actually, I think the best way is regeneration of oocytes from like iPS cells or even sperm we can regenerate, right? But the major issue is an ethical barrier. So actually, it's a little difficult to say this is a very safe method, you know. So we can do so many genetic studies, whatever we can do, but we cannot, you know, perform the 100%. We cannot give you the 100% safety. But this is the same as, for example, even ICSI, still we don't know the baby derived from the after the ICSI, if he or she developed the old woman or man, something will happen. So that's why our field, it's always very difficult to completely, you know, confirm the safety. But well, people try to regenerate an oocyte, a sperm in a human. So I hope, maybe I believe. So in future, I don't know, 10 years ago, 50 years ago, maybe our human can generate from the iPS cell. So this is one, actually one, in a sense, one complete solution. But other ways, like you know, people doing a stem cell injection, you introduced, you know, PRP injection. Well, sometimes works, sometimes doesn't work. And even my IV approach, if the patient has no residual follicles, it's not effective. So that's why for me, the ideal approach is regeneration oocyte and sperm from the iPS cell. So, but you know, there's so many ethical barriers, and also all the cost is also another issue. Yeah, but in future.
Огромное спасибо.
Thank you very much for your time, for your honesty in scientific research that you do, and in what we can say that indeed we are partners here in this very narrow range of reproductive medicine. All the best, all the best. We know you're at the airport. Have a safe trip, and I hope you will enjoy your trip. Thank you very much. Thank you very much for being with us. Dear colleagues, well, dear colleagues, Japan is staying with us online. Professor Kenichiro Hiraoko. When we traveled to visit Professor Kawamura with our team, Victoria, Valodz, and I, we visited Professor Hiraoka. And we looked, it was many years ago, at his time-lapse camera and how he's doing immediately like IVF. Even at that time, what he showed to us that head first or tail first, it was an amazing theatrical performance, amazing show. It is particular for this reason, Professor Hiraoka, Vice Director and Chief Embryologist of Medical Center Komeda in Japan. Injection of head first or tail first injection. What works better for ICSI? Thank you very much for being with you. You have 20 minutes to go. Please, Professor, the floor goes to you.
Thank you very much for your kind introduction, Dr. Lader. Good afternoon, ladies and gentlemen. I'm Kenichiro Hiraoka from Japan. I appreciate that Dr. Layla invited me to talk at this international conference. I met with Dr. Layla 5 years ago here in Japan at our laboratory. Since then, I have been learning many things about assisted reproductive technology from her. Thank you so much, Dr. Layla. I appreciate it very much. I have no financial conflicts of interest to disclose concerning the presentation. Let me introduce myself. I'm not a nurse or a medical doctor. I am an embryologist. The main job of an embryologist is to take care of sperm and oocyte and support patients to become pregnant. The topic of my presentation is intracytoplasmic sperm injection. This is one of the insemination methods in assisted reproductive technology. One of the important jobs of an embryologist is to assist the fertilization of oocyte and sperm. There are two insemination methods in assisted reproductive technology. The first method is in vitro fertilization, commonly known as IVF, as shown in the left movie. In this method, the sperm goes into the oocyte by itself. The second method is intracytoplasmic sperm injection, commonly known as ICSI. In this method, the embryologists select the sperm and inject the sperm into the oocyte. In the IVF, the cumulus oocyte complex is cultured with sperm. The sperm swim toward to the cumulus cells. After the sperm head attaching the cumulus cells, the enzyme is produced from the sperm head. The sperm dissolves the cumulus cells and approaches the zona pellucida. After sperm head reaches the zona pellucida, the sperm passes through the zona pellucida and membrane. The starting point for fertilization with IVF is the sperm head. That's why when learning the ICSI, the embryologist has been taught to inject sperm head first all over the world. However, the ICSI bypasses, However, the ICSI bypasses the process of passing through the tumor cell, penetrating the zona pellucida and the membrane. The embryologist remove the tumor cell, make a hole in the zona pellucida, break the membrane, and inject the sperm directly into the oocyte by using the ICSI needle. So we may not need to stick to head-first injection when doing ICSI, and it is possible to fertilize the oocyte and sperm by injecting the sperm tail first. However, when comparing the head first and tail first, little information is available whether which is better for ICSI. So I attempted to answer this question from these three perspectives: sperm aspiration, normal oocyte ICSI, and fragile oocyte ICSI. The first perspective is sperm aspiration. Before doing ICSI, we immobilize the sperm by scratching the sperm tail with an ICSI needle. In the left movie, when injecting the sperm head first, we use the ICSI needle to aspirate the sperm from tail, as shown in the left movie. Then inject the sperm head first. On the other hand, in the right movie, when injecting the sperm tail first, we use the ICSI needle to aspirate the sperm from the head. Then inject the sperm tail first. Before aspirating the sperm into the ICSI needle, we aspirate the sperm from the right side of the sperm. When aspirating sperm using a head-first injection, it may be more challenging to aspirate them quickly because the tail tip is smaller than the head. This is not as much of a problem with a tail-first injection. So I investigated the sperm aspiration time into the ICSI needle. The movie in the left shows the sperm being aspirated from the tail. Then inject the sperm head first. On the other hand, the movie on the right shows the sperm being aspirated from the head. And then inject the sperm tail first. This chart displays the average time it takes to aspirate sperm when done head first versus tail first. Significantly shorter sperm aspiration time was observed in the tail first. This result demonstrated that the tail first is faster and easier because of the bigger size of the sperm head than of the sperm tail. When doing ICSI, we noticed two types of oocytes, normal and fragile. The normal oocyte has a strong membrane. After fully stretching the membrane, we artificially break the membrane by applying the piezo pulse. However, the fragile oocyte has a soft membrane, so spontaneous membrane breakage occurs while moving the ICSI needle. I previously investigated the ICSI damage rates between normal oocytes and fragile oocytes. This movie shows an example of an ICSI damaged oocyte. The oocyte loses its membrane and collapses. The ICSI damage rate of normal oocyte was 0.0%. However, the ICSI damage rate of fragile oocytes was 5.2%. As you can see, the normal oocytes survived 100% and only fragile oocytes died after ICSI. This is one of the concerns of the fragile oocytes. The second perspective is normal oocyte ICSI. I investigated the effect of head first versus tail first on the ICSI results for normal oocytes. I compared the ICSI damage rate, normal fertilization rate, not fertilization rate, abnormal fertilization rate, and good quality day 3 embryo rate. I'm gonna explain these comparison items with the movie. This is an example of an ICSI damaged oocytes. This oocyte loses its membrane and collapses. This is an example of a normal fertilized oocyte. 2 pronuclei can be seen within the cytoplasm. This is an example of not a fertilized oocyte. No pronuclei can be seen within the cytoplasm at all. These are samples
слайды
of
не меняются? Слайды,
Sorry?
посмотрите, почему у человека не меняются.
Sorry, the slides seem to be frozen. Something is wrong. The slides are frozen. We're still on the slide. ICSI damage rate, normal versus fragile.
Oh, really? Okay.
We are still on slide 32.
ICSI damage?
Yes, 32, slide 32. We are stuck at slide 32. ICSI damage rate, normal versus fragile. Normal oocytes survive 100%, only fragile oocytes died. Slide 32, we're stuck there.
Алло.
Yes, hello, hello.
Oh, sorry. Oh, here. Okay. From here, do you see?
Yes, we can. Thank you. Thank you very much. Yes, we can.
Okay. I'm so sorry. Okay. I investigated the effect of head first versus tail first on the ICSI results for normal oocytes. And I compared the ICSI damage rate, normal fertilization rate, not fertilization rate, abnormal fertilization rate, and good quality day 3 embryo rate. I'm gonna explain these comparison items with the movie. This is an example of an ICSI damaged oocyte. This oocyte loses its membrane and collapses. This is an example of a normal fertilized oocyte. 2 pronuclei can be seen within the cytoplasm. This is an example of not a fertilized oocyte. No pronuclei can be seen within the cytoplasm at all. These are examples of abnormally fertilized oocytes. The left movie shows an example of 1PN. Only 1 pronucleus can be seen within the cytoplasm. The right movie shows an example of 4PN. You can see 4 pronuclei can be seen within the cytoplasm. This is an example of a good quality day 3 embryo. After showing 2 pronuclei, the embryo cleaves and increases the cell from 1 to 2, 2 to 4, and 4 to 8. On day 3, after oocyte collection, the embryo with more than 7 cells and less than 10% fragmentation was classified as a good quality day 3 embryo. This is an example of a head-first injection. After making a hole in the donor, immerse the ICSI needle in the cytoplasm. Then break the membrane and inject the sperm head first. This is an example of a tail-first injection. After making a hole in the donor, immerse the ICSI needle in the cytoplasm, then break the membrane, and inject the sperm tail first. The trick of this tail-first injection is to inject only half of the whole sperm. This chart compares the impact of sperm head first injection or tail first injection on normal oocyte ICSI results. The blue bars represent the head first results, while the orange bars represent the tail first results. At the beginning of the chart, both methods had a damage rate of 0.0%. In terms of normal fertilization rates, the tail first produced significantly better results than the head first. However, no significant difference was noted for not fertilization rates and abnormal fertilization rates. Finally, the tail first resulted in a significantly higher percentage of good quality day 3 embryo compared to the head first. The third perspective is fragile oocyte ICSI. I investigated the effect of head first versus tail first on the ICSI results for the fragile oocytes. This chart compares the impact of sperm head first injection or tail first injection on the fragile oocyte ICSI results. The blue bars represent the head first results, while the orange bars represent the tail first results. At the beginning of the chart, no significant difference was noted in the damage rates. In terms of normal fertilization rates, in the tail first produced significantly better results than the head first. However, no significant difference was noted for not fertilization rates, abnormal fertilization rates, and good quality day 3 embryo rates. I investigated to answer this question from these 3 perspectives. From the first perspective, sperm aspiration, significantly faster sperm aspiration time was noted in the tail first than the head first. So the winner of this perspective sperm aspiration is the tail first. In the second perspective, normal oocyte ICSI, significantly higher normal fertilization rate and good quality day 3 embryo rate were noted in the tail first than the head first. So the winner of this perspective, normal oocyte ICSI, is the tail first. In the third perspective, fragile oocyte ICSI, significantly higher normal fertilization rate was noted in the tail first than the head first. So the winner of this perspective, fragile oocyte ICSI, is the tail first. This movie shows the procedure of head first injection. It looks like a perfect sperm injection. However, If we look carefully, almost the whole sperm is outside the oocyte. Like this. After the membrane is recovered, some sperm may be gradually pushed out. I believe that this could be one of the reasons why the head-first injections have a lower fertilization rate. This movie shows the procedure of tail-first injection. The trick of the tail-first injection is to inject only half of the whole sperm. Sorry. So after the tail first injection, half of the sperm is injected into the cytoplasm. In other words, half of the sperm is mingled or fused with the cytoplasm, like this. Therefore, the sperm stays inside the cytoplasm even if the membrane regained. I believed injecting half of the whole sperm by a tail first injection is one of the causes of higher fertilization. In conclusion, my answer to this question, head first or tail first, which is better for ICSI, my answer to this question is the tail first. Thank you very much for your time and attention.
I never thought, my dear colleague, that we will be dealing with such a serious issue, tail first or head first. We clearly understand that tail first is always right, is always better. And could you tell us just one sentence, why it is tail first, why it is more preferable? Yes, half of that is inside the cytoplasm. Please tell us why, how to make that everybody is mastering the tail and not spoiling the head of the spermatozoa, please. Why tail? Why tail?
Why tail? This is head first injection is a little bit difficult. We have to pay many attention, but for tail first injection, we have to pay attention less than the head first. The head first is difficult for me. So if we inject the head first, maybe half size of the sperm, we have to inject much more volume inside the cytoplasm. But tail first injection, the tail is really small, and so there's no need to put the much more volume as compared with head first.
Мне очень понравилось.
I really like your answer, and you strongly recommend that we have to keep head safe. Tail first is better, so it's better protruded into the cytoplasm, and then the head right into the privileged position, more preserved and better preserved. So thank you very much. Thank you for such a brilliant presentation, dear professor. Now we know always forever that tail goes first and then head, and then the results will be definitely better. So thank you very much. Thank you, my dear Ken. Thank you for the connection. We wish you a very good day. So, dear colleagues, and now we are welcoming Patrizio Pasquale. Oh, United States of America, Miami. Optimization of the uterus before IVF. Professor of Obstetrics and Gynecology and Reproductive Medicine, the lead of the Reproductive Endocrinology Chair, School of Medicine of Miller, University of Miami, Florida, United States. My dear Pasquale, at last you are with us, and the microphone is yours, maestro. Microphone is yours.
Thank you very much, Laila. It's always a great pleasure to participate in your wonderful meetings, and in particular this one, it's really very, very stellar with the participation of so many colleagues. So today I'm going to cover very briefly a very important topic, which is how important the optimization of the uterus is before we do in vitro fertilization. And really, it's so important that after all the work that is done in the embryology lab, and we have very excellent looking embryos, whether it's at day 3 cleaved embryos at 8 cell stage, or there are blastocysts, that they do find a receptive endometrium, so we can hope for a pregnancy. Now, the topics I want to briefly cover in these presentations are really how to assess the uterus integrity, and these are probably already, some of them already been explained. The operative part, I'm not going to do it because my talk is in conjunction with my dear friend and colleague, Dr. Carugno, that is going to be talking after me, and is going to highlight the operative steps. Really briefly describe the pathologies that we as reproductive endocrinologists look for in trying to optimize the uterus: polyps, adhesions, fibroids. Importantly, I will spend a little bit of time on this new entity, relatively new entity, that is called isthmosil. Adenomyosis is also very important for the reproductive success. And then there is still a little question mark about chronic endometritis, but I will probably not talk too much about that. I want to finish then with the so-called methods that have been proposed for many years now to improve implantation in order to proper time the transfer of the embryos. But unfortunately, as you will see, these are still unproven, and the two of them, the ERA test and the endometrial scratching, are now probably completely removed from the market. Now, why is it important to optimize the uterus? There is a variety in the pregnancy rate worldwide and the birth rate, 20 to 60%, but really the most important and unknown black box for the success of in vitro fertilization, it's the implantation. And as a quick recollection, implantation is really the rate of embryo that attach, that implant, over the one that we have transferred. So that's the definition of implantation rate. And the endometrium really is the final barrier for the embryo to survive after it's been transferred into the uterus. So how can this be optimized? Very, very briefly, it's important to know that there are profound histological changes that happens into the endometrium in the luteal phase in the so-called window of implantation, that by definition is 7 to 10 days after ovulation. So there are about 3 days after that we can consider optimal for implantation. And during this time of implantation or implantation window, there is a desvascularization with the subnuclear vacuolation, stromal edema, firming of the glandular epithelium, and there is also a neutrophil infiltration. Why? Because there is a very complex, complicated nature of the dialogue between the blastocyst landing in the uterus and the endometrial decidual tissue with the immunological component that is a key message in such a dialogue. Ultrastructurally, it's these are slides from a very fine colleague that showed how the presence of in the window of implantation, again 7 to 10 days after ovulation, of these pinopods. And these pinopods or these microvilli, how the difference, how do they develop and grow from the early secretory phase to the mid-secretory phase. And what is important is also the fact that in this diagram, I just want to show you how complex the process of implantation is, because when the normal blastocyst is finally landing into the uterus, and imagine this as the uterus surface with also the invagination, the polarity of the blastocyst that has to find the right place to anchor. And you see that in this area here, the complexity of different molecules, estrogen receptor type beta, L-selectin, so many different growth factors, and the interplay with the immune reaction, really everything has to function at perfection. It's really like a fantastic large orchestra series of events that have to allow finally the blastocyst to attach. And things can go wrong. So there are many things that can go wrong. So the blastocyst may not find the right crypte where it can go in. It can be delayed implantation, it can be a shallow implantation. All of this can lead to potential placental pathology. And all of this really stems from an abnormal endometrial reaction with the blastocyst. And we can see the effect even later during pregnancy with the abnormal placentation, with the spontaneous abortion, miscarriages, pregnancy loss, preterm birth. So all of this really look and find the reason to be in an abnormal implantation. So what are the possible way that we can check for uterus? So you know hysterosalpingogram, we always order it before we do an in vitro fertilization cycles, just to assess that there is nothing really obvious on the hysterosalpingogram. But we do it most importantly also to check the fallopian tube, even though now we are trying to remove the hysterosalpingogram with the sonohysterosalpingography that also can allow the visualization of the tube. If there is a hydrosalpinx, even though it's not specifically for uterine optimization, it is because the fluid that is into the fallopian tube, when it's so dilated and blocked, may trickle down into the endometrial cavity and render inhospitable the endometrium for implantation. So therefore, those tubes need to be definitely removed. And the sonohysterogram is really what plays a huge role in assessing and optimize the uterus, because with ultrasound alone, you can already start to suspect that there is a possibility, for example, of a polyp, of a lesion. But when you instill some of the normal setting, you can see the presence of multiple polyps, or one polyp that is a little bit larger in this screen. So these are the things that need to be addressed. And here in this paper, even though it's a little bit older, but it's so important, particularly when I do lecture to the student and resident, how the sensitivity and specificity of the sonohysterogram is so much superior than to that of the hysterosalpingogram in detecting polypoid lesions into the uterine cavity. So we have a 50% sensitivity of the HSG hysterosalpingogram versus 100% with the sonohysterogram, and so the specificity that is much higher with the sonohysterogram and the positive predictive value of a lesion much higher. So, in addition to polyps, in addition to possibility of, there is also the possibility of adhesions, and this is something that happens most often after termination of pregnancies, drastic and curettage. So, and why is important to know if there is or not an intrauterine adhesions to optimize the uterus before IVF? Well, because inflammation into the uterus and the scarring into the uterus will prevent the opportunity for that complex dialogue between the blastocyst and the decidual tissue to form, and therefore that will impair the implantation. And so the fibroid, and so the polyps, and so the isthmocele, these are all the impacting, yes? And there are many randomized control studies that they show that yes, indeed, there is a need to remove a polyp. The meta-analysis also shows that if there are submucosal fibroid or fibroid that are impinging in the cavity, they need to be removed, because depending on the size, obviously, if they are more than 5 centimeters intramural, or if they impinge in the cavity, because there is a reduction in the live birth rates when the fibroids are larger than 4 centimeters. So this is just a few examples when I talk about Asherman syndrome. Just with the scissor, you need to be very careful how to remove those, but I leave this to Dr. Carugno to go into the details. Important for me is also to highlight the problem of adenomyosis, because it is not very often that colleagues request a pelvic MRI or a three-dimensional ultrasound when they have a proof of pelvic endometriosis. And has happened over and over again that I see patients with the stage 3, stage 4 endometriosis, and they never been checked for adenomyosis. And we know now that adenomyosis clearly may impact the implantation. So therefore, we need to know before doing an embryo transfer if there is or not adenomyosis. Why is that important from a chemical or molecular biology standpoint? Well, because these are just a few examples on how particular genes, in this case the OX10 expression, is reduced into uteri tissue that has the presence of adenomyosis. And there is also change in the epigenetics, so more methylation of this OX10 gene. So women with adenomyosis, A, they have a lower implantation rate. B, they also have a higher risk of miscarriages. Now, the isthmosial is a new, relatively new entity on the block, and basically, as a definition, is now classified as a cesarean section scar defect. You can see here, how do we realize that there is a risk or there is a potential that we are dealing with an isthmosial? Because when we do a preparation of the uterus for in vitro fertilization, we start to notice that there is the presence of a fluid, yes, in the uterine cavity, or there is a fluid in the little pouch that is present here at the time of the cesarean section. You can see right here in these other images. So the prevalence after a cesarean section, one is about 20-24%. After 2 cesarean section, 56 to 84%. If a woman had a 3 cesarean section or more, you can be guaranteed almost that they will have some degree of cesarean section scar defect, or as we call it, isthmosial. So the consequences for us as reproductive endocrinologists is really on the second part of the slides, where the embryo implantation can be impaired because of this fluid that is accumulating in the cesarean scar defect and therefore may leak into the endometrial cavity. But also don't forget that there is also a risk that the embryo, once it's been transferred, may also implant in the niche, and therefore you can also have a condition called ectopic scar implantation. Now, but it's not just abnormal anatomy, what we saw so far, that may impair implantation. For example, when we talk about fibroids and leiomyoma, so there are a number of molecular biology studies that are able to show how a fibroid is not only the presence of this foreign object in a way into the cavity, but also the transformation of the connective component of the decidual, the stroma, is going to be all impacted by the either hyper expression of fibronectin or tissue metalloproteinase. And therefore, there is a total different environment. So that's why when fibroids are large or they are impinging in the cavity, they should be removed. For example, in these other slides, I am expressing here the concept that it is not only the mechanics, it's not only the presence of a foreign body or physicality in the uterus, but also from a molecular standpoint, how this homeobox, and there are HOX genes, the MSX1 and 2, that are important for implantation, because all these are transcription factors that they regulate, yeah, the expression of integrins, the expression of selectins, and other genes that at the end of the day, they are important. If they are not properly expressed, they are impacting implantation. And I want to conclude by saying that, okay, so we can see, visualize things like polyps, adhesions, fibroids, and so forth. But what we cannot visualize if we don't have a proper testing is the molecular biology dialogue, which is important. Okay, so the black box of implantation, the only way to understand it and trying to modify it it's really by knowing exactly what is impacting, influencing the hypo expression of particular genes and therefore particular protein into the uterine environment. So lately, there were, and this is a slide from the HFEA, which is the Human Embryology Society of UK. And this is really an organism, the Fertilization and Embryology Authority, that has authority for UK to check what are considered valid or not validated adds-on. And they use a color system. So any of the proposed add-on or adjunct to in vitro fertilization, they get a color. If the color is red, means that has not been proven as on an evidence-based medicine. If it's amber, yellow, orange, means that there is not sufficient proof that works. And if it is green, it's okay. So, and I can assure you that if you look at the website, that there are really no green dots to any of the tests that we are proposing to our patients. And I want to stress here the endometrial receptivity assay and the endometrial scratching. The ERA, the endometrial receptivity assay, has completely been debunked lately with the randomized controlled trials. Therefore, most likely, I am guessing that is going to disappear from the things that we are going to be offering. And so very controversial is also the endometrial scratching. Now, what the endometrial receptivity assay was planning to do? Well, it was trying to tell us whether the endometrium biopsied was going to be in a receptive, pre-receptive, or post-receptive stage. In other words, was trying to identify if a particular uterine preparation with progesterone and estrogen, for example, in anticipation of a frozen embryo transfer, was done properly timed. So in other words, the endometrial receptivity assay was trying to detect whether a woman was having a tighter, less than 3 days, window of implantation, and therefore we physicians were doing the transfer at the wrong time. Well, at the end of the day, when finally randomized controlled trials have been done between embryo transfer done with the programmed proper timing versus not proper timing, but the standard preparation, there was really no difference. And therefore, the adds-on, particularly for the endometrium, it did not provide a better implantation or a better live birth rate. And also the endometrial scratch that was done with the idea of improving the outcome, because by creating an inflammatory state into the endometrium, you were going to elicit an immune response that was then going to be leading to a better chance for the dialogue between, therefore immunomodulation between blastocyst and decidual tissue. Also that one has not been shown to be valid, and therefore there is not, it was not demonstrated a beneficial effect of the scratching over improving implantation. So just to show that unfortunately, yes, we can see pathologies and we can treat them, obvious one, but what we are still in the dark is really understanding what are the most important factors that regulate the immunological, biochemical, and protein expression of particular genes that are favoring implantation. So a lot of work still to do there. And this is really the slide that shows that even the endometrial injury does not provide any benefit. So in conclusion, we need to maximize the uterine environment by removing any obvious visible pathology, and that is easy to do. Pay particular attention lately to the histmocele, and if there is one, like Dr. Carugno will show you in the next talk, probably needs to be removed depending on the residual myometrial thickness. The adenomyosis, please pay attention. If there is adenomyosis, you need to modify a little bit your strategy before you do the transfer, because adenomyosis is impairing implantation and creates more risk for miscarriages. I showed you that the ERA testing and endometrial scratching as adds-on are not are not really associated with the improved implantation rates and probably should not be used anymore. Women should not be exploited with tests that are not effective. And the molecular mechanisms that are controlling and favoring implantation are complex. As I showed you in a couple of slides, they are still elusive. We need more research. And on the top of this, we also need to understand the microbiome that is playing also an important role with the quorum sensing for favoring the implantation process. So still a lot of work to do. I hope that many of the young students and the resident fellows in the audience will take this project. Many things need to be still unraveled, and I look forward to more research in this area. And with this, I think I'm done with my talk, and I will give the forum to Dr. Carugno or to some questions. And thank you so much. Here is a blastocyst landing into the uterus, looking for the ideal spot to implant. Thank you.
Дорогие коллеги, вы...
Distinguished colleagues, you listen to Professor Patrizio. And Pasquale, as we know, is absolutely unique personality who clearly showed us all options for endometrium, but he still put a question, error test, whether it's evidence-based or not. Looks like no. Scratching, whether it's needed or not. Well, maybe, you know, to refresh endometrium and to get particular improvements of endometrial regeneration. And hopefully this picture will be more complete right after the next presentation, when we are going to announce our next speaker. And this is Dr. Jose Carugno, who would be speaking about intrauterine surgery, what is new, Professor of Chair of Obstetrics and Gynecology and Reproductive Medicine. This is Miller Medical School, and he's a director of Minimal Invasive Gynecological Surgery Department, University of Miami. My dear Jose, I would very much appreciate if something has already been mentioned by Professor Pasquale. Please, you can skip this moment, and we kindly appreciate if you stick to the timing, 20 minutes, because Tommaso Falconi will be waiting for us, and we'll have to make a short break. So microphone is yours. Jose Tony Carugno.
Absolutely, Laila. Thank you so much for inviting me to give this talk and being here in this prestigious meeting, and say hi to Dr. Falcone. I saw he was connected there, a close friend. And needless to say, Laila, Dr. Patricia and I will welcome you here in Miami if you want to come and enjoy some sunshine here in Miami.
Yeah.
Having said that, we're going to briefly touch about intrauterine surgery, and what you asked me to do is to just tell you what is new. And so no financial conflict. And as I was preparing this lecture, my 13-year-old son comes to me and said, "Daddy, what are you doing?" I said, "Well, I'm preparing the lecture." What's the title of your lecture? What is new in hysteroscopy? And my 13-year-old son said, "Dad, don't waste your time. Just ask ChatGPT, and ChatGPT will tell you." So that's what I did. I went to ChatGPT and I asked ChatGPT, "What is new in hysteroscopy?" And my surprise is that ChatGPT says there's an artificial intelligence doesn't have an opinion. But ChatGPT highlighted three things: advances in the imaging technology, single-use instruments, and miniaturization of the hysteroscopic instruments is what's new. And as we see as technology progress, this is a hysteroscopy that we were doing 10, 15 years ago. There was gas, distension media. You couldn't see anything. The quality of the image was really poor. But now, this is the hysteroscopy that we're doing today. Today, we have 4K definition. You can see the blood vessels running inside the vessel. You see clearly the pathology showing in front of you with the quality of better than the TV that you have at home. Also, as I said, technology is creating new instruments for us. And now intrauterine surgery has become almost a video game. Very easy to perform, very easy to teach, which is the most important thing. So our residents, our new graduates, are leaving our residency program proficient in doing at least basic endouterine surgery. So that technology and that miniaturization, single-use instruments, our resectoscope is now 15 French. What that means is we are able to put a resectoscope inside a uterus with the patient awake without needing to dilate the cervix anymore. So, and as I said, we acknowledge the hysteroscopy and the progress. The Homo hysteroscopus is always behind the Homo laparoscopus, which is always a little bit a step ahead. But we are creating our instruments. And what's also new, unfortunately, three things are also new. One is obesity. We have an epidemic of obesity. We have a higher C-section rate that represented the creation of Ismosil, that Dr. Patricia just mentioned. And we also have a lot of failed pregnancy and abortion that if managed blindly, there is risk of retained peripheral conception and intrauterine adhesion formation. I'm briefly going to touch on these three innovative, unfortunate situations. As the first one is this obesity epidemic that has increased our risk of endometrial cancer and hyperplasia. We know that nowadays the prevalence of endometrial cancer is way more than it was 10, 15 years ago, and we have to adjust to that. Frank Loeffler, clinical director of the AGL, put out a very nice editorial article saying that it's time to quit relying on blind EMB and DNCs to rule out endometrial pathology. And we had this past year an entire meeting dedicated to stop blind intrauterine procedures, and every intrauterine procedure must be done on the direct visualization. Because what's key is on the quality of the specimen, the quality of that endometrial biopsy that we're sending to our pathology. You know the saying, garbage in, garbage out. If we give the pathologist this, and we are expecting the pathologist to tell us what the pathology is, if we give them this image on the right side, it's more clear and easier for the pathologist to give you an accurate diagnosis. And this would be the analogy of the puzzle slide on pathology. This is where you give a bad quality specimen, and this is where you give an intact specimen. So the pathologist will obviously be more easy for them to give you an accurate diagnosis. There are some artifacts that we must know that when we obtain tissue for pathology. One is bleeding. When we do that DNC and we send blood, this is what the pathologist gets. It's harder for them to make the diagnosis. Sometimes when we take the specimen using the resectoscope, using the energy, well, there is that thermal damage that's created just the same as when we do a lip, that the edges are burned. Well, the same thermal damage happens if we get the endometrial biopsy with a lip using energy. This is a very interesting artifact. When you go several times one on another, the tissue roll into itself and create this telescoping effect that also makes the interpretation of the tissue a little bit harder. And lastly, is crushing. If you do a DNC and you crush that tissue, when you send this to the pathologist, it's harder for them to give you an accurate diagnosis. So how can we prevent that? Well, we can prevent that with appropriate technique when we take the biopsy. And briefly, because I know there's people in training here, what you want to do is the grasp probing technique, so you can provide more tissue to the pathologist. And you open your grasper, advance your grasper, and as you advance your grasper, you plow tissue into that bite. Then you close your grasper, twist, push in to detach it, and now you have a big piece of tissue that you're going to send to the pathologist for pathologic interpretation. And we published this not that long ago with my fellows in Italy, that we stated that this technique, the endometrial biopsy using the grasp technique, should be the standard of care for the diagnosis of endometrial cancer. And what we prove is when you take the biopsy that way, the accuracy of the biopsy is 100% accurate. And the concordance with the final pathology is also 100% accurate. But what's important is this: it's not only it's accurate, the diagnosis. You can tell with accuracy the grading of the cancer. And this is really important because when we know that when we have a grade 3 cancer, the surgical planning is totally different, and that has an impact in patient counseling preoperatively. But what's the future regarding endometrial cancer? The future is this: the visual DNC. As you said, now we have these it's hysteroscopic tissue retrieval systems that allow us, using the morcellator, to basically do a DNC on their direct visualization and provide the sample of the entire cavity on their direct visualization and not blindly anymore. So from now on, when we're doing biopsies for rule out endometrial cancer, this is the way it should be performed. And we also published that this technique can be easily done in an office setting. You don't need to take the patient to the OR to take the biopsy in that way. On a recent review article that we published regarding the role of hysteroscopy in endometrial cancer, we highlighted the way we resect the pathology. And you basically do several steps. First, you resect the pathology. Second, you resect the margins around the pathology, and you send that specimen separately to the pathologist. And then you resect the bottom of the lesion, and you send that as a third separate specimen. So the pathologist could tell you if there is a spread of the disease. Another interesting approach to this pathology is doing our colleagues in Italy, that they're basically using first the resectoscope to resect the endometrial cancer, and then they're using the hysteroscopic tissue retrieval system to get the pathology from the difficult areas where it's difficult to collect the tissue, like the corneal areas. So they're maximizing all the technology to improve our patient's outcome. The second point that I want to touch is on ismosil. As we know, the C-section rate is a worsening problem. It's growing. Here in the United States, it's around 30%, but there are places in the world like Brazil where the C-section rate could be up to 80%, especially in the private sector. And what that translates is into this cesarean niche scar that could have several shapes and a high prevalence, as Dr. Patricia already mentioned. There are several risk factors. So there are hypotheses. There's nothing proven, but they say the location where you do the scar at the level of the hysterotomy, the time of the C-section. If the patient was in labor and the labor progressed more than 5 centimeters, then if you do a C-section, there's a higher chance of having an ismosil later on. The surgical technique that you use, if the uterus is in retroverted position, there's also higher chances of having an ismosil. But basically what the ismosil is it creates this pouch. So when the patient menstruates, blood accumulates into the pouch, she stops menstruating, and then the blood that was accumulated keep going out, and in the form of post-menstrual spotting. What are the symptoms? As I said, the most common symptom is bleeding as a form of post-menstrual spotting, but it can also cause pain. It can also cause vaginal discharge and infertility, as Dr. Patricia mentioned. The diagnosis, the gold standard is hysteroscopy, but there are other imaging modalities, and I'm highlighting in red sonohysterogram and hysterosalpingogram because those are imaging techniques that you put fluid or gel inside the uterus, and putting that gel highlights the pouch. So we know that if we fill the uterus with liquid, the ismosil, it's easier diagnosed. But what's important? What's important in the preoperative workup of patient with ismosil? 2 measurements. One is the myometrial residual thickness that will dictate the route. If it's more than 3 millimeters, then you can safely do it hysteroscopically. But if the myometrial thickness is less than 3 millimeters, you should consider a laparoscopic approach. Another interesting measurement that's important, and not everybody does it, is how deep the ismosil is. So you want to measure what's the distance between the ismosil and the external cervical os, and you're going to see in a second why that is important. There is as far as the diagnosis, a systematic review again proved that you have to put liquid inside the uterus to better visualize. And when you do 2D ultrasound without the liquid, see how the accuracy of diagnosis go down to like 20%. For the treatment, you basically need to know the rules. And there are two important rules in the management of isthmosil. And rule number one is you only treat isthmosils of patients with symptoms. If it's an incidental finding that you did an ultrasound and you saw an isthmosil and the patient has no symptoms, there is no role to treat that isthmosil. You don't treat isthmosil to prevent future symptoms. You don't treat isthmosil to prevent that she might become infertile, to prevent a C-section scariotypic pregnancy. No, the treatment of isthmosil is only in patients with symptoms, and this needs to be very clear. That's rule number one. And rule number two is do not ignore rule number one. So the treatment, there's two different types of treatment. One is remodeling that you do hysteroscopically, and the other one is excisional, that where you just excise the piece and then basically stitch together the upper uterine segment with the cervix. Or here are the steps on the isthmosil. You basically first identify the anatomy. In the interest of time, I'm gonna advance, and basically you see how with the resectoscope you start doing. I like to start doing first on the right side of the patient. I find that easier, and first I tackle the upper edge. That's once the upper edge is done, I go to the under edge, and then I cauterize the base of the isthmosil. There is a very interesting thought now of what they call the 360 degree of the isthmosil, where they not only remove the edges of the isthmosil, but they're also cauterizing the posterior edge of the lower uterine segment, claiming that way the inflammation decreases and there is a higher chance of treating the symptoms. But is hysteroscopic isthmoplasty actually work? For symptoms, well, we have one randomized control trial with 50 patients in each arm, patients that with symptoms that underwent isthmoplasty versus expectant management, and those who underwent isthmoplasty had a significant reduction of symptoms. For infertility, the classic work of Dr. Gianpietro Gubini, where he has these 41 patients who had an isthmosil, treat them, and 100% of them became pregnant. But there's another interesting thing. The myometrial residual thickness after the treatment of the isthmosil is done, two things happen. The size of the isthmosil decreases, obviously, but the myometrial residual thickness increases after the treatment of the isthmosil, kind of relaxing the normal myometrium around the scar tissue. A quick algorithm for treatment. So is the surgical management of isthmosil indicated? Is the patient asymptomatic? That, as we said, no treatment. If the patient has symptoms, then you basically have two options, hysteroscopy or laparoscopy, and what dictates is the myometrial residual thickness. If the myometrial residual thickness is more than 3 millimeters, we tend to favor the hysteroscopy route. If it's less than 3 millimeters, we favor the laparoscopic route. Very interesting thought, though, the vaginal route. The vaginal route is you pull on the cervix, you identify where the isthmosil is. Once you identify the isthmosil, you can pierce it with a sound, basically excise the both edges, stitch it back together, and done. That's why it's important, that measurement from where the isthmosil is in relation to the external os. See, this is another patient. This is 4 centimeters from here to here. So if you have that isthmosil less than 4 centimeters from the external cervical os, that isthmosil is almost in the vagina. So the vaginal route will probably be the easiest access to the isthmosil. This isthmosil can get really, really intense and big. And we have here what we call a hot air balloon, where the isthmosils balloons up really big, and we perform the excision of the isthmosil here. So you can see, look at the size of that isthmosil when you highlight, when you turn the light on the hysteroscope. If you turn the lights on the laparoscope, that's you see the size. You basically that size of isthmosil you need to excise and then stitch it together. This is an interesting concept. They're saying that when the best way to prevent isthmosil is avoiding the formation of the isthmosil, and basically what they're recommending here, not only stitching the anterior part of the uterus, but also fixing the posterior part of the uterus with stitches, so to reinforce both ends of the lower uterine segment. There are some questions that have no answer still of isthmosil. The first question is how to prevent it. What is the best approach? Should we do the remodeling hysteroscopic approach? Should we resect the entire isthmosil? How to proceed after the repair? That's another important question. We, from the global hysteroscopy community, put out some recommendations. We recommend contrasection for 3 months. Then we repeat the hysteroscopy after 3 months to ensure that the isthmosil healed. And then the patient who had isthmoplasty, we recommend that deliver at 38 weeks by cesarean section to prevent uterine rupture. And I want to leave the audience with a question here. Have you ever seen an isthmosil in a patient who had a midline C-section scar? I haven't. And that's something that I'm looking forward to study. And just to finish, 3 minutes about intrauterine adhesions, basically as happening when you have misabortion on early pregnancy loss. You have the 3 options of management: expectant, medical, and surgical management. When you do the surgical management, if you do blindly and you do a DNC, you run into the risk of creating intrauterine adhesions that are up to 30% if you have to do more than one procedure. In a systematic review that they compare the management of pregnancy loss on a blind DNC versus hysteroscopically, you see that the prevalence in intrauterine adhesion formation is 30% after blind, now 13 only if you do a hysteroscopy, and your incomplete evacuation also 30% if you do it blindly versus only 1% if you do manage it hysteroscopically. The retain, what's important with the retained process of conception is the vascularity, the size and the location of the tissue. Basically, technically, it's really easy. We do it with cold resectoscope. It detaches very easily, and you only touch the line of the endometrium that is where the placenta tissue is. You don't touch the opposite side. Technology, again, is here to help us. We also can use the tissue retrieval system to manage the retained product of conception without problem. It's very easy to do. Doesn't create intrauterine adhesion after the procedure. Again, what's important is the size, the location, and the vascularity of the product when you plan your surgery. So 2 words about intrauterine adhesions. When I see intrauterine adhesions, I think of 3 things. Is this a physiologic condition, just the way the uterus heal? Is this a complication of the procedure? Or is this malpractice? Was this patient mismanaged, and that's why she has an Asherman syndrome now? It's definitely a problem. And here is the solution. The solution is hysteroscopy. The diagnosis, again, ultrasound is not good. We need to do a sonohysterogram. 3D ultrasound is the best way to diagnose, see the correlation with hysteroscopy and the 3D ultrasound. When you show this picture to a patient, she clearly understands the situation. Again, the hysteroscopy is the gold standard. What's important? What was the insult? How long ago was the insults, and what are the treatment that the patient has received so far? Is totally different if the patient had a DNC, postpartum DNC 3 times 5 years ago, and now she has Asherman to the patient who had
Профессор
one pregnancy loss.
Каруньо,
Professor Karun, we have no time. Sorry, we're pressed for time. Sorry about that.
Say that again?
заканчивайте, пожалуйста.
You are pressed for time. Sorry about that. Please wrap up the presentation.
Sure. So to wrap up, for the treatment, you need to be in the midline. You need to aim to have a triangular cavity. You need to use your scissors. Don't use energy. Identify your tissue and use high pressures as you cut. So secondary prevention, it's you can use gels or a Foley. The future is now. Take advantage of technology. Maximize the quality of your uterus before you're putting an embryo in there, and to maximize the chances of pregnancy. Thank you so much. I apologize for going over a couple of minutes. That's my email. Any questions or comments will be welcome. Thank you.
Dear Professor Karunia, thank you. That was a brilliant presentation. And many things I totally agree with you. Do not touch isthmus seal if a woman has no complaints. Isthmus seal, well, if you have no complaints on the part of the woman, do not do anything with isthmus seal, especially if you are planning to send a woman for IVF, but there may be other excesses. When, for example, we're talking about sending a woman to treat infertility, many doctors just say, well, no pregnancy in this case, IVF is prohibited in this case, and basically they have the situation when they try to excise niches. That's a very important problem. That's an important subject for discussion. And Professor Pasquale and Professor Carunia, well, Professor Falconi, who is here with us, we must minimize the number of C-sections. We have a lot of C-sections. It's just impossible. If we have as many C-sections as we have now, how can we regulate this process? It's horrible. We cannot just all the time control the situation, whether a woman has become pregnant or not, and we cannot just prohibit C-sections, or we cannot ask ART specialists to let them get pregnant and send them for explantation of the egg or not. Thank you very much again for this wonderful presentation, and now I'd like to give the floor to our big friend, Professor Falcone, a professor of OBGYN and reproductive biology, well, Cleveland, the United States, Ohio. The topic is uterus transplant. Thank you, Professor Falcone, for being with us. I am waiting for your presentation, please.
Okay. Let's see. Ну, как только начнет Голикова, вы тихо ставите мне звук.
Okay, good afternoon. I actually am presenting from London. I'm just going to share my screen, and I'm hoping that you get the right view of the screen.
Yes, the slide's okay.
Yeah, so thank you very much. I'm going to present about uterus transplantation, and I just want to make sure that you have the correct view of the slide.
They're not full screen. Make them full screen. They're very small. Sorry.
That's okay. That means that I'm sharing the wrong side. Let me just look again of how I can do this to share the screen for the correct view. Okay, screen 2 then. Share. And how about, let's see. How about now?
No, we just see the blue screen. Now it's okay. Now it's perfect. Thank you very much. Perfect. Thank you.
I'm going to talk about uterus transplantation, a brief update within the next 20 minutes. This all started back in 2015 after many, many years of research. This was the first birth and by the Swedish group with Mats Brandström. And it's very important to understand that the This led to the revolution that we have now, where many people are undergoing uterus transplantation. In the United States, just to make it clear, there are two programs which are off IRB, meaning it's not considered experimental. You can go there as a patient, and they will do the procedure off the Institutional Review Board. At the Cleveland Clinic, we still have it under IRB. So this was the first birth from in the second birth in the world from the deceased donor, which is what we use. As you see here, this is a patient that was born in 2019. We use deceased donor transplantation rather than live donor, which is what often most of the groups do for a variety of reasons we'll get into in a minute. But for us, then, we had this. In this particular patient, we did a hysterectomy immediately afterwards. And I was part of the team, as you see on the far right, that actually did the hysterectomy more than doing the delivery. So let's go through why we do this. So uterine factor infertility affects many people, as was presented by Dr. Carugno. In fact, if you have a lot of intrauterine adhesions, a lot of fibroids that were removed, actually a lot of intrauterine adhesions now are from actually removing of fibroids, and that can lead to decreased fertility or infertility. However, most of the world literature so far on uterine factor infertility is actually from Rokitansky syndrome, which is simply, as you see on the slide, a absence of the uterus and the vagina. And as you see over here, though, what's important before we go on, look how the bladder is really firmly attached to the rectum. When we create a neovagina, that is very important because the dissection of the upper part of the vagina in order to do the anastomosis of the donor organ to the recipient. This means you're really dissecting very dense tissue. So why do we do research on uterus transplantation? Well, as you know, in the world, surrogacy is often not acceptable. In most of the Islamic countries, it's illegal. In Sweden, it's illegal. In Italy, it's illegal. And then many other countries that will allow gestational carriers, like in the United Kingdom, the commercial contracts are illegal. Furthermore, in this country, for example, woman, the surrogate that has the baby is hers. The genetic donor of the gametes must adopt the baby. So therefore, surrogacy is not as easy as people think, and that leaves the possibility of either adoption or just simply not having a baby. So this is all about reproductive autonomy. So what was interesting is we, as you well know, we didn't actually advertise at all, but our trial was listed on clinicaltrials.gov. Many women and men that will actually go to see if there's a problem, a clinical trial that suits their needs. So, but if you look at the initial group that we had, in fact, transgender patients called us a lot. Androgen sensitivity syndrome patient is going to be done next, I'm sure. The trans community is very
Пожалуйста, дайте звук.
Technical, sorry, we got your computer frozen. Dear lecturer, we cannot hear, or you and your slides are frozen. Sorry. Off the mic. Professor Falcone, check. No sound. Dear colleagues, my apologies. There is nothing I can do. Unfortunately, internet can go down. Internet went down. Yes, we can. Thank you. Thank you. We can hear you. Please, could you share your slides?
I don't know where you stopped listening to me, but the screening of the donors, the living donor, is very important to exclude vascular disease and anything that could be reactivated with the anti-rejection drugs such as HPV. So the most important concept is the preoperative preparation. A lot of the patients of the living donor are often postmenopausal women. And it's very important to understand that the uterine vessels are estrogen sensitive. And therefore, a lot of patients are put on high dose estrogen preoperatively in order to increase the size and flow of this. This, of course, could render the patient at risk in the living donor for potential deep vein thrombosis. So living versus deceased. The living donor is easier to plan. So usually living donors are very appealing to transplant surgeons and to the group because if you plan for the surgery on Monday morning, everybody's available. One room has the donor, one room has the recipient. For the deceased donor, it occurs in a patient that is being assessed for donor of their heart and other organs, and therefore it usually occurs very late, inconvenient times, and certainly the investigation of the donor for potential donation of a uterus is done very rapidly rather than at pace, which is what happens with a living donor. On the other hand, obviously the patient that is donating the organ will become infertile. There may be possible pressure or coercion if it's a relative. And then finally, there's graft discard, which is if the donor uterus is not able to be used or does not function in the recipient, that could lead to a psychological stress. For the deceased donor, obviously there are no risks, etc., but it is considered a separate consent from the typical donation. So when you sign in the United States that you're willing to be an organ donor, it's usually the heart, the lungs, etc., but the face, limbs, and uterus is a separate consent. The next question, basic science, really is how long can this uterus stand ischemia? And as you see, there are different organs, kidneys, pancreas, they have different ischemia time before there is ischemic damage. And the second thing that we also have to have an interest in is this so-called ischemia reperfusion injury. This is for those that use, for example, tourniquets during myomectomy, that causes ischemia. And as everybody knows, when they reperfuse, sometimes there's more bleeding. But what's important is sometimes the a reperfusion injury causes the capillaries to leak. So all this is active investigation, but ischemia time probably for the uterus is closer to the heart, which is about 4 to 6 hours. So what about the psychological evaluation? Again, we need to make sure there's extensive counseling. We're interested in the couple, the recipient couple, being able to understand that they have a commitment to be available, and they have to often be in the city which does the transplant, especially as they get closer to term. And then in the related donor, we're always worried about donor guilt. If there's no pregnancy and the uterus has to be removed, the mother may have given the uterus to the daughter, and of course, if it doesn't work, then there are obviously going to be consequences for that. So what is the preparation? The first thing is we have to make sure the neovagina is of adequate length, and therefore oftentimes it is not, and we have to use dilators. The most important thing is the apex, the top of the neovagina has to be wide enough to accommodate a cervix. Most of the donors are multigravidas, and therefore it has to be wide. So we have to use dilators in order to accomplish this. The second thing is pre-transplant, we have to make sure we have enough embryos to achieve 1 or 2 pregnancies. And therefore, if the patient is unable to form adequate number of blasts or embryos, then there's no point in proceeding. Now, the immune suppression is pretty standard. It's the same as what they use for kidney transplant. It does cross the placenta. We're really not worried about it. from the point of view of fetal malformation, because we have a lot of experience with kidney transplants. The embryo transfer is done 6 months after the transplant. If they want to get pregnant, we change to azithromycin. Tacrolimus, steroids, and azithromycin have not been demonstrated to be teratogenic. Active area of research is immune tolerance. That is, you need less and less medication in order to keep the transplanted organ. How do we monitor for rejection? Well, fortunately, we have a cervix. We do cervical biopsies. There's a classification, as you see on the right of the slide, with more and more inflammation. And most of the time, it responds to an acute input of anti-rejection meds like steroids. And it's very uncommon to remove a uterus because of rejection. But we monitor very closely for rejection, and we monitor very closely for perfusion. Again, very standard and not really extraordinary. And most of the time, when you do remove a uterus, it's because of thrombosis. Finally, it's very important to understand that the donor part, the procurement of the organ, is the complicated part of the surgery, not the actual transplant. And as you see here, it's very long surgical times to procure. And this is because for those that are using exclusively the uterine vein, the dissection is very complex and is very long. And although we are getting better and we're doing it in a minimally invasive approach, it is certainly still very complex. This is an example of the Dallas group and their initial experience. They removed the first 3, and as you see, a very long surgery, potential complications. So the procurement is the hard part. And if you look at the complications of review of the outcomes of the first 45 cases, there are hundreds now, it's the same concept at the time of procurement. Obviously, it doesn't occur in the brain-dead donor, and most of the time there are ureteral injuries because of the dissection of the vein and arteries around the ureteral tunnel. Remember, it's not like a radical hysterectomy where you can just open that ureter tunnel. You have to make sure that the vein and artery are intact. If you clip, then you won't be able to use the organ. So there is psychological stress. A common factor for psychological stress in the donor that we're talking about is the fact that the woman gave her uterus to a recipient and it was not functional or did not result in a pregnancy. So we need to take that in consideration. Now, for deceased donors, what we use, and as you see over here, the deceased donor on the left of the slide is actually an endometriosis case. And you see the uterine vein, the scissors are on the uterine artery and the ureter. This is the left side, and the uterine vein is seen to go from the internal iliac all the way to the uterus. Now, you have to dissect that without clipping any of it, because if you clip it, then there's no venous return. So that you can do the anastomosis you see on the far right to the external iliac vessels. So this is a comparison. On the left, these are my fingers. This is a deceased donor. We take a huge chunk of the internal iliac and artery and vein. So we have a big proximal vessel. While, as you see on the right side, when the living donor, you have to really dissect from lateral to medial. So this is a angiogram. As you see on the left, this is a venous angiogram. Oftentimes these vessels become very, very dispersed, they're small, and it's very easy to clip them, and then you don't have venous return as compared to the right side where the uterine artery is very easy to assess, to take, and not a problem from the perspective of dissection and taking the artery. The artery is never the problem, it's always the veins. So if you see here, this is a transplant from us, a successful one. You see the big pipe that we used because we took the entire internal iliac and external iliac and anastomosed it to the patient's right external iliac artery. Now, when you take it from a living donor, you can't get this wide, and therefore you have to take more time to dissect. Then our part at the time of transplant, as you see here, is to prepare the vagina. Remember, these are patients that have a neovagina. As you see, we prepare the vagina so that we can do the transplant. And this, as you see, is how you do the transplant. The upper part is from the donor. So there's a cervix and upper vagina from the donor. And if the donor is deceased, there's no problem. But if it's a living donor, obviously you have to be conscious of what you can or cannot take. And often where the anastomosis site is, there is stenosis, which has implication for doing your embryo transfer, as you have to maneuver around it. This is the MRI of what it looks like, and as you see, completely normal looking uterus, but it's the parametrium, which is very different. So if you're doing a post-transplant egg retrieval, you have to just be aware of the anomalous vessels around it. These are the complications of the recipient. Oftentimes it's stenosis and sometimes fistula, but usually it's stenosis. And of course, it's thrombosis, which we're worried about, and removal of the graft, as you see here. This is a thrombosis. You see the picture. It does occur in most of the reasons why we remove the graft, which is in 29% of the patients. So just remember, if the graft is not removed, high pregnancy rate, but 29% of the time we do have that, and it's due to thrombosis or infection, sometimes ischemia, but it is due to those reasons rather than rejection. So psychological outcomes is the same. If you remove it, there is graft failure and psychological strain on the couple if we remove the organ. As for the births, there are many births. You can't really publish an article anymore just from a birth, given the fact that we have a tremendous number of births around the world. So how do we make this better? Well, we're going to go towards robotics, and there's no question the procurement is going to move towards that, but it's not as easy as people think. The surgery is very complex at the procurement. An initial experience of the Dallas group, which is very experienced, they had in fact complications, ureteral complications, long surgery, and then this is in spite of the fact that they have young population. And again, you gain experience. And the Swedish group, which again has pioneered all this, the operative times are still long, and therefore, again, there's a learning curve, but I'm confident that we will get to the point where robotic procurement, which is the hard part of the case. And then finally, now there's the Swedish group presented a robot-assisted actual transplant. Remember, the transplant itself is a vascular anastomosis. We do the vaginal anastomosis as gynecologists, the vascular surgeons. This is resurrecting the initial concept of why we even developed robot surgery. Robot surgery was developed to do coronary bypass surgery. As you see here, the robot will do a very fine anastomosis, and that can be accomplished by robotic assistance. And I think is the way, even for patients, you still have to make a small incision to put the uterus in. But I'm confident that we will go towards that. The other concept that a lot of people have published is that maybe you don't have to use the uterine vein. We can use smaller vessels. So this is a study that we did in the animal model where we cut off the uterine artery and vein and only kept the uterovarian circulation, and the monkey model got pregnant. And as you see here, it's very fine surgery. So this is another approach that we have to consider in our research program. Another initiative is mismatching of cytomegalovirus, which is very important because of the fact that if there's a CMV mismatch with anti-rejection drugs, that can cause a problem with the fetus. There's a potential for Epstein-Barr virus lymphadenopathy and even lymphomas in patients on anti-rejection drugs, and then of course HPV. The chemotherapy or immune therapy will be simplified with no MMF and starting with azathioprine. So it's not chemotherapy, but anti-rejection drug. So then to conclude, this is in fact where I work at this moment, where the arrows are. I'm actually in that building there across the street from Buckingham Palace. But I want to include my talk to say that the field of uterus transplant is moving rapidly. We have great successes. The main limitation for us is the procurement. The procurement is very difficult to do, but I think we're going to get there with minimally invasive surgery. And now for the transplant, we're also working on transplantation, which can be done with minimally invasive models. And we're going to work on simplifying anti-rejection drugs and looking at the concept of immune tolerance. With that, I thank you very much for the invitation, and I'm going to turn it back to you to move on. And I will stop sharing my screen. Let's see. Okay, I think I've already stopped sharing the screen. And that's it. So back to you.
Well, dear Professor Falconi, you know, what you showed, what you demonstrated is fantastic, outlandish things, much to my regret. I don't know whether we are prepared broadly in Russia to accept these methods. Yes, indeed, we are perfectly aware Dr. Bronström and his team, we personally know them, we know pretty well Professor Buktam Bekar, who does it laparoscopically, this uterine transplant. The role of transplantation of uterus in her life will probably be growing, surely. But unfortunately, as of today, this indeed is a procedure or an operation, if you will, which has very many outstanding issues. But regrettably, who else other than us? Data this colossal Congress, 60 stars of world surgery have to take a take on this. Thank you very much for highlighting the most fine points and the points that we will have to face and overcome so that every woman has a chance to become a mother. Thank you so much. Thank you. And we move over to the next lecture that is supposed to be delivered by Professor Ted Lee. A minor video. Well, Ted Lee will be delivering a presentation on hysterectomy for severe endometriosis. He's director of a clinic for minimally invasive gynecology of the Medical Center at the University Hospital at Pittsburgh, United States of America. Dear Professor, you now have the floor. We now make an announcement for Professor. Oh yes, there will be a video spot pre-recorded. National Medical Research Center named after Kulakov, laparoscopy and hysteroscopy in operative gynecology. Leader of the course is academician Adamian, Leila Adamian. A short ad for the center. Simulation Center of Kulakov Research Institute, laparoscopy and hysteroscopy in operational gynecology. That was an ad for Kulakov Center.
My name is Ted Lee. I'm the director of minimally invasive gynecologic surgery from McGillman's Hospital in Pittsburgh. I'd like to thank Dr. Laila Mayan for inviting me again to give a lecture on this prestigious conference in Moscow. The topic of my talk today is about hysterectomy for severe endometriosis. I'm going to go ahead and share my screen. Perfect. All right. So I have no disclosure with any relationship with any industries. The objective of this presentation will be to discuss the strategies to minimize the rate of unexpected endometriosis and incorporate anatomy-based strategies in the performance of hysterectomy complicated by severe endometriosis. When we encounter endometriosis during hysterectomy, it could be either planned or unexpected. And then the idea is to, try to avoid and minimize the unexpected endometriosis during hysterectomy. The issues with unexpected endometriosis during hysterectomy is lack of informed consent and then insufficient time allowed for the procedure to be performed in meticulous fashion. You end up with no treatment or incomplete treatment, and you end up with very unhappy patients. Endometriosis should be considered in every patient undergoing hysterectomy for pelvic pain. To minimize unexpected endometriosis, one must consider a few things. Number one, careful history. The 3 Ds, dysmenorrhea, dyspareunia, dyschezia, and detailed physical exam, including a rectal vaginal exam, to palpate for nodularities, and be aware of debris field ovarian cyst on the ultrasound. If the patient has ovarian cyst with the debris field ovarian cyst that was seen a few years ago and is still present, maybe slightly larger, there's a very good chance that the debris field ovarian cyst will be endometrioma, which is highly associated with obliteration of the cul-de-sac and significant potential visceral involvement. And also a patient have unexplained nulliparity. This patient Z0, P0, you have to ask why you haven't been able to get pregnant, or the patient have attempted to get pregnant in the past. Obviously, patients has been always using birth control all their life, and they want to avoid pregnancy. That's one thing. But a lot of these patients to end up with just couldn't get pregnant, and they never really do anything about it. So that's a very important factor to consider in history. When it comes to general surgical strategies for any distorted anatomy, is to work from known to unknown, perform the easy and accessible task, and define your anatomy and reestablish your landmark and perspective. Find the gateways to the retroperitoneum, and try to avoid confrontation with the pathology without going through the above. Don't attack the hardest part of the pathology without going reestablish all your anatomy. The most common gateway to retroperitoneum when you deal with severe endometriosis would be making a peritoneal incision at the pelvic brim between the IP ligament and round ligament, make an incision parallel to IP ligament. This is the most important incision that you will make for a patient with severe endometriosis. And this is the same incision you will make on the contralateral side. Again, parallel to IP ligament and started out from the round ligament towards the pelvic brim. And here is an example of a video of a patient with a large retroperitonealized endometrioma that have distended the round ligament and the pelvic sidewall. We'll incise the round ligament, and we'll basically make a peritoneal incision parallel to this large annexal mass that's being sent to the pelvic sidewall, and follow towards the IP ligament. And then this is pretty much a very standardized techniques that can be used for every patient with severe endometriosis. Again, really make that peritoneal incision as big as you can so you have a very good exposure to the pelvic sidewall. So once you make this peritoneal incision, and will be a good place to start for you to start your dissection retroperitoneally. So a lot of times I've been asked about, finding and dissecting ureters. Ureter has always been the most challenging part for a lot of gynecologists. And so the key is to make sure your peritoneal incision is big enough so the peritoneal edge can be retracted medially without difficulty. And always start with the pelvic brim where there's no disease. And once you find the external iliac artery, the ureter is in the same plane or layer as the great vessels. And so that's what the question I always ask my residents, my fellows, how do you find the ureter? The idea is to find the external iliac, and the ureter is in the same layer. You want to mobilize the ureter off the medial leaf of broad ligament if the ovary or endometriosis is attached to the broad ligament. And this is kind of general steps in finding and dissecting the ureter. Again, this is the same patient that I just showed earlier. That we will go ahead and actually extend our peritoneal incision more towards the IP ligament, parallel to IP ligament. And then we'll find that you can see the genitofemoral nerve, the psoas muscle tendon underneath it. You find the external iliac artery, which is right there. And the ureter is in the same layer. Okay, so once you find external iliac artery, you'll find the ureter. All right, then we'll get rid of all the adipose tissues above it so we can get better exposure. We already find the glimpse of the ureter when we follow the same tissue layer. And also, too, the other thing to do is to develop pararectal space that will accentuate the location or the dissections of the ureter. So that is the ureter, and this is going to be the internal iliac artery right out here. So you accentuate the space between the ureter and internal iliac artery. That's internal iliac artery. We'll go ahead and accentuate the pararectal space, and the ureter will become much more apparent. You can see that retroperitoneal fibrosis is obliterating the pararectal space partially. That's the ureter, and here is the internal iliac artery. So, in summary, is that you find the ureter at the pelvic brim, follow external iliac artery in the same tissue layer, find the ureter, accentuate the pararectal space between internal iliac artery and the ureter. And then once you find the ureter, then you have to begin to separate the ureter from its attachment to the pelvic sidewall. And a lot of times, people are afraid to use energy when they do ureteral dissections. The key point is to create space between the ureter and the tissues you're going to incise by using my instrument on my left-hand side. I'm going to have resistant retract for me. We'll go ahead, before we make a cut, we'll displace the ureter to minimize thermal spread to the ureter, to avoid thermal spread to the ureter. Spacing is key when you do this type of dissections. Again, create a space. When you create a space, then you can use heat to make your incision and provide better exposure for the rest of the dissections. The other thing is, a lot of times, especially with severe endometriosis, is at risk for having ovarian remnant. The key is to make a window between the IP ligament and the ureter. Once you create this window, you can use the most basic bipolar instrument and not have to afraid of thermal spread. And in terms of management of endometriosis during hysterectomy, I like to cut off the blood supply first before I deal with the ablation of the cul-de-sac with or without rectal involvement. So first thing I do is trying to find all 4 blood supply before I start the rest of the difficult dissections. So in general, it's very, very important to be able to find the uterine artery as the origin in patients with severe endometriosis. In this picture, you can see the ureter seemingly going directly through the endometrioma. So if I were to continue the uterolysis, I'll get into bleeding because the uterine artery will eventually cross over the ureter. So a lot of times I would like the uterine artery as the origin coming from the internal iliac artery. And you can do that in several different ways. This is just a schematic drawing of the left pelvic sidewall with the left coming iliac artery, external iliac artery, left internal iliac artery. The first branch going medially over the ureter is the uterine artery. And you can also use the medial umbilical ligaments to trace it backwards towards the uterine artery. So one way to find the uterine artery is using the medial umbilical ligament as a landmark and trace it back towards its origin from internal iliac artery, and first branch going medial is the uterine artery. We'll show a video of this. You can see the ureter in the same tissue layer as the external iliac artery. The pararectal space has been developed between internal iliac artery and the ureter. And then we'll go ahead and find open the perivesical space. That's up to the nerve. That's the medial umbilical ligament, which is the large cord-like structures medial to the great vessels. Then we'll begin to skeletonize the internal iliac artery as well as the medial umbilical ligaments. Then we grab the medial umbilical ligament to confirm the right structure, and we use medial umbilical ligament as a handle to displace the uterine artery away from the ureter. And then you can take the uterine artery from its origin fairly easily. You have all the structures, and then we'll go ahead and basically ligate the uterine artery from its origin. And this can be done fairly quickly, and it's a very effective way of ligating the uterine artery in patients with severe endometriosis of its origin from the internal iliac. We'll skip this video here. The other way to find the uterine artery of its origin is by developing a perirectal space between the internal iliac artery and the ureter. And the first branch going medial is going to be the uterine artery. This is a patient with a large retroperitoneal endometrioma, which I have shown earlier. Okay. And then once we identify the perirectal space and the ureter, then we'll free up the ureter medially, and we'll then proceed to basically find the uterine artery's origin. Again, this is showing the same dissection I shown earlier to displace the ureter from its attachment to the medial leaf of brow ligament. Again, spacing is very, very important. Okay. And so I have already developed perirectal space partially. Here's the ureter, here's the internal iliac artery. I know the medial umbilical ligament is going to be somewhere around here. You can see my pointer. And you can see all the retroperitoneal fibrosis that I have to cut through in order to find all the structures. Once I break open the septum of fibrosis, then we'll go ahead and find the internal iliac artery. All this surgeries clips are in real time. I'm not trying to speed up anything here. So this is medial umbilical ligament. This is the internal iliac artery. And can you see the ureter quite far away from us because we already developed perirectal space. And then we'll skeletonize the internal iliac artery and the medial umbilical ligaments. The back part of the medial umbilical ligaments and the internal iliac artery are free of any important structures. So you can seal and cut and skeletonize this structure fairly easily, and that's the uterine artery coming from its origin. Could accentuate the perirectal space even more. Grab the uterine artery. We'll also accentuate the perivesical space anterior to the uterine artery. And then you can go ahead and then ligate the uterine artery. We'll go ahead and open the perivesical space laterally, the lateral perivesical space, just for demonstration of the anatomy. And at this point, I can take the uterine artery from its origin fairly easily, and it's quite a distance away from the ureter. And once I ligate the uterine artery at its origin, then obviously I can complete my uterolysis. And this is a fairly common technique, also very, very important technique to have when patients have severe endometriosis, to be able to perform a modified radical hysterectomy. So once you ligate the uterine artery's origin, then you have to deal with the ablation of the cul-de-sac. Here's a schematic drawing showing the ureter on either side, the uterus, the uterosacral ligaments, all the peritoneal incision that you can make to develop perirectal fossa on either side of the rectum and to open the rectovaginal space. A lot of times patients get partial obliteration of cul-de-sac on the left side where the perirectal fossa and the rectovaginal space is obliterated, or it can happen on the right side, or can happen on both sides. So the only thing that incision you can make would be higher up near the presacral space. This is a typical patient with ablation of cul-de-sac with a rectum stuck to the behind the cervix and vagina. So we'll go ahead and make a peritoneal incision lateral to the rectum and be able to get into the perirectal fossa. And then once we define the tissue plane laterally, then we can begin to define the tissue plane medially. That's where the bulk of diseases is in the middle, in the midline. So you attack it from lateral to medial. Again, this is like all the previous videos. Most of my videos are real time. My hand doesn't move very fast, but it's effective in that I don't make too many moves to get the job done. Once it define the tissue plane on either side of the rectum, then eventually I have to cut this harder fibrotic adhesions between the rectum and vagina and cervix. And it's done with sharp dissections, and I'll intersperse some blunt dissection in between just to allow me to define the tissue plane and to allow me to make the next move. So open and spread and to see, kind of feel for the tissues, feel for where the weakness is. And then you go ahead and sharply dissect the rectum of the posterior cervix and vagina. Again, really kind of feel for the weakness of the pathology. And with traction contractions, we'll begin to, and then we'll connect to the long space laterally. And then, so once you connect the dots, because it's been open laterally either side, we use that as a reference, and there's a weakness there. We'll cut through the fibrosis. And then careful blunt dissection, we can open the rectovaginal space. And once the space is defined, and we can quickly mobilize the rectum by mobilizing the rectum posteriorly and open the rectovaginal space completely and away from the vagina, away from the cervix. And this can be done fairly quickly once the correct tissue plane has been developed. See, once I have more space, I can use more heat to minimize bleeding. Whereas initially I was using cold cuts because I didn't have much margin of error. A lot of times patients who are undergoing hysterectomy have a lot of rectovaginal and retrocervical endometriosis. Unfortunately, a lot of times this endometriosis on the retrovaginal septum and posterior cervix can be incorporated into the vaginal cuff. So it's very important to mobilize or to remove the endometriosis behind the vagina, behind the cervix, prior to making a copotomy. Otherwise, you'll incorporate endometriosis into your vaginal cuff. So as my left hand is retracting the endometriosis of the copotomizer cup, that way I don't leave a big rim of endometriosis on the posterior vaginal cuff, and patients are coming back with more endometriosis on the vaginal cuff and associated with pain and sometimes even bleeding. So it's important to mobilize all this endometriosis in the retrovaginal septum. And then it's done with both careful and sharp blunt dissections. And many times I have patients who have hysterectomy done elsewhere, and they will come back with all this big chunk of endometriosis on the vaginal cuff, and I have to go back and then remove them. And then it's very, very important to take care of it at the time of hysterectomy, is to get all the endometriosis in the retrovaginal septum mobilized of the copotomizer cup. And at this point, I can feel for the copotomizer cup. I can go ahead and make my copotomy. And then so now to include the retrovaginal endometriosis in my vaginal cup closure. So now I can make my copotomy here at this point, and that's very, very important. And at times, patient could have endometriosis involving the vagina, So if it's easy to do that after you finish your copotomy. And then you basically, I have already labeled the nodule, the vaginal nodule, vaginally with a suture, and that will help me to serve as a landmark. And basically, we'll go ahead and nucleate the nodule of the posterior vagina. And then basically, almost all my excision endometriosis involving the nodules, I use a squeeze technique so I can bounce off the nodule. So that allow me to remove the nodule in a fairly completely, fairly cleanly. Because of the wedge resection on the posterior vagina, I will close the posterior vagina vertically with a rounding barb suture. And then I will finish the rest of the cup closure transversely, so essentially end up with a T incision to close the vaginal cup. So vaginal endometriosis are fairly easily approachable once you've finished your copotomy. And it's just a typical cup angle closure. Then we can just finish the rest of the closure in a transverse fashion. So this is a consequence of endometriosis that was left behind after a vaginal hysterectomy. This is a patient that had a previous vaginal hysterectomy done at an outside institution, and patient continued to have bleeding and pain after a hysterectomy. And she has this large golf ball sized nodule on her vagina. That's why she continued to have a period despite her hysterectomy. And this is, again, if you compare this to put it in my hands, this is like a golf ball sized nodule. And this can occur. So it's very important to treat endometriosis at the time of the hysterectomy. The other thing that's considered in patients with severe endometriosis is that the perimetrectomy should be done at the same time as your hysterectomy. So in this patient, the ovary is completely fused with the perimetrium. So the perimetrium is then removed along with the rest of the perimetrium. Again, I'm creating some space between the ureter and my energy source. And that way I can completely mobilize the perimetrium off the pelvic sidewall, which has been diseased by endometriosis. The perimetrium is over here, and that's attached to the ovary. Essentially, this is just a radical hysterectomy by removing the entire perimetrium along with the ovary. And after they finish opening the applanation of the colosac, opening up the rectovaginal space, in many situations that patients with ablation of colosac could also have underlying rectal endometriosis. So once you open the rectovaginal space, then you have the rectum, then you begin to palpate the rectum for any nodules. And obviously in this patient, we have done MRI in advance, so we know she had a nodule involving the rectum. And then you can go ahead and treat the nodule, remove the nodule of the rectum. You can see the white rectal probe in the background. And this is a squeeze technique that I use virtually in all my patients with a nodule involving the rectum, bladder, vagina, or any nodule, or metrotic nodule, or anything. I use a squeeze technique. You can use this with an seal device, which I'm using right here, or you can use it with harmonic scalpel. Then we'll just repair the rectum in 2 layers. Fairly straightforward. So the conclusion is that you can minimize the risk of unexplained endometriosis with good history and exam. In treating endometriosis, if you think it is potentially a source of the patient's pain, and most importantly, incorporate knowledge of anatomy into your strategy for difficult hysterectomies. I'm going to stop share. Thank Dr. Mayan and the Russian conference for inviting me again for opportunity for giving these presentations. We'll try to answer questions in the very end of the session. Thank you.
Dear Professor Tedley, Your presentation is of great importance because today not everyone clearly understands the stages of hysterectomy in case of severe endometriosis. We listened to you already many times, and believe me, our Congress is very extended, and we have 60 stars of the international surgery, and we ourselves will use this video as teaching video, and we are following absolutely the same technology. Dear colleagues, now I'm happy to give the floor to Professor Rudi Kamp, because we could not connect him earlier due to the technical reasons. And after Professor Rudi Kamp, we will enjoy our further program. That would be our professors who are supposed to speak today. This is Professor Vito Cello and Professor Waterloo. So, dear Rudi Kamper, dear Professor Rudi Kamper, so we give you the microphone, and we appreciate your view on the problem of hysteroscopy. The mic is yours.
Dear friends, dear Professor Laila Adamian, thank you very much for this very kind invitation. It's an enormous pleasure to be with you at the occasion of this International Congress on New Technologies for Diagnosis and Treatment of Gynecological Diseases. The title of my talk is quite interesting. Hysteroscopy and subtle lesions in the infertile patient. A challenging subject, and all starts with the definition of normal and abnormal. Not everybody calls the same lesion in the same way. Especially for subtle lesions, there's an absolute lack of terminology, which I will show you. It are minimal changes of unknown pathological significance, so very difficult to see what do we do with it. And they can very easily be classified as normal. And then the most important problem in science and hysteroscopy is that there is an inter-observer variation between experts. Those are the Life Expert Center strict criteria of normality: 3D, 2D mid-cycle, and viewing the tubal ostia from the isthmic part by turning the 30-degree optic. Very simple rules. And then we have normal, abnormal, and the topic of my lecture, subtle lesions. They can be subtle cavity deformations of subtle endometrium changes. As the previous speaker has already mentioned, the incidence of subtle lesions in infertility is documented with a wide variety. 10% to 20% if you have in the diagnostic phase of an infertile patient. If you go prior to the first IVF, it's 10 to 40. And if you go after several IVF failures, it increases to 25, 45. The only thing we can say is that, interesting. Subtle lesions could tell us something. First, the cavity. We have the Cummey criteria, and we have normal Cummey criteria, and then we have this hysteroscopy. Well, if I ask Professor Jaime Ferro, is this a dysmorphic uterus? He will say yes. If I ask Professor Ferro, should I do something prior to IVF? He will say yes. We don't see the ostia from the isthmic part. We have difficulties to visualize the ostia by turning the 30-degree optic and lateralizing the hysteroscope. Is this important for reproduction? First of all, how do we treat? This is the Life Expert Center consultation room, the digital hysteroscopic clinic. The blue room, you see MRI, you see a dysmorphic uterus, we have ultrasound, and in the hysteroscopic Cummey negative patients, prior to IVF, we perform the scissor incision of the lateral walls, making a straight line from the tubal ostium to the isthmic part. That at the end of the procedure, and we do it with the scissors, we inspect the subendometrial myometrium, we look at the vascularization, we look if there are no adenomyotic changes. You see the blood vessels. We work at 80 mercury pressure, so very low. and we do not coagulate. We do not coagulate because we put the hyaluronic acid gel at the end of the surgery. And you know hyaluronic acid is like embryo glue, so we don't coagulate if it's not necessary. Then through the hysteroscope, in the top you will see a defect from a biopsy we took to exclude adenomyosis. And through the outer sheet of the trophy hysteroscope, we put the gel until the cavity is compressed, there is no bleeding, and in the subsequent or the cycle afterwards, we go for embryo transfer. So Jaime Ferro, our honorary member here, sitting in the front, has done the best. Attila and myself, we have 214, but the study of Jaime Ferro is, for me, the best because, first, he's a good surgeon. Secondly, he works in an excellent IVF center. Because you need both to have a single center, single observer is the best. And what do they see? In IVI Valencia, they have 190 repetitive implantation failures. And the surgeon, just by putting his little incisions, he has a clinical pregnancy rate of 80%. At 12 months, 76.3%, and at 6 months, 50%. And within the first IVF cycle, pregnancy and live birth rates were 77 and 86. Obviously, you can say this is not a prospective randomized controlled trial, but you cannot deny those results. We have a study ongoing, but quite interesting, in only egg donation patients. And if we have a subtle cavity lesion, all patients receive MRI, all patients hysteroscopy, all patients 2 and 3D ultrasound, all by the same examiner. And we see that 18 from the dysmorphic cavities, which were corrected from 18, 17 have a baby. Whereas in the Asherman or the adhesion situation, also a perfect cavity after surgery, only 47%. Only 7 in 15 take-home baby rate. So quite interesting. Now the most difficult part. Subtle endometrial lesions. I've tried to put all the possible terminologies. And then they are correlated with endometritis, adenomyosis, aberrant endocrinological situations. I give you the pictures here. Strawberry pattern, hypervascularization, polyposis, little synechia, etc., etc. What does it mean? What do we do with it? At the Life Expert Center, at that time Roger Molinas was working with us in Belgium, and he published the results of a prospective randomized controlled trial, abnormal uterine bleeding versus infertile patients. Subtle lesions are different. The infertile patients, it is true, they have this reddish endometrium with polyps or no polyps, strawberry pattern. They do have this much more. The abnormal uterine bleeding patients are polyps, myoma. That's the story, and carcinoma. But that's the story. Infertile patients is much more complex. Necrotic tissue, exophytic tissue, synechia. This is a study which is Roger Molina is doing today in Paraguay, Asunción. He has a big center, Neolife. And he saw that in 1,720 consecutive hysteroscopies in the infertile patient, it's not published yet, it's an ongoing study, 50% have subtle lesions. And from those, 37 are endometrial. And I put the details. Now, he starts with a prospective observational study. Today, 262 patients are included to see if there is a difference in outcome between normal and subtle lesions. In patients younger than 40 and a frozen blastocyst transfer, maximum 90 days after hysteroscopy. The current results are, for clinical pregnancy rate, still non-significant, implantation rate non-significant. There are differences, but miscarriage rate already significant. Live birth rate too early. So I think this study is quite well conducted, is quite interesting. That's the reason I asked him to show his intermediate results. And I'm very interested to see how it will continue and when we can differentiate, because this goes or includes all subtle lesions. So there is a need for uniform terminology. Histology and endoscopic exploration maybe can help us. We have adenomyosis, which is related to the green definitions, chronic endometritis. Do we need biopsy? And do we need a biopsy from what? Il Papo, Ettore Cincinelli, he did everything on endometritis. He put every images into the place. But is this sufficient? Here, this is an image from yesterday, where we were doing surgery. Is this chronic endometritis? We made a little cut in the fundus and we see an adenomyotic cyst. So hypervascularization is not always a sign of endometritis. So if we compare, if we do treatments, we have to know what is the pathology. So how can we do tissue sampling with the trophy hysteroscope, which was named after the trophy study which Tarek El-Touki conducted? We have the major advantage that we can take out the scope and do endometrial sampling, either with a curette or with the spirometry. Here you see under ultrasound vision, because we have always ultrasound in the OR, and then after the ultrasound you do the hysteroscopy, you put back the scope, you see what have I taken, and what you take is actually the superficial layer of the endometrium. And then we have this new world of 3D rendering, three-dimensional histology, in which Manako showed us that 3D images give a totally different view on the endometrial glands. They form a plexus network in the basalis, similar to the rhizome of grass. So if we go to the grass, my question is, do we need information on the rhizome, or do we need information on the roots, or do we need information on everything? This is the spirometry. The spirometry is inserted through the trophy hysteroscope under ultrasound vision. We have here an image also just for demonstration. So we can use the spirometry, we can use the 5 French instruments or the mini bipolar sectoscope to clear or to validate the myometrial layer. The spirometry is, you see here, Stefan Gotz, he's the father of the spirometry. The sample is harvested by turning the helix into the diseased area under ultrasound vision, and then you can make fantastic biopsies. And not only from the grass, because the grass does not include the rhizome, does not include the roots. You have a very well non-cell spreading biopsy. Thank you, Stefan. Then we go to 3D. Those images I received from Kate Isaacson with permission are made by Juan Gnecco from the MIT, Linda Griffith Research Department. They take, this is still from research, this is still from the uterus, the whole uterus, where they take tissue, then they clear the tissue with a clarity methodology, immunofluorescent staining, and then they go to 3D reconstruction with a software which is called Imaris. And here you have an adenomyotic lesion. You look at this vascular structure. And if you start to work with computers, you can make 3D renderings. And you can say, now I want to see the vessels. Now I want to see the glands. I want to see the capsula. Let's render. Look, the nerves. Extremely, extremely interesting, this new technology, the pseudocapsula, which is in development now in MIT. So here, an example. You see the vascularization. This is a little resection of an adenomyoma, and you see clearly all those vessels, which are pinpoint coagulated with the bipolar needle. So let's have another example. You see in ultrasound enlarged wall. You see in MRI, in T2 weight transversal section, You see a structure which can be a myoma, an adenomyoma, contraction, we do not know. And hysteroscopy, you don't see anything special, only a little mucosal elevation is present. When we go to explore the anterior wall, based only on the MRI information, look, we see a little adenomyoma with a pseudocapsula, which easily can be identified by hysteroscopy. We don't see it clearly in ultrasound. Here we see it clearly in MRI, but here hysteroscopy has a major advantage. Exploration of the subendometrial myometrium. Another example, we go bigger and bigger, nearly 3 centimeters. The only thing you see in hysteroscopy is a mucosal elevation. Here you see after resection, big lesion. How will this heal? We put the gel. How will this heal? Will we have major adhesion formation? The first was the scissors, this is with the resectoscope, and this is the result after 8 weeks. 8 miscarriages. I do not know how many IVF this lady had. Positive pregnancy test. Today, still ongoing pregnancy. You see, it's very early, 1602. Interesting. So, to end, I will give you an example from last week, which is quite interesting. You see in ultrasound, 2D ultrasound, a little cyst. You see an enlarged wall. You see that the endometrium is sitting on whatever protuberation. In the MRI, in the posterior wall, you see the cysts, and you see an aberrant T2 weight image, so the black area. In hysteroscopy, you don't see very much. And so the question is, if you explore a subtle lesion, can it result in major surgery? We start always our surgery with ultrasound. And then we go, we see a cyst. Okay. Will we open the cyst now? No. Wait, we go back. So that's the reference of the cysts, but the lesion was before the cyst. So we see this little elevation. Now we go with the scissors, no resectoscope, only scissors to explore. We can take a biopsy if we see that there is no hysteroscopic visual reference. But what we see is again this white tissue, this fibrotic tissue. And under the fibrotic tissue, you will find the vessels, don't worry. And you see here, we are now progressing under the fibrotic tissue, and we have the vessels, obviously, we coagulate and pinpoint, but we see a pseudocapsula very clearly. Look, nice, eh? I love it. Really. This is really nice surgery. This is fertility surgery. Look, again, the same picture, the diffuse vascularization, petechial bleeding, which, oh, look, it's a vessel, be careful, coagulate the vessel before cutting. But we continue with the scissor. Can I go over time, 2 minutes, Professor? I still have one slide afterwards. Okay. So you need really the skills to manipulate your 30-degree optic, turn around, put the visualization, pinpoint coagulation, and then the tissue is removed by shaping or by shaver or whatever. And until now, so there's still to remove. We forgot the cyst. We forgot the cyst. Where is the cyst? Did you see the cyst? No? Stop coagulating. We have to go for the cyst. So this still is adenomyotic tissue. Oh, there's the cyst. But don't open the cyst, you have to remove the capsula. And you have to find this plane. Ah, there you are. You look, this is the plane of cleavage. We got it. So to prevent adhesion formation, we perform hyaluronic acid, HIA region or matter region gel we use. It remains 14 days. In this large defect, we perform a control hysteroscopy 5 weeks later. If everything is okay, if there's no necrotic tissue, the healing is perfect, we go for embryo transfer. If not, we wait another 4 weeks and then we go to embryo transfer. But you see, no bleeding. Eh? So, we discussed, Stefan and myself, I think 1 year, should we do this or not? But we have cases who don't get pregnant, always miscarriage, so we say we try. It heals perfectly in the cases we've done until now. And we are surprised by the pregnancy outcome. We will wait for here the gel, very important. And we will wait for the live birth and the complication rate, because placenta accreta this is the control. After 4 weeks, you see the little indulation, but it heals without. So, is it important to remove the tissue? Again, we see that if we have a normal junctional zone in MRI, we have 11 in 12 patients by removing the tissue, which become pregnant and deliver. We don't have miscarriage and we don't have ectopics, whereas we have a diffuse junctional zone differentiation disturbance, we have only 53%, and if we don't treat, that's the upstairs, there, if hysteroscopy is normal, ultrasound is normal, MRI is abnormal, here you see an example, no deliveries with egg donation in a high-quality program. So to conclude, dear friends, whereas the relevance and diagnosis and treatment of major lesions is well accepted, diagnosis and treatment of subtle lesions remains very controversial. The lack of uniform standard and universal accepted terminology makes research also extremely difficult. Although most of the studies do not find a correlation between, but now I'm very happy with your study, subtle lesions and negative influence, the NeoLife demonstrates an increase in miscarriage at this interim analysis. MRI, ultrasound, and advanced 3D histology might contribute to define tomorrow the importance of some subtle lesions, and hysteroscopy seems of major importance to diagnose adenomyosis and to treat it. Come to the ESG in Brussels. Brussels has muscles. Thank you very much.
Thank you, Professor Campo. We must move on, and we have two very important presentations. Professor Antoine Waterloo, Awareness in Decision-Making in Case of Laparoscopic Complications. He's an honorary consultant of the St. Bartholomew's Hospital, London, the UK. He is head of the Educational Center on Fertility Study. He's a member of the French Academy of Surgery and president of the Lyon Center of Endometriosis. And he's our great friend, a brilliant surgeon and a brilliant scientist. Professor Waterloo, well, we have a lot of countries participating in this Congress. We're slightly behind the schedule, so please do not overrun your time. After Professor Waterloo, Professor Viticello will speak next.
Thank you, Leila, for this kind introduction. Thank you also for your invitation in this very prestigious conference, I will say as usual. And don't worry, I will keep my time. And I start to share my screen immediately. to start with this topic about decision-making and communication when facing adverse event. We have seen beautiful talk. Now we have to speak about something which is less evident, which is problem of the complication. So complication in laparoscopy, 50% occur during entry, and so they occur at the very, very first step of the procedure. Fortunately, complications, as you know, are rare because, for instance, vascular injury during entry is only 1 out of 12,000. But as a result, there is no technical or psychological anticipation, and complications may quickly lead to a disaster. If we compare that to aeronautics, the probability to lose all engines during takeoff is so unlikely that there is almost no chance to see this event in 2 consecutive pilot professional lives. However, the accident is anticipated in the pre-flight checklist before every single takeoff. In laparoscopy, do we do the same? In fact, very usually, no. And so the question is, are we ready for that? Are we ready for this event? You see that very quickly, it can lead very quickly to a disaster, that it is experimental surgery, but you see that very quickly we can have a major hemorrhage, and that it is the problem to be prepared to that. So we have to adopt a culture of safety. In fact, the complications are generally underestimated. I like the rule of 2 when you hear a surgeon telling his number of performed cases divided by 2. And when he tells of his complication rate, multiply by 2. So we underestimate complications, but we all have complications. We are not good. So prevention and complication management before surgery, importance of information and consent, of course. During surgery, we have to mix the soft and hard skill. We'll speak about that. And in case of complications, we have to be prepared to act timely. So during surgery, there is the 3 pillars of human factors, what we call also the soft skill in comparison with hard skill, which are the technical skills. First of all, it is diagnostic and awareness, to be prepared, coping with stress, decision-making, and the leadership or teamwork. Of course, in complement of technical skill, we have to have both. What is diagnostic and awareness? Awareness is that the fact that the complications may occur at any moment from the entrance of the patient in the OR until the very end of the procedure, and we have to reassess constantly the situation, and it is something we have to be prepared to do. So first of all, awareness with equipment is this operation made by a skillful surgeons. So it is during endometriosis, it is a dissection of the ureter. So carry the dissection, I go a little further. So you see the dissection in this sclerotic tissue. You see above the ureter, which is moving, no problem. And then the surgeon continues the dissection, and you will see that he will have a small bleeding, just here. And then he make a coagulation, and he just forget that, you know, there is a jaw and the activity between the jaw, but also it is a little, there is some extension, and so you cannot see when that he do the coagulation. Once again, look at that, makes the coagulation, and what there is above the ureter, and he make a burn to the ureter, and then he have to repair the ureter. So that you can avoid that if you have a good awareness of the situation. So another example, you see this guy, which is doing a knot during a mesh procedure. Probably it is a sacrospinal fixation. Look what happens. He do the knots, and up, it is in the vessels. So that it is a combination of 2 mistakes. The first mistake is a non-technical one because lack of awareness. He cannot see where is he. And also, and it is often the case, a technical mistake because we have never to do a knot. When you hold the needle, you have to hold the thread. So the combination of both big this kind of hemorrhage. Also, the surgeon, we have to be prepared. We have to stay calm in case of complication, which is not so evident. And so the take-home message, which is very important, is to call a colleague when a serious event occurs. that it is something we have to do. Don't be shy. Today is you, tomorrow it will be him. So we have to be prepared to help and prepared to ask for guidance. We have to copy with this first look. It is the beginning of the laparoscopy, and there is a small bleeding, and the guy is losing his brain because you see this bleeding, which is not big. So he's still in the trocar, so he's losing 50% of the information because you cannot see anything. He put the bipolar to make a coagulations, but not under the control of visions. So he has some kind of panic because he's stuck in the omentum. During that time, it is bleeding. Fortunately, it is not a big bleeding. Look at this movement, totally unconsidered. If at that time the bleeding have been very big, the disaster we can have. Instead of stay calm, they kick another forceps to remove the epipleuron. And so during this time, it is still bleeding. Once again, it is small bleeding, okay. It's okay. Now it's okay, and he can start to act timely. So you see, he loses at least 30, 45 seconds. It makes the difference between the small complications and the disaster. So don't you lose your brain. Decision making is an important process. What to do, for instance, in case of a major complications, for instance, if you have a big vessel injury. So look at this operation. It is not gynecology, it is a nephrectomy. This guy is going to put a clip on the renal artery, and suddenly you have a big hemorrhage. You see this hemorrhage. And so I am going to show you that in slow motion. So you see, we have the counting on the bottom of the screen. So the bleeding starts, 1 second. Immediately, good move. The assistant start to try to make a compression, which is the sensible things to do to start to stop the bleeding. So we are now at 4 seconds after the initial event, and you see that the bleeding is still quite heavy. Remember, we are in a slow motion, and the assistant compression is not effective. So the surgeon is coming to help him. He starts the compression. We are 9 seconds after the event, and already he has decided to convert in a laparotomy, less than 10 seconds after the initial event, which is very, very quick. So he has the compressions. Now we see outside. He starts the laparotomy less than 15 seconds after the initial bleeding. Very quick, very good answer. It controls that you have still, some kind of control of the hemorrhage. Now we are a little further. We are almost at 3 minutes, and he is able now to have an effective compression with the manual compression, and then he is able to repair, to see what was the culprit. The culprit was an atheroma plaque in this case, which had broken the artery because it was very hard, and then he makes a suture of the renal artery. You see that it was a very good way of thinking, no transfusions, no postoperative complications. Patient was discharged on day 4. So that it is really a good answer to the complications. Also, anticipations, we have to know our limits. For instance, look, in this case, it is with the use of plasma jet. Plasma jet is a good tool, but it has some complications if you don't care. And you see there is here an hemorrhage. And this guy is a good laparoscopist, so he don't panic, really. Very important, he controls the bleeding. He has the suction aspiration, and suction aspiration is the key. It is why we have to use suction irrigation in every laparoscopy, because if you have any bleeding, if you have suction, you can do some things. If you have no aspiration, you are totally lost. So it is like your swab. So you see, it is controlling the situation very gently to see where it is bleeding. You see, you have so 2 forceps to control the bleeding. You have the aspiration very close, so there is no risk to be lost by a big bleeding. And then he's going to put 2 clips around the hemorrhage. You see that. Since it is a big artery, we cannot just close the artery, so he makes the suture, and at the end, he can remove the clip and continue the operation. So that is something you can do. So it means that if you are comfortable to do that, you can do that. If not, you have to convert. But it is important, it is not to lose time, because when you have big hemorrhage, the time is the key factors. You see the end of the procedures. Then now the team and the leadership, which is something important, that it is a concept of medical team training. We have to know that in complex activities, we do 3 to 5 mistakes per hour on average. 80% will be corrected by the responsible and 20% by the team. So the team is very important, and we have to accept the fact that we all do mistakes, no matter how good we are. So the team is critical. For example, the preparative briefing or timeout to check the equipment availability, but also to reinforce the cohesion of the team. They are included in the whole process, and sometimes they can see things that you have not noticed. So it is very important to pay attention to your team. So the conditions, it is for a good relationship and communications, is important in order to accept that the leadership has to be autocratic during complications. It is not the time to discuss. And we have to implicate the whole team, including the nurses, anesthesiologists, and so forth. But don't forget that you are the team leader, and it is a role that you have to consider by very important when we are doing surgery, and especially in case of complication. Therefore, in the OR, complications are unavoidable, and difference between near miss and disasters depends on the quality of management by the surgeons, but also by his team. Now, quickly after surgery, in case of complications, the fact, if the doctor is sued, the expert will scrutinize very accurately the timing and the delay to manage the complications. It is proven that a delay exists in more than 40% of cases. It is important. So we all have the dilemma when you have complications to redo surgery too late or to redo for nothing. And of course, it is a difficult decision, but we have to take it. And we have to ask ourselves why an excellent surgeon loses his brain when it is necessary to re-operate a patient. We have a lot of contributing factors, like exclusive confidence in exam like scanner, which are proven to be not very reliable in the early postoperative phase, misinterpretations of the situations, the most unlikely hypothesis is favored, lack of communications, and the difficulty for doctors to accept his own medical failure. Communication difficulties, some words, because we see in a lot of cases difficulties to dialogue with the patient, to announce bad news, for instance, to say to the patient, we have to make a reoperation. And in these occasions, there is a critical importance of the preoperative information. If the patient is aware that the complications may occur, it is more willing to accept it. So very important to have say that before the operations. Also, we saw from time to time difficulties to show empathy, and also difficulty to call a colleague. And if you are not sure if we have to reduce surgery or not, don't hesitate to call a colleague guidance, because it may help you in a lot of cases. So in conclusions, we have to reinforce the place of human, we have to anticipate, make standardizations, and we have to make training in human factors and team building. And I think that it is something which is important, because at the medical school, very often, at least in France, it is just starting now to have some training in human factors. So we are really not prepared to do that, and it is something we should consider. And after surgery, something which is important is the good information to show humanity with the patients. We have to accept the occurrence of complications and be prepared for the worst. We have to dialogue with the patient and the family. And lastly, to make traceability, because we see a lot of doctors who do very, very good job, and they see patients twice a day after the surgery, but they don't put any mark on the patient files. In case of medical legal actions, the judge say, okay, we have not seen the patients. In fact, we have seen the patient, we have not written any words on the file, and that it is a pity, because they will consider that we have not made a good following, even if it is not the case. So the take-home message is, be prepared mentally that it is a non-technical skill. I hope to have demonstrated that it is something which is critical. Of course, we have to train to react properly, that it is a technical skill that we have learned that in the medical school. Be a team leader, don't forget that, and overall stay human and a brain user. And I thank you very much for your attention.
Well, dear Antoine, thank you very much. Your presentation was the most important. And what is the most important is you say, be prepared. If we are prepared, well, there will be no complications like that. That's a key moment. Dear Antoine, dear Professor Vautrilot, thank you very much. And we have Vita Cella, who is a professor at the Department of Aesthetics and Gynecology, Pisa University. She is an expert on robotic surgery, the director of the IVF of the University Hospital. And Professor Cella would like to say how far we can go in robotic surgery and gynecology, experience of more than 2,000 cases. Please, the floor is yours. 3,800 people are watching you.
Thank you very much, Leila, for the invitation. It's always a pleasure to be with you and share our experience in robotic surgery that started a long time ago. So, okay. As we know, robotic surgery started in the United States probably in 2000. They made the first robotic surgery, was a thoracoscopy, and after we had developed of robotic in all the world, and also we have a develop of technology. So we start with the standard robotic with intuitive in 1999, and after we had new machine. Sorry, but I don't know how. Okay, the robotic was a innovation, was like a wild horse, and you know, a wild horse you have to ride, you have to keep galloping, and after day by day you have to train him and bring to the normality. This is the robotic surgery. At the beginning, it was very expensive, it is still, and so we have to we ride robotic surgery, and we have to try to keep robotic surgery to the normality. But the robotic surgery is not only surgery. So we speak about surgery, about ureter, about no, it's not only that. Robotic surgery, because it's costly, is another things, is also organization, is integration, and is still is a developing technique. We made the first hysterectomy in 2007, and after day by day we develop the hysterectomy, and we try to understand and give us the guideline. First of all, we thought that we need a multidisciplinary approach. There was no, in our organization was not only gynecology, but the organization was many other medical like general surgeon, urologists. And after we thought that it was important, the training, it was important to standardize the procedure. It was important to increase the volume of surgery. This is why the multidisciplinary approach, and to make effort to try to do surgery with complex procedure, and also to centralize the robotic procedure. So I'll show you the first procedure in my hospital was in 2001. It was a cardiac surgery. The first hysterectomy was in 2007. And we, at this time, was uses the standard robot. After we bought the second robot in 2010, the third robot in 2015, and now we have 4 robots 2021. So it's a multidisciplinary approach. This is the specialty: gynecology, colorectal, transplant, pancreatic, liver. So all the specialty, all the surgeons, we are 36 surgeons 38 procedure, and we made it up. In the same time, to reduce the cost, we increase the number of procedure. Actually, we perform 1,500 procedure every year. And we also increase our surgery. You see, we started in 2007, was the first, and after every year, you can see how gynecology, we increased in 2040, we had 600, around 1,000 surgery. Actually, our center done 40,000 surgery from 2007, and we are around 3,000 surgery only for gynecology. You see, gynecology is the 90th, actually is doing the 19% of surgery in robotic surgery. But doing robotic surgery mean also standardize the procedure. Standardize mean if we have to know, we have to check the pre-surgical, the surgical, and the post-surgical, because we want to see how the costs were for each surgeon. So we try to understand which were the cost, and we try to understand which were the final cost. There was around 9,000 euro for a radical hysterectomy. So the country give us 7,500 euro for radical hysterectomy. That means then we should work in that and bring back for the hospital around 2,000, 3,000 around 2,000, 3,000 euro to reach to enter for our economically approach. So standardize mean also understand and think about to reduce the cost. So we were working about in the instrument in different way. One, use the number of the instrument used. They try to reducing the operative time to increase the number of the procedure, and for that we should train more the robotic surgeon. We also stimulate the multidisciplinarity. Of course, gynecology is not much more is bring less money in comparison to other specialty like thorax, cardiac, etc. So multidisciplinarity at the end help to decrease the cost of the robotic surgery. And also, if you increase the procedure, you can talk with the factory and say, okay, we are increase the cost, we increase the number of surgeries, so you can decrease your cost of the robotic tools. We also work in surgeon. This is 3 types of surgeon doing radical hysterectomy, and you see the surgeon C spend 56% more than the surgeon A and the surgeon B. So something was wrong. So we talk with the surgeon and we try to put back to discuss with him why he was spending more than the other. And also, we increase the complex procedure. Complex procedure were what mean doing oncological cases and also obese cases, because they make more money for our economy. But robotic surgery, I would say, is also organization. Organization is a lot of mission. The mission we create a hub, a robotic center, and from all the other hospitals around our hospital, surgeons could come in our hospital to make surgery. So we ensuring consistency of robotic surgical practice, we achieving outstanding quality standard, and also we optimizing OR and platform or utilization. So we had the dedicated OR, we had the dedicated ward, and also a dedicated training area for surgeon. And also another thing that is very important, usually people like to have gynecology to bring the nurse from gynecology. No, all the nurses were specialists in robotic surgery. They were working with general surgeon, gynecology. That means that they can change surgery room very quickly. They know the instrument better than the other nurse. Also, we had also a management team of the hospital to work for the cost of robotics. So we built a training with the simulator. We make a course, we make a master, we trained our surgeon, and we trained also surgeon outside our center. We in our training program we had also the double console, and in this case we standardized the for instance the hysterectomy, teaching to our surgeon how do hysterectomy in only one way. Of course, after people can change, but we try to standardize. The standardize means reduce in this way the cost. And also we build a curriculum. This is a curriculum, the CERCS curriculum. So we built a curriculum for a robotic gynecology, that this is very important. So this is my experience from 2007 to 2022. 30% for hysterectomy for benign disease, 32% for hysterectomy for benign cancer, and also deep endometriosis, myomectomy, colposacrocepsy, tubal reanastomosis, lymphadenectomy. And I start with the hysterectomy, of course, with the easy hysterectomy. So we never start with big things or with huge things or with very difficult surgery like endometriosis. And after hysterectomy, I made tubal reanastomosis, myomectomy, colposacropexy, and after radical hysterectomy, and for the end, deep endometriosis, because I think deep endometriosis is the most difficult because you are working with a young woman. It is no cancer. Next step will be uterine transplant with robotic surgery. How do we say? We start with hysterectomy and also we extend the indication. So the patient with previous treatment, chemotherapy, obese patient, high risk patient, ASA 3 and ASA 4. So the indication that I treat is a benign indication like fibroids, abdominal bleeding, endometriosis, pelvic pleuras, and ovarian growth, and also malignant indication has endometrial cancer, cervical cancer, and ovarian cancer. And after, also we publish a lot of paper in endometriosis, paper in infertility, paper in myomectomy, and also this we are increase our publication in pelvic lymph node. But I'll say robotic surgery is always a developing technique. So we are to develop intraoperative ultrasonography, so we can do ultrasonography in the same time inside the robot. This is robot has a TilePro, and TilePro is special tools then allows us to use ultrasound in the same time than robotic. We develop an app. The name is Hysteronaut. We can put in the app our MRI, and with the app we can do this is an endometriosis, you can say a reconstruction, and the reconstruction of endometriosis, you can see two ovarian cysts, you can see a nodule inside, and after use the reconstruction also for our surgery, and try to overlap our 3D reconstruction with our surgery and see where is endometriosis and where we have to go to touch. This is in endometriosis, in myomectomy, and so on. But say, is still a developing technique, robotic surgery. And sorry for that. At the end, and I want to be longer, more than 2,000 mean a lot of surgery, of course, but mean also develop an organization, because you have to be organized for that. We need the organization around you. We develop training. That means we are trained, but we train also people, and also we try to develop a new technique that we develop surgery, introducing ultrasound, introducing 3D in our surgery, try to overlap imaging with robotic surgery. Thank you very much.
Dear Professor, yes, what is it? Dear Professor Cella, Professor Vito, what I want to say, this is what we've been looking for. Thank you so much. Your huge experience, over 2,000 operations, means that robot is worth it. It's certainly worth it. And we should not be afraid of robots. I'm now waiting for this robot become something like not only intuitive, but it will be working more in depth, helping us. Like, as you know, I got robotic certificate by Professor Maresco. I studied there, and I also belong to robot surgeons. Thank you so much for the presentation. Thank you. And we continue our work. The floor goes to, is part of the plenary session, comprehensive approaches, integrative new approaches to the treatment of gynecological disease. Assistant Professor of the Chair for Murvatov. 3D
моделирование мочеводящих путей и сосудистых.
MRI modulation of the bladder and in diseases of uterus and adnexal masses. Simulation of urinary tract and pelvic vascular system. Professor Kamal was the first to create an atlas for MRI and for spiral computer tomography SCT. Please keep the time, 15 minutes to go for you. Please try to be on time. Try to make it shorter. Thank you. Distinguished chair, distinguished colleagues. Oh, mic is off. Oh, sorry, what is it? I can't share my slides. What is it? Sorry, my computer cannot share the slides. Could we have the presentation up, please? Could we have it up, please? Could you share your slides, sir? Okay. Now put it at full screen mode, and this would work. Good. It works. I'd like to show you multispiral CT to diagnose urinary tract and vascular disease. In recent years, alongside with other methods of imaging, such as ultrasound and MRI, which belong to first and second level, we now adopted a null method of imaging, such as multispiral CT, to diagnose vascular system and urinary tract in patients. One of the most frequent diseases seen in gynecology is varicose vein enlargement and chronic pelvic pain. And I'd like to show you in this slide normal anatomy of the ovarian veins, which fall into to the left vein, and to the right they fall into the inferior vena cava, IVC. If a patient has a pathology, if she has enlarged veins, look at this slide. Enlargement of left ovarian vein to the right, and it is very visible where we can see, apart from this enlargement, we also see in ovarian veins that are very much enlarged, like bulb-like enlargement. In other situations where we see combined pathology in uterine masses and enlargement of the veins, this 3D image gives you a clear picture there are enlarged ovarian veins in this patient and enlarged ovarian artery, which help the surgeon plan step-by-step intervention. In combined pathology, where we have tumors and other cysts, cysts are well visible in multispiral CT, and we may also evaluate venous flow, blood flow in pelvis. Please look at enlarged ovarian veins in this patient. Based upon this, you can build a 3D image in 3D and do a multi-planar reconstruction, very much like you see in this slide, where we here see an enlarged ovarian vein to the left, to the right, and to the left we see enlarged veins too, ovarian veins too. If you have a picture like this, we would choose how to approach this patient. Do we do surgical intervention? We tie ovarian veins, but best would be do embolization with navigation of ovarian veins. Multispiral CT helps us evaluate urinary tract, especially identify defects in urinary tract, pulse that are typical in congenital defects of the uterus and the vagina. In the top left, you see dystopia of the right kidney, and you can evaluate the degree of blood flow, blood supply of the kidneys which are in the pelvis. Apart from that, we can see other congenital defects, such as Z-like deformation in the upper third of the ureter, L-shaped kidney, U-shaped kidney, and at that, we can say that multispiral CT is also helpful when you see large masses, very much like here, giant size tumor that rises in the uterus, which grows into parametrial space as well as into retroperitoneal space, thus obliterating the ureter. And this slide shows it pretty well that it switches off the left kidney, basically. We see impaired function of the left kidney, and we also see that it leads to situations where the aorta pathway is malpositioned. In pre-op preparation and investigation in this situation, patient was identified with a thrombosis of the left ovarian vein, which spread into the lumen of the left renal vein, which helped postpone the operation until we address the situation. This image shows you a pretty good picture. Patient with a combined morbidity. She has a kidney defect, nephrostoma, because of obstruction of the left ureter, due to endometriosis. And the previous slide also showed that this cyst of the retroperitoneal space leads to stenosis of the external iliac artery. What did you do then? As we planned the operation, we planned a hybrid operation. We did laparoscopic removal of the endometrioid cyst, and you see the chocolate color contents. It means that indeed it was there in the retroperitoneal space, and we used hybrid operation, involved cath lab surgeons. We did angiography, angio repair of external arteries, and positioned the stent in place. 3 months later, repeat multispiral CT showed iliac arteries that were fully restored. In other situations, hybrid operation that is used in jointly with urologists, where we have enlargement of the ureter or obstruction of the ureter because of some masses that rise from the pelvis. In this slide, this is a post-op pic, lymphocele that has been compressing the ureter, which leads to hydronephrosis to the right. Tumor of the right ovary, compression of the right ureter, lower third as well as enlargement of the pelvic cups. In this slide, you see serosocele There's especially of panhysterectomy, hydronephrosis to the right, with impaired function of the left kidney, and nephrostoma was positioned in place, combined pathology. Sometimes multiple myomas in endometriotic patients may lead to obstruction of the ureter and may lead to something that we see in this slide. In our activity, we've been using very actively ultrasound navigation, ultrasound guidance, and we do it when we do classical reconstructive operations to keep the uterus in place, to preserve, to save it. Through 11 millimeter trocar, we put a US probe which evaluates the condition of the uterus. We identify the nodes which could not be palpated. Other than those two novel technologies that we adopted, which, as I say, are hybrid, that are done ultrasound operation during the operation, there's also novel technology. This is segmentation, where we build 3D during using all sorts of software, which helps the surgeon evaluate the lesser pelvis and take the adequate right decision to make sure we provide surgical care to our patients. In cases where patients have disseminated and widespread endometriosis of retrocervical endometriosis of the retroperitoneal space, we do what we call novel technology. This is CT colonoscopy, where we evaluate not only the functional condition of the colon, but we also evaluate the tonic peculiar features of this organ. And at that, multispiral CT helps us do 3D image, build it, and thus choose the proper way to operate as patient. So, dear colleagues, in conclusion, I'd like to say that alongside these imaging is ultrasound, MRI, which we widely adopted, which, as I say, belong to frontline, second line. Multispiral CT helps us diagnose the pathology, both in the abdominal cavity as well as build 3D images, which helps the surgeon take the right decision, and in this way build a roadmap. Well, thank you very much, Kamol Jamaholich, for a brilliant presentation. I do hope, dear colleagues, you appreciated the beauty of these slides. And Professor Kamol Jamalhonovich is one of the authors of modeling of the operation and intra-op navigation. Thank you so much. Thank you. Thank you. We now give the floor to Professor Biergenar. Professor Biergenar from St. Pete, custom-made approach in treating endometriosis, in charge chief specialist of the Committee of Healthcare in St. Pete. Well, Professor, the floor goes to you. Please, much as I adore your presentations, please try to be in time. Leila Vladimirovna, dear colleagues, it is with great pleasure that I take part in this event. I mean, indeed, fully enjoying fully this information that we are getting here. Very much like the very format. I don't know what is going on. My slides, I cannot share my slides for some reason or other. You know what surprises me most? That indeed we seem to be speaking, we're speaking about endometriosis, but each expert, both Vito and Rudi Campo, and all, they are all very bad patients, and they all have the same diagnosis, endometriosis, that you've been working on all your life. Thank you. And I want to say this thing which you might think is something like a challenge and a provocation. I hope you will share my position. There is no such thing as endometriotic patients that could be thought as patients with mild disease. Right, there are different stages of the diseases. You may say they have stage 1, 2, 3, but it's always a challenging disease. always a challenging disease. It really requires this sort of approach, very much like was shown by Professor Muratov. Very often we need to have navigation and guidance, use ultrasound guidance. We must have a pre-op evaluation, how spread it is. They are difficult, challenging patients. And only expert centers, tertiary care centers, and I suppose Kulakov Center is top center in this country. Another point that was made by Rudi, there are no oncological patients. They're severe patients with such difficult stories that sometimes require all sorts of approaches. And they're patients where it is not a life-threatening disease, where we fight for this quality, but we are also facing complications and difficulties, you name it. Our colleagues have shown us brilliant images of how to operate. Mario has been working. This is a nerve-sparing surgery. We have adopted this and we'll look at main stages, and this is a very important point. You must really allocate the space, you must allocate sympathetic and parasympathetic fibers of the ischial nerves and of the lumbar nerves so that we could improve the quality of life, no matter whether it is a radical operation, a resection, or organ sparing, because in most cases this is what young women need. But this is again another provocation that I want to share with you. This is an instrument in our hands. Despite this high-tech, cutting-edge technology, I was amazed by hysteroscopic technology by Professor Campos. Still, we cannot affect the underlying reason. It is not a pathogenetic therapy at all. Of course, when we speak about operations, it's important to avoid reoperations because this means high risk of complication even further. So our approach takes it as a surgical disease, but it's something chronic that requires comprehensive approach, long-term therapy and medication. This is a component, main drug therapy is the main component of the comprehensive approach. And the presentation I'll be giving you today, we need to evaluate the need for long-term therapy in post-op time after this organ sparing has been done. Very many women with marked pain syndrome, and our data say that over 70% of patients where pain may be exceeding 7 or even up to 9 points in VAS, important component in quality of life, but infertility is seen in almost 40%. Look how many approaches in outpatient setting in terms of therapy, but not all of them are in line with the guidelines that will be updating and revising this year. This work would be led by Leila. And we need to be looking at evidence-based medicine. And what follows, only 4% of women got their pain arrested. So 11%, 2 operations, 47% are the women that only had only one intervention. Post-op setting therapy that we did analyze in our patients.
This is a very important moment. So 31%, every third one, no treatment was received. And this is also one of the reasons why we have such prevalent diseases and presence of relapses. And also I want to say another unfavorable aspect, that 22% of the females who got relapse, the treatment was initiated by doctors. And sometimes this treatment is not matching the guidelines. So this is invasion into the large nerve stems of the small pelvis, also lesions even in the intact abdomen. So all these morphological criteria should correlate with the intensity of pain, but it's not always correlating. We have to say that morphological assessment was pretty deep one, not only trivial morphology, also immunohistochemical and also the assessment of reactions to the inflammation, vasculogenesis. And when we see all these examples, which are demonstrated perivascular growth and all these reactions related to the endometriosis, expression of the fibrotic marker, which is PGP95, which is another important component, very big lesions which are prevalent for the whole gut wall involving even mucosa, infiltrates which are going deep into the muscular wall, into the muscularis. So all these aspects definitely confirm, once again, clear need of the comprehensive approach, complex comprehensive management, post-op management of these patients, which should be done individually. So in this group, which I'm demonstrating at step 3, we administered hydrogesterone that could be used in different schemes, different doses, very tailored approach, depending on the plans of the patients. Why specifically the hydrogesterone? We used different options and we love different groups of treatments, but we still believe that it's very important to select one specific patient, one specific treatment. So here are all the advantages of the drugs presented here. So here are results 12 months after the start of the treatment, 12 months post-op, pain intensity dramatically reduced up to 1 point, dyspareunia and chronic pelvis pain reduced, and also it correlated with the quality of life and with intensity of sexual life. Colleagues already shared the results of pregnancy rates after hysteroscopy, 70%, and we got a little bit less, but these are patients where not hyster but laparoscopy was performed, so two-stage approach, and we are supporting that actively. We believe it's very important to be in contact with outpatient clinics because something that is administered in a patient should be supported outpatient, and drug selection always in the hands of the expert, always keeping in mind all those individual capacities our patients demonstrate. We have lots of options. They're all presented here. And these options are shown, and it demonstrates all schemes, different schemes, because if pregnancy is not planned, so that could be scheme for quite a long time. So patient is not staying treatment free. Effective treatment, maximally safe, with participative approaches that we all know very well. So as you know, this data was approved by Fertility and Sterility, and we are very proud of that. And in the next issue of Gynecology, we will see new algorithms of patients' management with endometriosis. So this is consensus position of Russian experts. And I think that in the nearest meeting of the Regional Society of Russian Society of Gynecologists in St. Petersburg, we will have a very detailed presentation about that. So here are my conclusions, and once again, I'm emphasizing endometriosis is chronic surgical disease which requires surgery in majority of cases and very long post-op treatment. And thank you very much for your attention. Brilliant, brilliant, very crystal clear, very smart, very precise. And thank you very much for your service to medicine. Thank you very much. So hope seeing you again. So very soon we'll see each other in St. Petersburg. So distinguished colleagues, and now it's my greatest pleasure to present Professor Krecht Lyubov. Endometriosis and adenomyosis in females of reproductive age. And this is the title of the presentation. Specificity of relapsing of immune system with different stage of process. And dear Lyubov, microphone is yours. Microphone is yours. Dear Leila Vladimirovna, dear colleagues, so it's a great honor, as usual, it's a great honor to participate in such fantastic forum and speak up in front of professional audience of clinicians who help to so many females in their daily practice to understand the reasons of pain, to overcome problems related to infertility, to prepare to pregnancy, to finish the pregnancy and get the delivery. So that means to implement the reproductive function. That is why problems of endometriosis are quite prevalent, and any practitioner, gynecologist could face that. Pathogenesis of endometriosis is a mystery for several decades already, and for at least 40 years we carry out precise studies. We look at the immune system in patients with endometriosis. We try to understand how immunity is involved into there. One of the first Russian publication is starts of publication in Perm Medical Academy, laid by Professor Bolezin and also Marchok Torobarova-Tkachenko, carried out in our center, led by Professor Adamian and Professor Sukhich. In these publications, even at that time, we characterized suboptimal lymphocytes in the peritoneal fluid and peripheral blood and the change level of cytokines there. But it is very interesting to know that at that time, authors concluded that endometriosis is not autoimmune disease, but is characterized by functional disbalance that correlates with the severity. For the last 40 years, immunology dramatically developed and extended the limits of knowledge how immunocompetent cells behave in physiological and non-physiological processes. And currently, endometriosis is immunocompromised disease. There are new methods that are strongly different from the methods that were used 40 years ago. And Professor Stefano Bittocchi very brightly demonstrated us today the difference between the methodological level of today and the second half of the 20th century. There are new methods that allow very fast and routinely visualize the surface of lymphocytes to assess their activation and suppressive status, production of cytokines in different conditions. So in parallel with new methodological approaches, we analyze the condition of immune system by these methods in endometriosis in terms of search of non-invasive markers of the prevalence of the process. In 2022, United States, there was published a 3-volume book, Immunology and Reproduction, led by famous immunologist Gilles Mora. And there is a very big volume devoted to endometriosis. And very impressively, they put together fundamental studies on endometriosis currently, which are quoted also all over the world. And Russian publications are also there. We have very good laboratory, and at modern level, we can look at the subpopulation of lymphocytes, and we could look at the level and production of cytokines in peritoneal fluid, in peripheral blood. But the objective of this work is to identify specificity of interaction between the subpopulational cells of inborn immunity and the level of cytokines in females with endometriosis of different prevalence, also in peripheral blood and also in peritoneal fluid. In the prospective study, we recruited females with the endometriosis grade 1, 2, 3, 4. And the control group were the females with non-complete septum with the absence of inflammatory and proliferative diseases, which was confirmed laparoscopically. We provided phenotyping of immunocompetent cells and fluids. We used site flow cytometry, and multiplex analysis. We identify a big spectrum of different cytokines, immunoregulatory molecules in the diluted forms. Recruited females were not different according to the background characteristics, but as expected, endometriotic group had stronger pain, not related to menstruation dyspareunia, delivery rate, and infertility rate. So what is our final result? At the systemic level, females with endometriosis have higher level of total rate of leukocytes, neutrophils, monocytes, and neutrophil leukocytory index. In females with endometriosis, there is no difference in killer cells in peripheral blood versus control group, but there is a lower level of T-regulatory lymphocytes and lower level of monocytes. And totally opposite, in the peritoneal fluid, there is high level of killer cells, both with regulatory and cytotoxic function, with a different level of other cells. About the cytokine production, in peripheral blood, we see no intergroup differences, and in the peritoneal with endometriosis in both groups with a high level of pro-inflammatory IL-6, 8, 10, and also there is clear trend to increase the level of chemokines. What does it mean? What does it mean? So according to the last 3 slides, we could tell you that females with endometriosis have very clear features of the inflammation development. In order to understand the role of cytokines and possible mechanisms of pathogenesis and endometriosis related with the development of inflammatory reaction, we carried out the analysis of diagnostic significance. So it appeared to be that in the grade 1, 2 prevalence, it's important with diagnostic evidence to detect chemokines, and in endometriosis grade 3, 4, the level of IL-6, 8, and also ratio of pro-inflammatory cytokines versus anti-inflammatory. So, at early stages of endometriosis at local level, we see proliferative and angiogenic processes. At the later ones, chronization of inflammation. In order to assess whether the cytokine profile is reflected at a local level at the peripheral blood, we carried out particular correlation analysis, which is presented as parallelogram and also as a chart here. And here in the chart, you could clearly see that the only strong correlation at systemic level could be seen in endometriotic females, which is demonstrated in between cytotoxic T lymphocytes and regulatory IL-12. But in order to understand what could be studied there as non-invasive marker of prevalence of the process, we carried out correlation analysis of subpopulation content of cytokines in peripheral blood at systemic level. So what did we get at the end? We identify very strong correlations between the parameters that were assessed in each specific group, but in each group, combination of these links was different. For the first subgroup, with the low prevalence of endometriosis, it is typical to have connections of cytokines with cytotoxic T lymphocytes and NK cells, and no link with monocytes. So altogether, it shows the dysfunction of the congenital chain of immune system that leads to heterotopy. And for the second subgroup, it is typical to have monocytes, growth factors, and expression of C20 200 pro-inflammatory marker. That means that there is a chronic inflammatory process. This analysis allowed us to conclude that females with different rate of prevalence of endometriosis have different features of inflammation. In first case, it's acute. In subgroup 3-4, it's chronic inflammation. And wrapping up, I would like to say that our suggestions that active immunological reactions could be seen to early stages of endometriosis could be presented even very first publications on endometriosis performed by our and also British and American scientists that are quoted in the publication of 2022. So in this study, we used very modern methods of analysis, and we confirmed that. So the search of non-invasive markers of prevalence until now is very relevant, and we do hope that with the development of new opportunities, we will not keep this problem. Finally, we will reach the solution of that. Thank you very much. Lyubov, you made me touched. You touched me very much. You showed our results, your results. Then you recollected the story of 70-something. And I'm very happy that as soon as Gennady joined our center, with your labs, we managed to perform very significant works in immunology of endometriosis that the whole world is referring to, and many others. So you will now report at any of our forum, and thank you very much for that. So, dear colleagues, and now I'm happy to give the floor to Professor Svetlana Dubrovina. So this is relapsing of endometriosis as a clinical opportunity. So what are our clinical opportunity? And this is a fellow from Obstetrics and Gynecology Pediatrics, Moscow State Medical University. So, dear Svetlana, now the microphone is yours. So in your manner, very clear, crystal clear to all of us. So let us know to know more. Dear Leila Vladimirovna, dear colleagues, dear friends, before I start my presentation, so in all possible forms, I would like to express organizers and personally Leila for that honor which is given me today, and also to present my vision of relapsing endometriosis, and then we can prevent it. And I can say that it's very difficult when today, we already 2 days have been talking about it in detail, and the leading experts are participating. It's difficult to add on something, but I would like to go back to the issues of pathogenesis. And today we understand that without pathogenesis, we cannot move on in this disease. And also today, what is most leading is the uniting theory of implantation, theory of metaplasia, so that means transformation of cells in endometriosis, which is more aggressive type, more mobile type, more invasive type versus epithelium, and all that is united by this theory of the stem cells. If we speak about verification of endometriosis, we see that in the discussion of that, what can be mentioned like endometriosis? So this is a very relevant issue of glossary, what endometriosis is. And also it was related to the fact that if we say that this is endometriosis, verified in laparoscopy, then we cannot administer ex-vivacious treatment before we do the surgery. So that was removed from ESHRE, and we kept only the diseases localized beyond, which does not require verification, and that's surgical. But on the other hand, we clearly understand that we miss quite a lot. We miss quite a lot. Even with the great presentations of ultrasound where there was clear verification of the nose, etc. But nevertheless, if today we take in total our data, how we verified endometriosis, that in 90% of the cases we could verify it even endometrioid cysts. But on the other hand, deep infiltrative endometriosis is a disease. Is a disease. If you look at these 2 days of the Congress, with the same technique, different approaches, every surgeon up to the approaches, opening, and then sequence, some nuances for everyone. So that's anamnesis, medical history, examination. And it would be very helpful for us, even in manual examination, which is also very important, with MRI, recent data, etc. Endometriosis is one of the diseases which is clearly showing that today a lot depends on the professional who is taking to treat endometriosis and correspondingly selected this or that tactics or approach. Philip Koenigs also participated in this conference, but if we exclude endometriosis on MRI and ultrasound, but still there are some symptoms that can potentially be associated with endometriosis, so we can miss the disease. We try to avoid excessive surgeries if there is no need to do that. And also it could postpone the disease and lead to more severe processes that require extended interventions. And another conclusions that also can be made today with the publications which are available, we can say that if we speak about deep infiltrative endometriosis, and actually not many surgeons of the world can do it. Speaking about endometriomas, well, the situation is more or less clear for those who are doing it laparoscopically, and hopefully they are performing the surgeries correctly. And today, currently, endometrioma removal surgeries are not challenging, they're standardized. We discuss the techniques, but still we cannot have complete standardization of these manipulations. Looking at the literature which is available, we know very clear that if we don't administer anti-relapse treatment, so we should expect relapse 7 years later in 72% of females. And this is separate chapter of ESHRE about the relapses of endometriosis. So that's why it is different from previous ESHRE of 2014. So these are recommendations of ESHRE. They emphasize it. And also we checked the glossary, and also we checked the definition of endometriosis. So how important is to all of us whether ESHRE is available? You can follow this QR code, and there's a use of trainings and positions. But whatever we say a lot, so in order to avoid repetitive operations, surgeries, we need to administer anti-relapse treatment, because we're truly not eradicating the disease. But nevertheless, only every fourth woman now, statistically, is getting this anti-relapse treatment. It's an important question here. It should be the legacy between the inpatient and outpatient, regardless the histology. So definitely we should tell the surgeons. Surgeons are trying to do their surgeries very nicely, but they don't pay attention to the patient post-op in order to administer anti-relapse treatment. And sometimes there is no link in between these connections, inpatient and outpatient. Patient leads to the fact that we see the relapses, and that's another important problem. In order to prevent the relapse, there should be compliance. Today, peak endometriosis, first onset of endometriosis comes to the age of first pregnancy, and sometimes before that, and in order to prevent that, we need to have drugs that first would have minimal side effects and the patients would take them for quite a time, and also they have to suppress the lesions of endometriosis, and plus to that they have to preserve fertility.
Негативно некоторые из препаратов. И на эктопический эндометрий, а не только эктопический.
So that's ectopic pregnancy, which is clear in the lesions. Another important moment here, that we speculatively believe that the reduction of menstrual volume with the change of microbiome from the uteral cavity, which ruins the microbiome of abdomen, could prevent, it could be helpful, for example, to minimize the risks of endometriosis and to eradicate endometriosis from that. Continuous gestation or COX, oral contraception, that could be prevented, but again, that's quite speculative about the microbiome. Although Robert Cuthbert was one of the first in the world in 2011, he raised the question about the negative influence of estrogen component oral contraceptions, which make symptom easier but could worsen and hide endometriosis and also make worse the cause of deep infiltrative endometriosis, which was shown many times before. So yes, we see such consequences, and the most important, even if we do the surgery, then this process could give us very severe adhesions. What else? The analysis using COX for females with endometriosis showed us that for 30% it's not effective, and every fourth one stops combined contraceptions because of side effects. And in the recent Congress of the World Society of Endometriosis, which was carried out in St. Petersburg this year, I represented Russian Federation here, and there was some unpublished data, preliminary data from Canada, where colleagues emphasized that regardless of the fact that still many contraception is administered, every second one is refusing because there is no efficacy. So beside that, I would like to emphasize once again in the diagnosis, this is a worsening of the disease, and in the future, possibly the presence of deep endometriosis or potentiation of that. From the gestagens that we are using at the first line of treatment in the Russian Federation, so, and here we see Gynecologic and noreldestrone, and also gestagens are also used, and Ashley emphasizes that this is the first line of treatment. Dihydrogesterone showed its efficacy within last 63 years to be used, but let's say recent studies of Kitavaki and Turkish colleagues showed us that again they actually assessed the efficacy of dihydrogesterone for the treatment of endometriosis to reduce pain syndrome related to the menstruation, no menstruation related to sperinia, and change sizes of the cysts. I want to draw your attention that sometimes in gestagens about the continuous use we have sudden, unexpected discharge. We have to explain that this is not related with non-efficacy of treatment. So it could happen because of trophic endometrium, and due to that we can stop the treatment or can switch to dihydrogesterone for cyclic administration day 5 to 25, and then it allows us to avoid this sudden bleeds, or for the period we can give even estrogen component if we see some atrophic changes. So that's the advantage. It can be used in very different options, and gestagens, and also from day 1 to 25 of menstrual cycle. In this regimen, according to Orchidea study, we had no deterioration of the menstrual cycle. Today it has already been said that this is something we are proud of. This is Orchidea study published in Fertility Sterility, where we had comparison of two regimens, continuous and cyclic, and both demonstrated it. For the first time in the world, we showed the comparison of regimens 5 to 25, and then continuously we showed the efficacy of dihydrogesterone, and the pain was localized. And another important moment, no refusal with the use of dihydrogesterone due to the minimum of side effects, due to the fact that it has high affinity to progesterone receptors versus Gynecologic and noreldestrone. And about Gynecologic, we see that about 40% of the patients they refuse because there is a huge amount of side effects. So that's it, what I wanted to say today. Mainly it is all published, and you can find it in one of the recent articles in the modern diagnosis of endometriosis treatment. And also interesting webinar, which we appreciated last year, so carried out with our participation. And so Charles Chaffron, but unfortunately today our colleagues are not participating in the conference, and in the QR code you can easily find the translation into Russian. So today we already said that algorithms of patients with endometriosis, I hope that in the future, that in the local and regional conferences, we will report these algorithms. Thank you very much for your attention. Thank you very much. Thank you for the presentation. And once again, you convinced us completely that relapse of endometriosis could be really severe, and we have very many clinical opportunities, and endometriosis is still there, and it's still a big mystery. So, dear colleagues, now I'm happy to give the floor to Stanislav Pavlovich, the role of hormonal treatment in the prevention of the relapsing recurrent endometriosis, associate professor of our chair, and also scientific secretary, steering committee secretary, and medical PhD. Dr. Pavlovich, microphone is yours.
Well, distinguished Leila, Adambian, dear colleagues, today we've talked a lot about endometriosis, and I think this auditorium knows how relevant this problem is. Well, actually, there are more than 33,000 publications starting from 2017, and you can see that 190 million people in the world have endometriosis, 3.5 million in the Russian Federation. That's a significant burden of disease, and for many decades it has been linked usually with the active period in the life of a woman. Therapy for endometriosis is in the forefront right now. We should take into consideration different factors to make diagnosis and to choose the proper treatment. There are a lot of factors involved here, such as age, symptoms, the type of the disease, well, the need to preserve the reproductive function, also the volume, the duration, and so on and so forth. And there are dozens of reasons for infertility during endometriosis. That should also be taken into consideration when we're talking about therapy or when we're talking about any long-term medical interventions. Well, a few words before I move to therapy about the diagnosis and the studies which were conducted in the field of endometriosis at our center. It is open secret that we do not have enough diagnostic markers for endometriosis, not to mention that there are also imaging methods. And of course, there is a need to look for new, informative, and effective markers. And here I should say that interdisciplinary interaction is of paramount importance. There should be different specialists involved, and first and foremost, there are lots of different technologies in the field of systemic biology that we use as of today. Here are some examples, such as mass spectrometry, used to assess the efficacy of steroid hormones to treat endometriosis. The concentration of some hormones changes in women with endometriosis, and we came up with the concept endometriosis as a pathological process. It's not just the localization of heterotopic tissues, but the activity of the process. ROC curves were developed, and we can differentiate patients with endometriosis and without endometriosis. There are also a lot of studies which have been conducted over the last 10 years at our center with the use of lipidome, and here you can see one of the algorithms of differential diagnosis of various ovarian forms, including endometrioid forms, including lipidoma. The comprehensive assessment allows us to make this differentiation, not just using imaging, but also characteristics of blood lipidoma. There is a new direction of our study, diagnosis of the disease and monitoring of patients in a post-operative period with endometriosis, on the analysis of dry spots of menstrual blood. Well, those patients who have menstruation, of course, and as of today, we can say that this is a very progressive method. We hope that at next congresses we'll present more detailed information about the nuances of the study. MicroRNA is another area, and we can differentiate different pathological conditions using different microRNA. And there is one area related to the study of transcriptome in case of different conditions related to cancer and endometriosis, well, the transcriptomics of single cells. And several years ago, the atlas of endometrium was developed during different stages of the menstrual cycle. There are transcriptomic changes in the endometrium depending on the phase of the menstrual cycle. Last year, there were studies conducted resulting in formulating the integral atlas of a human being on the basis of single-cell transcriptome. Well, you can see that molecular signatures in case of endometriosis have different types of transcriptomic reprogramming, and there were also studies conducted at the Kolokov Center devoted to microbiome in case of endometriosis, and now we have all the necessary information to identify different microorganisms, including epitopes, depending on the different conditions, including oncogynecological conditions. Endometriosis characterized by Escherichia coli, Pseudomonas, Acinetobacter, and there is also an increase in Gardnerella and a reduction of Lactobacillus. Well, you can see some comprehensive studies using the methods at the Institute of Microbiology of our center. They allow us to use sequencing of DNA samples to characterize the microbiome and to identify those things which are specific for each of the diseases shown here. As for medical therapy for endometriosis, well, during the last few days, a lot has been said about, well, comprehensive therapy of endometriosis. You can see the classes of drugs used in the Russian Federation as well as abroad. They're basically the same, we just have different brand names. We have some exceptions to the rule because we have sometimes limited possibilities for using vaginal donazole, but in general, the range of drugs used here is basically the same as in other countries. It has been the same for many years. And here we should say that endometriosis is the disease that should be monitored and should be impacted in the course of the entire life in some cases. That's very important. A separate issue is the long-term rehabilitation therapy after surgeries for endometriosis. We can have the latest version of clinical guidelines. A lot of attention is being paid to this issue, including progesterones, and the progesterones have shown very good effects, such as Dynagest, for example, provides a good effect in terms of anti-proliferation. It is characterized well in terms of prostaglandin effect, that means curing the pain syndrome, and also inhibition of inflammatory processes. It is also important to suppress angiogenesis. We've been dealing with angiogenesis for several decades together with Professor Berlin. Way back in the 1990s, we came up with the theory of cyclic angiogenesis or systemic angiogenesis as one of the key components of pathobiology per se, including proliferative oncological diseases. Well, a lot of studies were devoted to assess bioequivalence of different drugs, including Dynagest, pharmacokinetic curves of different drugs of Dynagest, which on the market are in fact identical after the standard dose of 2 milligrams to healthy individuals. These types of Dynagest showed very good results in terms of bioequivalency. Dynagest can prevent relapses or recurrences after a laparoscopic procedure. It is preferable as compared to gRNH agonists to have secondary prevention of endometriosis. Unlike agonists, GnRH agonists, well, Dynagest can be used for a long time. Here, there is no need to monitor secondary symptoms which can occur when gRNH agonists are used, and we encounter them in our practice all too often. There is no need to use add-back therapy, without which gRNH agonists can cause specific problems. Dynagest is comparable with dipoliprolide, well, acetate in terms of controlling pelvic pain after laparoscopic procedures. Good results were obtained in terms of similar effects with dipoliprolide acetate. The safety and tolerance profiles are very good, not so many adverse events in case of Dynagest, which were shown by some publications. Another important factor is the duration of treatment. Our main goal, not in all cases, but in some cases, to administer long-term therapy. And here you can see some of the studies after laparoscopy for endometrioid ovaries, and it was shown that Dynagest is quite effective in terms of prevention of recurrence of endometriosis and also in terms of controlling pain from endometriosis. This is one of the studies shown here. We can say that we can administer Dynagest for a long time. It has a good profile of safety and efficacy, including the study when the intake was done for a long time. How much time did it? 1.5 minutes. Well, it controls pelvic pain, it prevents recurrences after laparoscopy, and the drug is very well tolerated by patients. When Dynagest is used for more than 1 year, the endometrioid cysts diminish in size, and also it reduces the severity of pelvic pain associated with endometriosis, and in general, Dynagest reduces endometrioid cysts when there is a recurrence after surgery. Well, thus, and I will skip several slides related to the efficacy of the drug, I should say that Dynagest is more effective as compared to wait-and-see tactic. It controls pelvic pain after laparoscopy for endometriomas, and these are the results of long-term observation. Dynagest has a lot of positive properties: antihistogen action, high bioavailability after the intake. Dynagest is very effective when there is short-term or long-term therapy. Also, because it is metabolically neutral, it is a safe drug, and this group of drugs is very optimal to prevent the recurrence of disease. Thank you very much, dear colleagues. Once again, thanks for the opportunity to share this experience. And that was our view on therapy for women with endometriosis. Thank you. Well, you can go back to those slides that you missed, no problem. You have time. Well, you mentioned I skipped several slides. All right, you can go back to some of the slides if you want. Well, it's okay, Leila. I managed to well, make my presentation. All right, thank you very much. Let's move on. Andrei Kozachenko is our next speaker, comprehensive treatment of patients with endometriosis. A surgeon's view. Dr. Kozachenko is a professor of the Russian Academy of Medical Sciences. He is the chief leading specialist of the Department of Gynecology of the Kolokov Center. He is a brilliant surgeon and a prominent scientist. Please, Dr. Kozachenko, do not overrun your time. Dear Leila, dear colleagues, and indeed, I would like to focus on the surgical treatment of endometriosis. And in this light, I'd like to say that right now, there are no effective ways or methods of treating this disease. Our goal is to control the pain syndrome, to slow down the progression of the disease, and of course, the maintenance of the reproductive function of the patient. There is always a difficulty in terms of the choice. Should we start with surgery or should we start with the preservation of reproductive function or with hormonal therapy? Of course, in case of infiltrating endometriosis, the choice is usually comprehensive, taking into account different factors such as side effects, and also remember about the negative impact of surgery. We go back to the personalized approach in treating patients with endometriosis. Each patient has its own goal in treating the disease, and we must help a woman achieve this goal. Our Italian colleagues came up with a classification algorithm of patients with endometriosis. There were 9 classes, depending on the type of treatment, whether it's medical, surgical, or the use of ART at stage 1. Thus, we can standardize both diagnosis and treatment in this severe group of patients according to clinical guidelines of the Ministry of Health of the Russian Federation. The major goal in treating endometriosis boils down to removing the focus of endometriosis, treatment of infertility, and prevention of progression of disease. Nevertheless, I'd like to draw attention to the following aspect. In Russia, as well as other countries, surgery remains the only method of treatment of genital endometriosis. We can make an excision and to remove the morphological substrate of the disease using different surgical energies. Of course, here you can see the diaphragmal endometriosis with the fenestration endometriosis of the anterior, abdominal wall. Of course, only surgery is possible here, or this is a more severe situation when the cupula of the diaphragm is damaged and there are prolapses into part of the kidney. As for surgical energies used to treat endometriosis, of course, laser can be used here, as well as a cold knife surgery or bipolar coagulation, laser, etc. Robotic surgery was the subject of the presentation by Professor Mareska. But in speaking of endometriosis, we must also realize that surgery primarily is conducted when the urinary tract is involved, when there are infiltrating endometriosis, when there are cystic forms, when there are endometrioidal cysts, or in case of adenomyosis. In speaking about the bowel, I should say that in case of deep infiltrating endometriosis, the retrosigmoid section of the bowel is primarily affected. Resection of the bowel with the removal of the segment or the removal of the disc is possible in 90% of cases, and we can use the organ sparing technique in the form of shaving. The number of complications will be reduced, the number of recurrences does not increase. That's very important. Let me just give you some data by Horacio Roman: conservative surgery versus colorectal resection in deep endometriosis, infiltrating the rectum. Shaving or discoid resection, preserves mesorectum and the function of the bowel, and also the pregnancy rate is comparable in both groups. 2/3 of pregnancies were spontaneous. That is very important for our specialists in reproductive medicine. Does surgery for deep infiltrating bowel endometriosis improve fertility? Yes. And this is also very important information. In speaking of adenomyosis, we understand it perfectly well that surgery, including the occlusion of fallopian tubes in 100% of cases, can treat dysmenorrhea. And please launch the video. Women of reproductive age after the removal of endometrioid cyst in order to prevent the recurrence, levonorgestrel intrauterine device can be of great efficacy. The systemic review shows that post-operative hormonal treatment for prevention of endometrioma recurrence after ovarian cystectomy, you can see thus we can prevent recurrences. As for urinary tract endometriosis, here is another article. 40 patients with severe endometriosis, and we understand that we should use a multidisciplinary approach. It looks like it's a gynecological disease, but nevertheless, some women had a nephrectomy performed, and of course, this requires hormonal support in the future. Here you can see pre- and post-surgical medical therapy for endometriosis surgery. Of course, it can control pain, but the level of evidence is not quite high, although that's the data of the Cochrane Library. As for adenomyosis, there are different classifications of the disease, and at our department we have our own classification under the auspices of Leila Damian. We use this classification. There are also other forms of the disease. And in speaking of adenomyosis, of course, there are different drugs which changes symptoms, but the disease remains in myometrium, and in this situation, we can use adjuvant therapy after adenomyomectomy. Also, when we're talking about preserving fertility, we must understand that the best efficacy belongs to GRNH agonists and levonorgestrel containing intrauterine devices. Well, you can see some of the publications here, effect of modified levonorgestrel, intrauterine device, and of course conservative surgery can be used in this case, and laparoscopy is used to remove nodes which are less than 5 centimeters in diameter. Also, you know, the Hisao-Osada methodology. Here, the frequency rate of the uterine rupture increases after this surgical procedure. Well, this technique is used in our department, and you can see the pregnancy rate with nodular adenomyosis as compared to diffused adenomyosis. Well, the pregnancy rate is taking place more often in this case. Well, here you can see the association of uterine wall thickness with pregnancy outcome following uterine sparing surgery. The safest thickness is from 9 to 15 millimeters. Of course, I would like to say a few words about the medical treatment. Empirical medical therapy is gaining momentum. Now we're trying to use a personalized approach. Professor Birshiner mentioned this in his presentation. And of course, the personalized approach means starting medical treatment, but not in those cases which were showed on previous slides. In speaking of the choice of medical therapy in endometriosis, we must understand that there are different factors that should be taken into account. Age, reproductive plans, fertility plans, the intensity of the pain syndrome, adenomyosis of endometrioidal cysts, the wishes of the patient per se, and what should be the outcome of the treatment according to our patient. And we must combine, please launch the video, surgery and hormone replacement therapy. And here you can see that the etiological therapy is absent, but pathogenetic therapy is gaining momentum in our country. I'd like also to say a few words about drugs which are not on our market, but have a very good recommendation. That means GRNH antagonists per os, such as Glycolics, and it reduces the symptoms in case of adenomyosis and endometriosis. The same is true of lisogolics and lagolics. These drugs are very effective and they improve the quality of life in this severe group of patients. It should be said that there is a dose-dependent effect of such drugs, which allows us to control the pain syndrome, to deal with uterine bleedings, including patients with endometriosis together with uterine myoma. In Russia, we've been using dihydrogesterone, and as for DDH, it was proven that the use of dihydrogesterone allows us to achieve high efficacy in terms of controlling the pain syndrome, improving the quality of life, and this study was published in Fertility in Sterility, and well, there was a positive assessment made. Professor Bergener continued the study. The drug was administered for 12 months, and also it was shown that dihydrogesterone was highly effective. We have the new instrument of adjuvant therapy, and we can use the individual regimen. In conclusion, I would like to say that surgery and medical treatment are not things that should be considered separately. They can be used in combination. This will allow us to achieve better results in the severe group of patients. Thank you very much. Thank you for this clear presentation. You are a surgeon. You can see every day what endometriosis is all about. Thank you very much. Let's continue with our plenary session. Sergei Martynov is our next speaker. Intrauterine infusions and niches and scars after the cesarean session. Dr. Martynov is the leading specialist, the senior fellow of the gynecological department of our center. Please do not overrun your time. Distinguished Leila, esteemed participants, it's a great honor for me to present the Department of Operative Gynecology headed by academician Adamian. And in my presentation, I would like to cover major issues related to intrauterine adhesions and niches and scars, and of course, especially after the cesarean section. Why is this problem relevant for us? It has been relevant for the last 10 or 15 years. First of all, we are far from the level of C-section of 15% recommended by the WHO. We have a much higher rate, and unfortunately, it's not going to go down. There are lots of different classifications. They are descriptive in nature, and it's difficult to identify some particular classification. Each clinic uses its own classification. I'd like to say a few words about the situation here. Right now, we can have a sober look at the situation, and we know where we are as far as this problem is concerned. While patients with symptoms who have a scar on the uterus, and there are criteria regarding what surgery should be done in this or that situation. In case of asymptomatic disease and patients are planning pregnancy, well, the situation here is not quite clear. Why is it so? It's because all recommended indications for surgical correction for the scar are usually postulates. They're based on the mechanical assessment of specific parameters of the scar or a niche. Well, the most important study, and we have mentioned this many times, are prospective studies. One of them is shown here. That's the study conducted by Professor Vikhareva. You can see the threshold here, 2.5 millimeters, and we use this criteria. Nevertheless, we're still on the horns of a dilemma, and it is due to the fact that on the one hand, metroplasty is done due to conditional indications. All classifications are descriptive. The mechanical approach to the assessment of the function of the scar, and the major parameter is the minimal thickness of the scar to choose this or that particular tactic. And of course, here we're talking about the measurement of the parameters of the uterine scar. We have had about 600 patients with this pathology. Most of these patients were subjected to a specific type of surgery, mostly laparoscopic metroplasty. I'd like to share our experience that we have gained as a result of treatment of such patients. First of all, the peculiarities of the diagnosis of this condition. As of today, there are all methods of diagnosis available: ultrasound, 3D, ultrasound, sonar hysterography, MRI, well, and also hysteroscopy and laparoscopy at the final stages. I should say that as far as ultrasound is concerned, we have a clear understanding of the importance of ultrasound, and of course there should be a specialist properly trained in using ultrasound to examine the uterine scar. There should be a special room equipped with the necessary equipment, and you can see the differences in the major parameters of the scar when the standard study is done and when it is done by experts. The difference is quite significant. Well, of course, we cannot just do one ultrasound, or when the ultrasound was done in a clinic which is not specialized in such conditions. It should be only a first-class ultrasound performed. When we did the comparison, of course, there is a need to standardize the study, and Delphi method offered as a result of the consensus by experts in this field is preferable. They also say that anyway, sonographic examination of uterine niche is preferable as compared to the standard ultrasound. The same consensus was used to train specialists the skills of measurement. As we did the comparison of different studies, I should say that ultrasound performed by expert as compared to echo hysteroscopy has some differences. First of all, we're dealing with a major parameter, the thickness of the scar, as well as other parameters. But the most important thing is that there is a range of different meanings. When it was done on the same patient, it was much higher when expert ultrasound was done as compared to echo hysterosonography.
Which says that echo GSG has much higher reproducibility. MRI is also different, about 0.03 is lesser value that compared to ultrasound. You see also the range in MRI is much less, which speaks about higher reproducibility of the method. What do we choose then? Is it MRI or echohysterosalpingography? If you look at this bar diagram, the range here is least compared to MRI. And if you have this, you can better be guided by this. The test that we showed has another advantage. We can identify full thickness defects that go under the abdominal wall in the lesser pelvis, which may not be visible when you do conventional ultrasound. And there's full thickness defects may be the reason for uterine rupture during further pregnancies. Hysteroscopy. Hysteroscopy is something that has been disregarded and discounted, but nowadays it enjoys great attention. Why? If you look at this pie chart in the upper right slide, depending on the position of the scar that we look at the ultrasound and after hysterosalpingoscopy, the difference is about 15%. We can see cervical position of the scar and avoid unnecessary metroplast repair. This slide is something that shows what is adopted in our unit, the procedure, the algorithm, the flow chart for asymptomatic course in patients who plan their pregnancy. The cut through is this what the value on this slide. Hysteroscopy is a must, and in presence of the scar in the isthmus, well, we recommend metro repair. We use orthoscopic methodology, but others are also widely acceptable. Resectoscopy in presence of the scar and leveling off the edges. Apologies. And of course, based upon what I said, we realize that all the clinicians see the need for functional methods. Why? Because they alone can give us an answer to the question, when do we need metro repair? When can the scar behave nasty during the pregnancy, maybe provoking uterine rupture? And these methods alone further on, as I think, may be considered later on when we take a decision about surgery. What methods are available in our armamentarium? Of course, it is ultrasound elastography of the shift of the wave. The difficulty about using the methods has to do with smallish size of this zone we are studying. And as of today, regrettably, a lot of material that has been accumulated has not been accumulated yet. However, what seems to be more promising is functional MRI, which helps evaluate perfusion of the tissues not only in the scar but also in the adjacent areas. And in some cases, maybe another supplementary method that helps us do surgical navigation in further metroplasty. We're accumulating experience in this test at the next Congress. We'll try to present you data that will be summing up. Surgical therapy implies two main categories. They are resectoscopic leveling off of the edges of the coagulation of the enlarged vessels of the possible foci and cysts in the scar area, as well as metroplasty, laparoscopic, laparotomic, or vaginal approach, whatever. These operations are well known and you can see them on these videos. What I want to highlight is this conventional technique for laparoscopic metroplasty, or rather analysis of its outcomes, shows a relatively high level of poor outcomes. About 10% of the patients we operated in 6 months' time had similar characteristics of the scar compared to the original data. More in-depth analysis showed that the leading role may be played undifferentiated disposition of the tissue, which almost doubles the poor outcome rate. These women, how much time do you need more? Well, half a minute, please. They have retrodeviation, retroflexia of the uterus, which helps us suggest the use of, in metroplasty, shortening and plication of the round ligaments of the uterus, which helped achieve 100% effect of this operation. So, dear colleagues, the conclusions are: metroplasty should be done only in case of indications. Ultrasound helps screen. Decision on operation should be based upon more precise methods such as echo hysterosalpingography, which can be considered gold standard. Cutoff values today, they are 2.5 millimeters. Hysteroscopy is a must. And of course, we realize the need for further adoption of functional methods. Thank you for your attention. Thank you so much. It's very interesting and most importantly that you should know, we have huge experience, over 500 patients. The country, we are a referral center. That's why we see them, all of them work in my unit, and Professor Martinov, amongst others, is one of the key figures in this question. Thank you so much, Professor, and thank you for being on time. Thank you so much. Dear colleagues, it is my great pleasure to give the floor to our distinguished doctor who has been waiting online. Today we have 3 more professors who will be speaking to us. Professor Mark Winter, Ido Sirota, and Juan Gelabert. So please, who are ready, who are fully online? Mark Winter, the floor goes to you. Scar pregnancy. He's in charge of the benign gynecology department, Presbyterian Hospital in Newport Beach, California, United States. The floor goes to you. It's such a pleasure to see you here at this Congress. Plus, stick to the time, please. It's something very essential too. Thank you.
I will. Let me share my screen. All right. All right. I'd like to congratulate Professor Adamian. It's great to at least see you, and really congratulate you on this wonderful Congress you've put together. And I thank you for the honor of being able to participate. Due to the limited time, I will just jump into my talk, where I'm going to talk about some of the other uses that we have found useful using robotic-assisted laparoscopy and reproductive medicine, including scar pregnancy. So compared to standard laparoscopy, some of the benefits theoretically are the 3-dimensional vision and really the with the instruments, the ease of suturing, in addition to increasing surgical autonomy. In the United States, just for your interest, when we look at adoption, see certain procedures, prostatectomy for one is virtually 99% robotic. Benign hysterectomy is at about 40% in the United States right now. All right, so common procedures performed would include hysterectomy, mammectomy, sacrocolpopexy. What I'd like to do is talk about some of the less common procedures and just make some comments about them, including resection of endometriosis, transabdominal cerclage, and then following the previous talks, talk again about our technique of repairing a uterine niche and cesarean section scar pregnancy that we've encountered. As far as endometriosis goes, I wanted to demonstrate the use of indocyanine green, which I will show you where on the robot, it's very easy to go from white light to near infrared. At the current time, one would have to place ureteral stents and then inject the dye. You can see easily where the ureter is. Right now, our facility is going to be one of 10 sites involved in a phase 3 trial where a new version of the dye has been developed where you can inject it intravenously and it will go into the urinary tract and light up the ureters. So that's something that's not expensive, easy to use. Here, you can see this is a retroperitoneal dissection as we're developing the perirectal space, and we have a fair amount of retroperitoneal fibrosis. You can see that deep green right over underneath the suction. And I can tell ureter is in that area. Excuse me. So I can easily go back and forth, and then I will continue the dissection. This was here you can see the retroperitoneal fibrosis right over the ureter. This was a case where on preoperative imaging, it appeared that there was an endometrioma on the left side that was compressing the ureter. So it was important to dissect that area out before we went after the endometrioma. As you can see, as I'm unroofing that scar tissue, you can easily see where the ureter is and follow that down. And then we go back and forth from white light to what we see now here is the near infrared light. where the green of the dye lights up. This dye is used in endometrial cancer, injecting into the cervix and lighting up the sentinel lymph nodes. And again, this new version we're working on, I think, will be readily available and able to be used just with a simple intravenous injection. Transabdominal cerclage. Of course, cerclage has been used to treat incompetent cervix. A couple of recent studies. There was one I was involved in, myself, Gabby Mowad, and a group from George Washington University, where we showed a 400% increase in live births after placement of a robotic-assisted laparoscopic cerclage. There was what's called the Maverick study out of the UK, which showed the superiority of transabdominal cerclage to repeat vaginal cerclage in women who failed previous vaginal cerclage. So this is the right side of dissection. This patient is about 12 weeks pregnant. If we identify these patients and we prefer, if possible, if they're identified, to perform these procedures as interval procedures before they get pregnant, but sometimes we're not allowed that luxury. And so here I'm dissecting the area into the broad ligament a little bit and right over the cervix, and I will continue that dissection until I can identify the main branch of the uterine artery. They're always, when they're pregnant, are tributaries, and we worry about bleeding more than anything else. So here we're identifying the ureter, staying well medial and superior to it, and opening up a window of the posterior peritoneum. I'm using 4 arms with the robot, and on the far left is what's called a small grasper, which is actually a very large, one of the largest instruments that we can hold up on this 12-week sized uterus, and then taking advantage of a 30-degree laparoscope to either look upwards posteriorly, or in this case now we're going to look downwards 30 degrees down, which I just flipped it to. And then we will be able to hug the uterus, go through the broad ligament, and pass our cerclage. So now we're through, pretty much at the level of the internal os, and are pulling a 5mm Merceline band through. We'll come up on the other side in similar fashion. When these patients are not pregnant, I keep a needle attached, and I'm able to just pass a needle through this area without having to make as large a dissection. So again, passing it through, we are medial. You can see right here, uterine artery. So we're coming medial to the main branch, staying medial to the ureter, and then we'll be able to tie our knot on top. I used to do these procedures with regular laparoscopy, really no different other than the ergonomics, and much easier to come around the curves, and in this case tie a knot with the proper tension using robotic assistance. So you can see relatively very easy to tie our knot, and again get the proper tension as we come around the cervix. All right, we'll move to the next one. So now I'd like to talk about uterine niche cesarean scar defect. Our experience has been very similar to the previous speaker. We similarly use a definition of less than 3 millimeters of the anterior myometrium on patients that we recommend surgery. You can see a list of potential complications. The most serious is cesarean scar pregnancy. I have a case next week of intermenstrual spotting, which is her main complaint, and we think we'll be able to easily solve that problem. So again, I have in my left hand a bipolar instrument, and in my right hand monopolar scissors. We have taken a bladder flap down, and now we're starting to outline the scar tissue to remove. In this case, the anterior myometrium was approximately 1 millimeter. So you could see that little bit of blood coming up. That was entering the cavity as it was very thin in that area. And again, we're continuing the dissection to remove the scar tissue before we begin our uterine reconstruction. I have a manipulator in the uterus so I can see, and many times we combine this with hysteroscopy, and we'll look inside first. So here I'm using a barb suture to close the defect. I will try, this is the first layer where we are bringing this together. And you can see how easy it is to suture in this case. And here, I try to do this in 2 layers. So I have that first layer to close the endometrium and part of the myometrium, and then another myometrial layer to more superficial to imbricate this. So we actually will get a 2-layer closure in addition to closing the serosa. Again, done very efficiently. This is the last portion of the closure. And now we'll start to close our serosal defect. Try to get the bladder well out of the way. And this is the end of the closure of the serosa. And now you can see the end of our 3-layer closure. We go. All right, I want to share with you a little bit of time about cesarean scar pregnancy. So, again, it's a relatively uncommon, occurring in 1 in 2,000 pregnancies with prior cesarean section. Similarly here, we're doing roughly 1/3 of our deliveries via cesarean section. And over time, this has become more and more of an issue. There are various potential treatments, including ultrasound-guided suction aspiration, medical therapies, insertion of a balloon catheter, urinary embolization, and resection. And I want to demonstrate the resection to you. The patient is a 32-year-old gravida 2 para 1 AB0 with a history of previous cesarean section who presented to the emergency room with severe abdominal pain. Ultrasound examination revealed the gestational sac was within the myometrium, clearly away from the endometrial cavity, and the patient was diagnosed with a cesarean section scar, ectopic pregnancy. You can see the bulge on her anterior uterus where the ectopic pregnancy is. This video will show the robotic-assisted laparoscopic resection of this cesarean section scar ectopic pregnancy. Here we're using monopolar scissors in one hand and have a bipolar grasper in the other. Because of the risk of massive hemorrhage, the patient was taken to interventional radiology and underwent bilateral uterine artery embolization prior to the procedure. This was completed using gel foam, a temporary agent to occlude the uterine arteries, and the patient was taken directly to the operating room where the procedure you see was performed. Here, using the monopolar scissors, an outline of the area to be resected was made. Already, you could see a bladder flap was made and the bladder was pushed well away from this area in case
excessive bleeding was noted, we wanted the bladder to be well away from this. Here you can see the dissection going on and going deeper into the endometrial cavity. As we enter the cavity, a balloon can be seen here, which was attached to the uterine manipulator. And this was used to our advantage to actually push up on the ectopic pregnancy. As you can see during this dissection, very little bleeding was encountered, due in part to the technique of slowly going through the tissue and the decreased pulse pressure from the uterine artery embolization. Here, the monopolar scissors are continuing the dissection around the ectopic pregnancy, and this is gently being pulled up. Again, the balloon is used to our advantage to push up on the ectopic pregnancy, and now we're able to, with tension, pull up further, which will help with cutting the tissue. And one can see with a close-up here more of the actual endometrium and its demarcation right there from the ectopic pregnancy. Pulling up with the left hand and gently pushing up on the ectopic pregnancy, you can see with a close-up the plane between the endometrium and the ectopic pregnancy, which was slowly followed with the monopolar scissors to dissect the ectopic away from the endometrium. This was slowly continued to minimize any chance of bleeding and continued with the last portion of the connection. The ectopic pregnancy is now being dissected completely away from the uterus and will be placed anteriorly for safekeeping until it's ready to be removed. A barb suture was chosen for repair due to its strength and ease of use. The defect was closed in a multi-layered fashion. Here we'll see our first layer through deep myometrium, through the endometrium. Similar to repair of a cesarean section. And this first deep layer was performed, as you can see, going from right to left with good approximation of the endometrium and closure of the cavity. Then coming back from left to right, a superficial myometrial layer was performed to imbricate the closure. Here you can see the last suture of this being performed. This was done to add strength. The barb suture was able to be used for a third layer of approximating the serosa as well, going back from right to left. You can see how hemostatic the incision is, as there was very, very minimal blood loss. Here, the ectopic pregnancy is placed in a 5mm pouch and will be removed through one of the 8mm ports that were placed. You can see fibrinogen thrombin substance was placed on the uterus to add hemostasis insurance.
So I think, again, we're able to affect this closure in multiple layers. We routinely do ultrasound after, and usually we'll see with our uterine niches a width of the anterior myometrium is usually approximately 10 millimeters at the end of that. This particular patient that you saw with the cesarean section scar pregnancy, I'm happy to report, several months later, got pregnant and delivered a healthy baby boy, which we were all very, very happy about. Again, I have, this is my YouTube site where I have several of these videos there, if available for anybody to watch. This concludes my presentation. I thank you very much and hope to see you soon in the future. Thank you.
Thank you. Thank you so much. Thank you. Thank you.
A little bit. I was, я была немножечко занята.
I was somewhat busy with Ida Sirota because the connection is so good. Thank you so much. It's a very important lecture because very many patients after all sorts of C-sections, after operations on the uterus, and you name it. And nobody seems to be paying attention what to be done next. That's why I know your fantastic technique. I visited your institution, I visited your clinic, you visited our country, and I'm so happy. Do you think I forgot it? No, I cannot forget such things. You're always a good guest in our our congresses, of course, that's a slip of the tongue. As a brilliant surgeon, as a fantastic doctor, and a person who's fully knowledgeable of all novel technology, is a brilliant lecturer. And my Leila Zamaranch, my best regards to her. Thank you so much.
Thank you so much for your comment. My pleasure. And thank you for the honor of participating.
Спасибо.
Thank you. Thank you. Dear colleagues, right now I'll give the floor to Dr. Ilya Sirota. This is a brilliant surgeon. I invited him at this time. He's in America. And you should realize that all these operations and lectures that we're giving you at the end of the day, this is done especially for our colleagues from America, given the time difference. Thank you very much, Ida. Robotic surgery, past, present, and future. Please, the floor goes to you. Director of minimally invasive gynecological robotic surgery, New York Presbyterian Hospital at Queens, New York. Ida Sirota, the floor goes to you, please. Please, will you start?
Okay.
You able to see my screen?
Да, я вижу, отлично.
Yes, we can. Thank you very much. Yes, we can see it very well. Please begin your presentation.
Thank you very much for the invitation. I thank you very much for the invitation for all the esteemed colleagues that have joined us. I will talk today about robotic surgery, the past, the present, and the future. This, as you can see, is the starting of robotic surgery. About 20 years ago, robotic surgery started with intuitive surgical. And even though that 20 years have passed, I will argue in this presentation that we are still in the infancy of robotic surgery even today, as we currently doing procedures with robotic surgery, but only 2% of total procedures being performed are done robotically, meaning that the penetration is still very low and there's much more to do as we see that the technology keeps evolving and there's more and more disruption happening in this environment. I have nothing to disclose. And we will focus in this presentation about the history of robotics,
громче делать перевод.
the current robotic platforms, the future potential directions and applications. So we know that the robotic surgery started back from 1990 when the ASOP was introduced by a company called Computer Motion. The idea was back to create a robot that will have the significant advantage of scope manipulation. The robot that was introduced back then was in orthopedics. However, this did not succeed, even though that it received the FDA approval back in 1994. And then following in 1995, a future predecessor of that robot was introduced called Zeus. The idea and the innovation with this robot was that this robot introduced the idea of console, also by computer motion. Back in the days, another company was developing robotic surgeries, and that was called Intuitive Surgical, that we're very familiar with. The two companies were heading heads, both based in California, developing robots, seeing the future of this field. And there were a lot of lawsuits back then in 2000 between the two rival companies, and a lot of lawyers that made a lot of money, and eventually they merged into one company that we know today called as Intuitive Surgical. And since then, the stock has seen a meteoric rise since the great adoption of this technology. So the disruption in this innovation was that we basically created a computer-enhanced telesurgery. Unlike the previous laparoscopy and laparotomy, where the surgeon stand next to the patient and control the movements of the instrument directly with his hands, over here, there is a system of a master apprentice, basically, where the surgeon sits next to a console and the robot attached to the instruments next to the patient, and the movements that the surgeon is doing away from the patients are being translated via the robot inside the patient's body, with articulation, with dexterity, with improved visualization. So we all know about the advantages of robotic surgery, such as smaller scars, shorter hospital stay, lower adverse side effects, faster recovery, less pain, less blood loss during surgery, and quicker return to normal activity. Those have all been reported multiple times and have shown the superiority of robotic surgery over open surgery and comparability to laparoscopy. In the past, throughout the history, Da Vinci has developed different robots. The standard back in 1999, the S in 2006, the SI in 2009, and the XI in 2014. With the SI being launched in April 2009 with a surgeon console and a patient side card, with the key features of endo-wrist instruments and a 3D HD visualization, which were key breaking through at that time. The XI that was launched in April 2014 was a major breakthrough because he introduced a multi-quadrant access, basically, with the boom-mounted arms, with a reduced camera port size, with port hopping, basically, that you're able to move the camera to each of the arms and operate through each of those arms. And the smaller signature, basically, of 8mm compared to the 12mm previously. And in 2017, the X was introduced, which was designed to largely replace the SI as a patient cart-mounted versus a boom-mounted with the XI, and was also interoperability with the XI ecosystem that we'll talk about in a little bit. So this is the surgeon robotic console that we see in the OR. There are 7 degrees of motion compared with the traditional 4 in laparoscopy. We know that the robotic console is 3D HD, as we mentioned, with intuitive motions. There's improved ergonomics, the pedal control camera and electrosurgical function. And there's also a potential 4th arm in case that you would like to avoid an assistant port. You're able to do the whole surgery on your own. And far and foremost, one of the main keys that there's a reduced tremor, basically. As we can see over here, comparing the surgical videos over here, we can see that in laparoscopic procedure on the left compared to robotic procedure on the right, we can see that there's significant more tremor on the left performing laparoscopic surgery compared to robotic surgery, which in complex surgeries that we perform within the pelvis, we can see that that could be a differentiating factor. And that allows to do more precise surgery. As we know, the robot never gets tired. It doesn't matter if the robot had 2, 5, or 7 surgeries a day. The robot has no issues with sleeping the night before or eating before the surgery or being hungry. So those key features help us to get better results basically when we perform this type of surgeries. And we can see the decreased tremor with robotic compared to laparoscopic surgery as we perform similar procedures over here that are very complex within the pelvis. So we see that the location of the robotic port placement, we placed it in the arch with the camera in the middle, and then the robotic ports. You can use a assistant port, but you don't have to. The ports are usually 8 millimeter, and the camera 8 millimeter. This is the X side that is relatively smaller. And we then connect the arms to the patients and plug and play, basically. This is the whole OR, and the whole thing allows us to get better results for patients that previously it was more difficult to achieve surgical success compared to laparoscopy, basically. Patients that are with higher BMI, patients with multiple surgeries in the past, patients that had multiple C-sections, and more complex cases that are now you're able to perform them more easily. And also, you don't have to count so much on the assistant as you have to when you perform laparoscopy over here. You have the complete freedom to perform the surgery within your hands. And also, we can see that with the aid of the articulated endo-wrist instruments, basically, we can perform multiple tasks that are complex, such as also suturing over here. We can perform them very easily as if our hands were inside the patient, and very successfully. And the result is basically a patient, as we can see, extremely obese with small incisions, previous surgeries, but a midline incision previously with small incisions that is able to go home the same day, a couple of hours after the surgery without any special issues. We know that there has been a great adoption of robotic surgery since the adoption and the FDA clearance of the Da Vinci robotic surgery for G1 in 2005, where we see a clear rapid decline in open surgeries for hysterectomies, for laparotomies, and a quick rapid increase in the robotic surgery. And this has been a thing that has been maintained since then and keeps growing. There's also societal impact, as we know, studies that have been conducted and show that there's also a decline in hospital stay, decline in overall cost, even when robot purchase and maintenance is included, and also improved outcomes. And since a lot of companies have recognized that, many companies are going into this field, exploring the opportunity to penetrate the market. One of those companies is a CMR, Surgical's Versus robotic assisted surgery system that has a modular arms. As we can see, it's an open console. It's different from the Da Vinci. It's currently on the market. The uniqueness of this system, besides the modular arms that are able to be in different quadrants, is the fact that also those instruments are relatively small. They're about 5 millimeter. They're surgical signature, and they're very modular. It allows you to do and to perform precise surgery. It's been used for multiple disciplines, not only for GYN. And this robot has been coexisting the intuitive surgical robot for quite some years, and we know that this has been a challenge for them since the first mover advantage of intuitive surgical, which we will talk in a couple of minutes. However, they were still able to perform pretty well with the uniqueness of their system. Transenteric Enhance is another robot that they initially got approved, FDA approved in 2017. However, back in the days, it was relatively unpopular, considering the fact that it was cumbersome. It had only 2 arms compared to the 3 that the intuitive Da Vinci robot had. and limited the articulation and endo-wrist instruments because of the IP patents that were still existing back in the days by Intuitive that prevent them from manufacturing similar instruments. So there was limited popularity. The system was pretty bulk, as we can see, even though that we see that each arm is separate, and there was also some lagging between the movement of the camera. The joysticks were not moving directly the camera, and at that time, Intuitive was superior to this system. There was another system by TransEnterix called SurgiBot that was rejected by the FDA back in 2016 due to the fact that it did not reach the necessary requirements. It was a single port, as you can see. However, it only consists of 2 arms instead of 3. It was pretty bulky, and the FDA did not approve the 510K that approved the other systems, and it was rejected. Then on, it was pursued by TransEnterix to penetrate the Chinese market and has been used over there recently for pediatric procedures, and it's been trying to gain popularity again, but not in the States. Another system that is a relatively new system for the last couple of years is an Israeli company called Momentis Surgical, previously called MEMIC, which is the first robot that received an FDA approval back in March of 2021. It's a transvaginal robot, the transvaginal approach, basically, as you can see, also an open console. The robot is bed mounted, and the approach is through the vagina. You can see over here, this is the surgical theater where the surgeon sits on a console. The console is open, is able to see the field pretty clearly. The approach is through the posterior cul-de-sac, basically, so similar to a V-nose. And there are 2 arms. There are some challenges also with this system, as we can see over here. The articulation of the instruments is superior. There's ability to reach points which were pretty difficult to reach previously with the extreme articulation. However, we only have 2 arms, and the camera comes still from the abdomen, so it does not reach from the vagina. So it raises the questions about the advantage of such a system. And as we know, there are some complex pathologies within the posterior cul-de-sac that might inhibit the use of this system, and hence the uses and the designation for this system for different surgeries is limited, and you are not able to do all type of surgeries. It has a specific designation for different type of procedures in gynecology. So what about the future? This is a character that shows 2 robots sitting in a cafeteria, and the robot tells one of the other, I don't know why I was suspended from doing surgery. I'm not the one who loaded the appendix app rather than the gallbladder app. So yeah, it's funny, thinking that in the future will be replaced by robots. But if you are open-minded to it, this is already happening in a way. The idea is that there will be robots that won't be anymore following the master apprentice pattern that we're seeing today, but rather thinking robots, that the robots will have AI capabilities, machine learning capabilities, as we'll discuss in a couple of minutes. And the surgeon will move to the position, basically like a general of the army, that is basically able to navigate the armies, which will be the robots, basically, and moving from the surgeon who sits on the console at the moment to a position of basically of a decision maker. And you're able to do masses of surgeries and not just one surgery, while you have robots under you that are following the patterns of surgery. So worldwide, we know that surgical procedures have been estimated today about the 62 million procedures every year. And we can see that the majority of the surgeries are still being performed open. not even minimally invasive. And robotic is still in a penetration of 3 to 4% now. The idea is that what we believe that the penetration will go up to 11%. And out of the 18 million cases that are performed currently, we believe that by the end of 2030, there will be about 27 million cases that will be performed robotically, and also other minimally invasive procedures such as diagnostic procedures that are not being included today. In the US, the same pattern, we see that large number of cases are still happening with open fashion, however, a bit different from the world. And we can see that the compound annual growth rate is significantly greater in robotic compared to lap and open, worldwide and in the US. So the robots of the future will be very different from the robots today. And the areas of innovation and the technology are the key things that we need to think about: fundamental design, reducing the footprint, improving ergonomics and haptic feedback, visualization and navigation from preoperative and real-time intraoperative imaging, as well as anatomy demonstration using emerging techniques, digitation of surgery, teaching techniques, computer mentoring, and evolving level of computer automation, which is very provocative, but probably would be one of the leading disruptive technologies out there. And also other long-term opportunities such as implantable devices, soft robots, and regenerative medicines. So this is a type of a robot that was created. This is an article in the Israeli media showing a small robot, cardiac catheter that is able to navigate its way to the heart and find the leaking valve on its own, which is pretty amazing. Worldwide, by segment, we see that surgical procedure will still lead the way throughout the next decade, as well as within the region worldwide, it will grow from about, let's say, 4 billion to 18 billion share market. The companies that will still lead will be Intuitive, but other companies such as Medtronic that we'll talk in a second, and Johnson & Johnson and Stryker, other companies are joining in the effort since they see the potential in this market. So for future robotic platforms, since the IP have expired, we see that Intuitive is going into regenerative medicine with implantables and AI integration. There's their SP with a single site, single port with indication for urology, but intention to expand to other disciplines. With the first mover advantage, having the ecosystem with the support and analytics, with the training and education, with the innovation and integration. The Hugo by Medtronic, which came with the help of the German aerospace system, DLR, to create a modular system as well with different arms that are bed mounted, with instruments that are interchangeable from laparoscopy, which will give them a great penetration market as well, and will make the robot very popular with an open console. It already received the CE approval in October 2021, and in the US it's investigational with the first case of clinical trial in December 2022. And then there's Johnson & Johnson, who started Verb Surgical with Google, with Verily, which is the research, life science research arm of Alphabet, which is Google. However, they retired from this venture back in 2019, and Johnson & Johnson is now fully taking over this project with the XXXVI International, which is the Stanford Research Institute, to democratize this type of surgery and make it worldwide available for all patients. Also open consult, as we can see from the PI, modular as well, modular arms, and fully articulated. And the future idea is that we'll be able to talk with patients and physicians all over the world and mentor each other and connect with each other, and everything will be interchangeable. As we can see, the robot is very precise, as we will see from this quick video, and there's no way to go back. This is the future, this is the way, and that's what we're following through. And the robot, basically, after teaching the robot what to do, the robot follows with more precision, faster position. And the market is supposed to grow in the next decade, as I mentioned, from about 4 billion to about 18 billion, with penetration from 2% to 11% worldwide, with different platforms from different companies introduced all over the world, with different capabilities, AI and machine learning. And this is
the way of the
Okay. Oh, cool.
I thank you all.
My dear Professor Sirota, you have fantastic presentation, very impressive, especially last part of Hugo and Johnson with Google and the alphabet. Please advise. We are aware each other, and I personally invited you several times. Could you please explain your experience of robotic surgery? Do you do robotic surgery yourself? That's first question. And then, well, uterine robot. Yes, I already heard about it, but maybe you didn't show, or maybe I missed it how this type of robot is working. So I give you these two questions within 1 minute. Thank you.
Yes, so I perform most of my cases robotically. I adopted the robotic technology years ago, believing that this is the way of the future. I still perform some laparoscopy, but I do believe that you cannot stop technology, and this is how things are being done. This is similar to the discussion back in the 80s when laparoscopy was compared to laparotomy, and nobody believed that there would be adoption of this technology. However, we see clear adoption of this technology, and I think as prices will decrease and the technology will be cheaper, there will be less thinking and less questioning about whether to use this technology, especially with the advanced technological software capabilities such as AI and machine learning that are adjacent to this type of surgery. So yeah, I think this is the way.
Очень приятно,
I'm very pleased to get your answer, but a robot would never replace the human, although it's called intuitive, but still, this intuitive, its intuition is again limited intuitiveness, but maybe you believe because you are young and probably one day it would be a real intuition. And well, I think artificial intelligence still should serve human intelligence. That's my approach. That's my understanding. I cannot imagine that would be complete autopiloting without real pilot, like in a jet. What do you think? What do you think?
I think that, as I mentioned throughout the presentation, and from working with different companies in the field as a consultant, I see that we still need the human mind and the surgeon that is operating. We need to develop this technology. However, we are able to create things that are unmanageable, that were unmanageable about 20 or 30 years ago. And this is a reality, all around the world. Who thought that you'll be able to send a rocket back into the space, that you'll be able to go back and land straight back without having to get rid of it? There are many developments in technologies. I don't believe that it will replace the surgeon completely. As I mentioned, the surgeon from the position as we are today of the operator will move to the position of the decision maker. And you will basically, as a general, you will conclude and you will master those thinking robots that will be basically in the position of the operator. And you will have the opportunity to interject if you need. Same as with pilots today, that basically pilots are there in the cockpit. However, today there's no need for a pilot to be there. The airplane autonomic system is able to take off, landing and fly throughout. And there are some studies that show that they do it better than the humans. However, we as humans, we have the problem of giving up the control. And I think similar will happen also with surgery. And I think it's a gradual process. It won't happen overnight, but there are things to look forward to.
Dear Edo, you are accepted to our very strong international big team. You are a member now, and please always wait our invitations at least twice a year. At least twice a year. We traditionally carry out 2 congresses in January and in June. So thank you very much for connection. Thank you very much for brilliant presentation, and thank you very much for being with us. Congratulations with the membership. I was eagerly waiting for your presentation. Thank you very much, and we wish you a very good day. Dear colleagues, and today we will have wonderful person, surgeon with us, from Spain, and this is Dr. Juan Jalapel Esteras. We will speak about the anatomical landmarks in the obliterating small pelvis from normal to deviated anatomy. As the lead of the endoscopy department and the Department of Oncogynecology, and this is University Hospital General Universitario, Valencia, Spain. My dear Jalbert, microphone is yours. Please start your presentation.
Thank you very much. It's really a pleasure to be with you. I would love to be there in Moscow with you. We expect that next year we can go there. So thank you for the invitation in this great Congress. I'm going to share my screen. And I'm just want to check that you're seeing well my presentation. Can you see it?
Perfect. We can see, we can hear full screen. Yes, I confirm. It's all right. Please start.
Perfect. Okay, so I'm going to try to do a very practical presentation. I have nothing to disclose, and I come here to this meeting representation of my team in Hospital General of Valencia. We're going to try to talk about a very frequent situation, which is the frozen pelvis, is where the pelvis has a distortion of the intraperitoneal anatomy with involvement of the pelvic organs, and this reduces the mobility and exposure. And it is a very challenging situation in the life of a surgeon. So we will try to move from normal to distorted anatomy. And it is very important that when we deal with this difficult situation, we are able to understand the anatomical landmarks. So it is as if you were seeing from a window, say in the Central Park in New York, and then you focus to different areas of this park in order to be able to understand the whole problem. So we will speak and we will try to use some videos to first understand which are the doors for entrance in the different areas of the normal pelvic space, and then try to move to distorted anatomy. So we are also using the ICG technology in order to enhance different structures such as the ureters, the vagina, or the bladder, and this is going to help us during our dissection. We have to understand that in gynecology, usually we stay in the central part of the pelvis. It is important to know that the more lateral we go, the more chances of injuring different structures we will have. If we're staying close to the midline and we go lateral, first we will have some problems with anatomical structures such as the autonomic nerves or the ureter. And then if we move more lateral, we will find problems with the pelvic vessels and also the somatic nerves. So it is important that we understand where these structures are located, and there we will be able to understand what happens in pathological situations. So the idea is if we find a situation like this with a frozen pelvis, we will have to think that we have below the peritoneum several structures, and we should do exposure maneuvers in order to prevent injuring these anatomical structures. So we are trying to move from a frozen pelvis, as if we were seeing this landscape, to a normal pelvis, but we have to follow several rules to perform this. You know, this is a nice picture where we can see that there are many spaces. So we gynecologists are lucky that you women have a central organ, which is the vagina, the cervix, and the uterus, that defines different central spaces and different lateral spaces. So there are a lot of names, but generally speaking, we will have several spaces which are lateral to the bladder, several spaces which are lateral to the rectum. And then we'll have some medial spaces, and with laparoscopy, we're able to travel and to find the doors of entrance in each of these spaces. So we will start by the medial pararectal space, which is the so-called Kobayashi space, which is located medial to the ureter and lateral to the rectum. This is a space usually found, for instance, this is a video of a radical hysterectomy of the right Kobayashi space. So we keep lateral the ureter, we keep medial the rectum, and in this space, it is very important to understand that we have the right hypogastric nerve, which is going to cross the space. So see here, if we have any problem affecting the lateral aspect of the pelvis, the first structure which is going to find is the right hypogastric nerve, which has sympathetic innervation. Then we will move a little bit more lateral to the lateral pararectal space, which is the so-called LATSCO space. This is a space which is very interesting for gynecologists because we can find here the uterine artery. So here you can see this pararectal space, which has a triangle defined by the uterine artery right here. Medial, you can find the ureter, and lateral, you're going to find the umbilical artery. So this is the right LATSCO space, and we can find at the very bottom of this space the pelvic splanchnic nerves that might also be affected. We are moving towards the paravesical spaces, and here we have the medial paravesical space, which is medial to the umbilical artery. It's a space which is also very interesting. You can see here the robotic dissection. We're still working in the lateral pararectal space here, and here we are developing also the medial pararectal space. We are using the ICG here to define the parametrium, the paracervix, and we can move from one space to another space, keeping in mind that we have the uterine artery that crosses it in the middle. Then we're moving a little bit more lateral, and the lateral paravesical space is very interesting when working with distorted anatomy because we are going to find here is the left dissection of the lateral paravesical space. We see here the left external iliac vessels, and we're going to find this structure, which is the umbilical artery, that we can also see it from the peritoneal fold, and it is going to give us a lot of information and a lot of capacity of dissection. It is also important to understand that there are some lateral spaces that are going to be useful overall when we're working in oncology. Here we have some ICG in the bladder. This is the right bladder pillar or pubovaginal ligament. And then we can find here the right Yabuki space where the ureter is going to arrive to the bladder. It is interesting that we preserve and we dissect this space if we are working in oncological cases in order to preserve both the ureter and the nerves that are coming to the bladder, both sympathetic and parasympathetic. Talking about medial spaces, and we have to understand that rectovaginal space is one of the spaces that we have to know how to dissect. Here we have some ICG in the vagina, so it is important to perform a posterior traction of the rectum, and then by keeping the uterus anteverted, we are going to be able to open this avascular space, and we can develop this space up to the bottom of the pelvis, up to the pelvic floor or the levator animuscle plate. And this is a space which is absolutely essential if you're working with endometriosis. Then we have also a retrorectal space, which is between the sacrum and the rectum. Here we dissect and do the dissection of this space, so we keep the rectum above, and then we keep the sacrum and the sacral fascia below, because we're doing an economical resection in this case of an endometriotic case. So this is a space that is going to be developed overall in cases of endometriosis and ovarian cancer. So let's see how we have several steps in order to be able to come from this situation where we have the frozen pelvis to this situation where we are unfreezing the pelvis. We're trying to restore the anatomy in case of endometriosis or be radicals in case of ovarian cancer. One of the main rules, and we've learned in that from the team of Professor Novatiés, is that we have to understand that we have to come from normal to distorted anatomy. So we have to start from healthy tissue to pathological tissue and from lateral to medial in the pelvis. So there will be many situations where we can find frozen pelvis. So these are, for instance, several examples. It's not yet just endometriosis, also ovarian cancer, but also infection or the presence of fibroids, or also the presence of adenomyosis. But in all of these cases, we might follow several rules that will help us. And you have to keep in mind that when you're dealing with frozen pelvis, you might have some problems, and you have to be able to solve these problems. So you might injure the vessels, injure the rectum, also the bladder, or even the nerves. So you have to know about anatomy if you're dealing with this situation in order to preserve the function of these structures. It is important to understand that endometriosis is the most challenging situation in the gynecological surgery because there's an extraperitoneal involvement. The other situations, even in ovarian cancer, usually we have intraperitoneal involvement with no infiltration below the surface of the peritoneum, so we can perform procedures safer in terms of the dissection of the retroperitoneum. But endometriosis distorts this anatomy, and it is very important to understand that even if it's similar when you see some ovarian cancer implants or some endometriosis implants, these implants of endometriosis are infiltrating below the peritoneum. So two cases, videos, they seem similar, but you can excise all the ovarian cancer by doing on-block dissection. We will see some examples, but for the problems, the peritoneal implants and the deep infiltrating endometriotic implants, you have to work below the peritoneum. This is a case of endometriosis, so we will have some disease inside and some disease which is outside. So it is very interesting that we identify these cases which are more difficult to deal with and to have a very interesting and very good preoperative workup. Similar case, ovarian cancer, we have also some involvement, but usually this involvement, when you enter and you open the retroperitoneum, you are able to do an unblock dissection and nucleation of the problem. So we'll try to do like this, coming from complex and go for simpler and follow some rules in order to deal with this situation. You've seen yesterday the interesting lecture from Alessandra Di Giovanni that taught us how we can identify those deep infiltrating nodules of endometriosis, those nodules that sometimes they have this type of shape that infiltrates very much in the rectum or in the parametrium, and we also have to check for the ureters, and this ultrasound workup is essential if you're dealing with deep endometriosis cases, and also use some signs such as the sliding sign to understand if we are going to find a frozen pelvis or we're going to find a free pelvis. As I told you, when we're working with ovarian cancer, usually it's easier. In the pelvis, we say that any problem below the umbilicus in terms of resection is possible to resect. So usually the irresectable cases of ovarian cancers are due to locations which are in the upper abdomen. We can do this Hudson technique where we open the peritoneum, we cover all the peritoneum over the disease, and we work doing an extraperitoneal hysterectomy and extraperitoneal resection of the retrorectal space and an unblock enucleation. So that works for the ovarian cancer, but it doesn't work from the endometriosis. So for endometriosis, as I told you, we have to follow several rules. The main rules is that we have to first work from healthy tissue to pathological tissue. Try to free the pelvis and then work in the intraperitoneal and the retroperitoneal space. So, for instance, you see this case. It is interesting that when we start, it's an easy case, but we see here that we have some exposure maneuvers. First of all, we have put some IgG in the ureters. Then we have a good vision, and then we have the uterine mobilization, which is essential. See, for instance, in this video, how the anatomy changes. This, up here, we have the uterine artery, and see how close it goes to the ureter when we have a bad manipulation and how far it goes from the ureter when we have a good manipulation. So it is essential that we can move the uterus and we can move the rectum if necessary. First, we have to start to free the adhesions and see how different are the adhesions from the small bowel and from the colon. From the small bowel, we want to use cold scissors, not energy, because the small bowel is very thin, and we might have some problems. And for the rectum, as we have some fat sometimes, so for the omentum, we can use sealing devices, and we can work with more safer using the electricity. Another exposure maneuver, the second step, would be try to free the ovaries, try to do adhesiolysis. It is interesting if you can work with some ICG, because sometimes you have the ovarium which is attached to the posterior leaf of the broad ligament, and it is very close to the ureter. So be aware that you have to free the ovaries. You can do this type of maneuvers, free the ovaries outside, pull them outside using a T-leaf or a suture, and then you are able to free the hand of your assistant and work directly to the problem of the retroperitoneum. let's move upwards. As I told you, from lateral to medial, from healthy to distorted or pathological disease. See here that we go up cranial as much as needed. So here we have the disease that is blocking the pelvis. We go up, we identify here the left external iliac artery, we identify here the left infundibulopelvic ligament, and we try to work in this medial pararectal fossa, trying to find the ureter here, and then we work downwards. So here I'm working in healthy tissue, and I'm moving from lateral to distorted anatomy, and you see that I'm able to do that without even using coagulation. See here the same case. Now we have the ureter here. We can use this ICG, and then we work in the pararectal fossa, which is the area where we can free also the hypogastric nerve and try to go from one side to another side and try to free everything in order to focus on the disease. See here how we dissect the medial pararectal fossa. This is a case of endometriosis. And see here that we are trying to free the ureter. This is a little bit dilated in this case. But when we free the ureter, we are trying to preserve this structure. And then we go one more caudal and try to preserve here the left hypogastric nerve, which is also trapped by the disease. And then finally, we move to the disease, which is sited here in the medial aspect of the pelvis and affecting a little bit in the lateral medial aspect of the pararectal fossa. This is another case. For instance, medial pararectal, you see the ICG, you see how we use the assistant. We have freed the ovary. We are pulling the ovary upwards with the tele for the suture, and then my assistant can pull the leaf of the pro ligament, and then I am able to use both my hands in order to dissect this pararectal fossa and identify the hypogastric nerve. Here the same case in the right pararectal fossa. We can do this type of maneuver for the hypogastric nerve. Try not to pull it very hard, try not to harm the nerve, not because you're going to perform a neuropraxia, you're pulling the nerve. So try to do indirect maneuvers of mobilization. Then when you have fret laterally, then you focus in the disease. Two cases. First, here, up here, we're focusing in the adenomyosis after doing the dissection. And here we are focusing in the left parametrial deep infiltrating nodule, which is over the left ureter. And here we have freed the ureter and we have removed the nodule. Remember, the disease sometimes go more lateral, and this is a case where we have an involvement of the right sciatic nerve and the right pudendal nerve. So we are working very, very lateral in the pelvis. And we also have to know that the more lateral we go, the more chances we have to have some problems in the somatic nerves and also in the pelvic vessels. So we have to know if we are dealing with these cases also of this type of anatomy. And yes, finally, important, if you are dealing with frozen pelvis, check for complications. We have a lot of tools to check complications. We have different modes for seeing the ICG. We can check the bladder. We can check the rectum during a rectoscopy using methylene blue or using the test of air inside the rectum with serum inside the pelvis. So we can check the complications, and we have to convert a possible complication into an event and solve it directly intraoperatively. Last slide, just to tell you that it's like the lights of the street. We have some red lights. We have to know the anatomy. We have to come from medial to from lateral to medial. We have to do exposure maneuvers. We have different tools, so be free to use technology, free the ovaries, identify the structures, and then go for treating the disease and finally checking the complications. I will just finish my presentation by saying that simple can be harder than complex, but we have to work hard to get your thinking clean to make it simple. We will organize the winners meeting next week in Valencia. I would like to also invite you. And finally, the last picture is from a nice place that we share, Leila and her family with me in Moraira, near to Valencia, which is a paradise. So I hope, Leila, to see you very soon there. And I hope the best to all of you. Spasiba. Thank you very much.
Thank you very much. Fantastic, elegant, beautiful, artistic performance by Maestro Juan. Thank you very much for being with us, and I'm extremely happy that you are a member of our very big professional team. Thank you very much, and hope seeing you again. Today we cannot ask any questions because it was crystal clear and beautiful, and I extremely liked that quotation of Steve Jobs. So if you want to make it simple, you should think clear and work hard. Then it would be simple. Thank you very much. We wish you a very good day and goodbye. Well, dear colleagues, with that, we finish day 2 of the Congress. Here you can appreciate that we completed our agenda for today and almost without big delay. There is nothing to discuss because there were very many discussions and we asked questions after the presentation. So let me announce day 3. We meet here exactly at 8 and we start international course on laparoscopy and hysteroscopy. Tomorrow, we have live broadcast, and that would be Arnaud Battiès. Also, we will have surgery on the dissection of the uterus scar and the niches. Also, we will show very different videos, very useful videos, and after 9 o'clock, we expect another live surgery, and tomorrow we have very big session on oncology and oncogynecology. With that, I would like to thank you for your trust. So today, more than 3,500 professionals connected to us. It's a big trust, and we are very grateful for your attention, and we are very grateful to our fantastic speakers and lecturers. Hope seeing you tomorrow. Take care. I wish you a very good evening and goodbye. See you tomorrow, 8 a.m. here. Thank you.